गणपति गाइए गणपति जगवंदन शंकर सुवन भवानी नंदन गाइए गणपति बुद्धि सदन गजवदन विनायक सिद्धि सदन गजवदन विनायक कृपा सिंधु सुंदर सबकाय कृपा सिंधु सुंदर सबकाय गाइए गणपति मोदक प्रिय मृदु मंगलदाता मोदक प्रिय मृदु मंगलदाता विद्यावारिधि बुद्धि विदाता विद्यावारिधि बुद्धि विदाता गाइए गणपति मागध तुलसीदास कराचोरे मागध तुलसीदास कराचोरे बस ही राम सिय मानस मोरे बस ही राम सिय मानस मोरे गाइए गणपति जगवंदन शंकर सुवन भवानी नंदन गाइए गणपति. Thank you.
We will now begin. I call upon stage Dr. Aravind Jagadish, Chairman and Chief Diabetologist, Aravind Diabetes Center, Basveshwar Nagar, Bangalore, to welcome the ceremony.
So good morning everybody. At the outset, on behalf of Dr. Aravind Diabetes Center, Basveshwar Nagar, Bangalore, I welcome all of you to this scientific academic conference. So every year we are doing this conference. In the past 8 years we are doing this. Last 3 years, because of the COVID, we did online, that is virtual, where many international speakers were also part of it. This year once again we have started it physically. So the main aim of our conference is the audience interaction. Audience interaction is the main role. In the sense, the speakers here, they'll present their data, what they have got according to their topics allocated. After that, we keep interaction as well. So each talk will be of 20 minutes duration, and 16 to 70 minutes will be the presentation by the speakers, and 3 minutes we'll have an interaction. If you have any further questions or anything like that, you can always interact with the faculties. They'll be around over a coffee. You can discuss with them. So kindly make use of this academic event. If anything, any discomfort you're having or any doubts you're having, always feel free to ask us, and make it as a good learning experience in this conference. So hope you all enjoy this academic extravaganza. Thank you.
Thank you, sir. Well, let's begin the program. So the opening batsmen, I would rather say batswomen. You know what I mean, right? So we all know ladies first, right? You can see here, the anchor is also women. The two girls who sang are also women. Just like that, let's follow, because we all respect women a lot, isn't it? So let's follow this ladies first rule. And now we have the chairperson, Dr. Lalita R., diabetologist, Karnataka Institute of Endocrinology and Research, Department of Medical Education, Government of Karnataka, Bengaluru, and the other chairperson, Dr. Sri Lakshmi, Senior Diabetician, Bengaluru. Over to you, madam, for the further proceedings.
Good morning, everybody. Welcome to this wonderful feast of knowledge today. So our first topic for diabetes today, diet, because all patients come and ask us what is the best diet for diabetes. So I think it's an apt way to open the session. So I call upon Mrs. Nayantara. She's a dietitian at Dr. Arvind's Diabetic Center. Madam, please come over and take over.
A very good morning to one and all. First of all, thank you, Dr. Arvind. Thank you, Dr. Sri Lakshmi, and thank you, Dr. Lalita. Even before I begin about diet as such, I hope all of you have had breakfast.
Hello, Naina. I'll just introduce you.
Hope all of you have had breakfast. Yes? Okay, because that's the first duty which we generally do, right? Okay. The topic is diabetes war with diet. So which diet will you follow? So what do you need for starting a war? You need a weapon, right? So we have many weapons in hand. A lot of medical people are here who will tell me more about the drugs, right? So when we say weapon, which weapon do you want? That is the key word. So why do you want a weapon? We need the weapon to fight against diabetes. And where did this war actually start? And how do we take it forward from here? And which is the weapon that is most suitable for this war, right? So why in India? Basically, we know that India is the epicenter for diabetes. Most of us know that we are just next to US, but we contribute only 1% to the diabetes research. So we need to make sure that we know where it has started. We all know that it has started in Singapore, where Singapore has started this global war of diabetes, basically to know that 537 million people who are affected by this metabolic disorder, and we know that by 2045, more than 784 million people will be affected. So what is the state of diabetes as such? In India, it has continuously been increasing, and currently 25.2 million adults have IGT also. And India, when we see as a whole, this was a study which was done by ICMR in 2017, which was done in 2 phases, which shows that we are almost, each state has more than 10% of diabetes, which is prevalent in India. So which weapon, as a dietitian, I would say diet first, but drug is also essential, exercise and lifestyle. Dr. Sri Lakshmi was, when I was discussing with her about diabetes as such, she had also told me that this has to be a lifestyle change when we know it is a metabolic disorder. This has also gradually increased because of COVID. Because of COVID, we've had a lot of clients who come in to tell us that my sugar levels have increased. For that, we are, as an individual, we have to give them the proper diet. So leading cause of this diabetes, anybody? I'm trying to make it interactive. Okay. So let me just get to the diabetes as such. How do we tackle the situation? We tackle the situation with etiology and precision medicine along with diet, and we make sure that we implement this. When I say implementation, there shouldn't be a gap between research and where we are providing the diet also, because to the provider as well as the person who is getting the benefit from it has to be known. And health policies. Of course, we can't leave our government without any work on diabetes. Of course, we have to ask them for health policies which will help us to fight against the diet as such. Already in India we've seen that a lot of farming practices have been introduced in terms of millets which are being grown, which are more of complex carbohydrates as such. And pharma is also introducing, I think one of the doctors had also said there are some patches which are available. So we should make sure that it is available even to the lower socio-economic group. So big food, of course, when I say big food, we have to make sure that we are educating them regarding food labeling also, because most of the foods that are available are low sugar and with artificial sweeteners as such. So when I say etiology, every time when a person comes for a diet as such, we take their diet recall. So I've always had a conflict even in with doctor, where you don't need to talk for a long time regarding diet. But until and unless I counsel a patient to know about their fat distribution, how they have followed their diet and what are the changes that they have done, it will be very difficult for us to prescribe a diet for them. So the health policies have already been there in the market, like ICDS and MDRF, which introduces a lot of studies as well as favorable conditions with respect to health policies as such. So diabetes is an organized care. So more such conferences will help us to not only create awareness, to implement it in the right way. So medicine has given us types of diabetes. We all know how many types of diabetes do we know? I've listed here type 1, type 2, Modi and LADA. have not listed GDM, of course. But how many types of diet is available? Anyone? Okay, type 1 diabetes, let me just speak about type 1. This is for children. And type 2 diabetes, which is nothing but the actual diabetes where glucose needs to be monitored in the individual. Modi, there are a lot of studies which are documented. This is due to the genetic variant which is of concern of late because of COVID. LADA, this is another one. This is a late adult onset autoimmune diabetes, which is not very rare, but it is seen that different phenotypes have LADA. So when I say diet, sir says diet, diet, diet. I cannot follow it. But a patient says, did I eat that I developed diabetes? So it is basically the pancreas is not secreting the insulin properly, or it is not functioning, right? And normally if it is secreting properly, this is just a small picture for understanding what diabetes is for a lay person. So as diabetes is creating an awareness about glucose metabolism, even medical nutrition therapy has been introduced, wherein the percentage of macronutrient distribution is being studied. So if we try to be very rigid with it, it will be very difficult for us to manage the diabetes or manage the control, because food is the first thing which everybody talks about when we want them to reach a certain goal to maintain the sugar levels. So first recorded treatment was by John Rollo in 1797, where the diet started. The diet started in terms of meat-based diet, wherein it helped the people to control the sugar levels. But as we went further, the total dietary restrictions, a strict diet schedule was introduced. So diabetes is nothing but it's a condition where glucose, which is ingested in our body, is not utilized properly. But when it comes to dietary perspective, we see all the three macronutrients. That is your raised blood glucose level, and there is an alteration in protein and fat metabolism also. So there are lots of diet, as I mentioned. There could be a bullet diet, there could be just a GM diet, a General Motors diet. Is there anybody who's followed any of these diets? Okay, I guess it doesn't sound interesting. Fat diet is not a diet which can be followed by everybody. This is not a scientific terminology, and it is just a trend where diet is used to fix the obesity. So studies have revealed, Seldman et al. Has showed there is a U-shaped curve wherein increased amount of carbohydrates would cause increased mortality, decreased amount of carbohydrates would also cause mortality. So the risk of dying is lowest when you have your carbohydrate intake between 50 to 55%. So make sure that you match the right diet for the right patient. So diets have been come with, as I already earlier mentioned, 90% of it is a meat-based diet. That is how we saw that it helped glucose monitoring also, where there is no glucose from your carbohydrate. But even meat also does give small amount of carbohydrate but high amount of fat depending on how it is cooked. So including starchy foods in your diet will increase your glucose level. So around 80% of their diet was animal fat and 20% was protein. But anytime when you know it is a fat, how will you check? This is the best example to see if there is any food group that is missing, the diet is going to be fat. If it is not nutritionally adequate, if it does not give the necessary nutrients, and it can cause further complication. So make sure that if you cannot maintain your diet with your with the diet which has been you have heard because it is in trend. So diet. Make sure that Mr. Venkatraman has told that we are winning the battle, but we are losing the war. Why? Because we are not attending towards how we need to prevent it even when they come just before pre-diabetes also. And a lot of global research has to be done. It's not with respect to only higher socio-income group. There is a mismatch. So this is what I would like to say. We have to make sure that diet is given utmost importance as soon as any patient comes in. So Atkins diet, this is just a brief history which I have given. Atkins diet was started in 1970s, and again this got modified into many other diets. When there was a random study which was done with 43% who had metabolic syndrome and 39% had type 2 diabetes. Low carbohydrate diet, actually this is the Atkins diet, low carbohydrate and high fat, they lost 3.8 kgs of weight. But there is a complication that can arise if it is not supervised by health professional. There was a case wherein 40-year-old obese woman was reported to have presented with nausea, vomiting, dehydration, and even dyspnea. So even though she lost 9 kgs in a month, she developed ketoacidosis. So keto diet started just in 1923 by Dr. Russell Wilder. This was actually a diet which was started for epileptic patient. Even though they lost 10 to 15% of body weight, which is actually beneficial for your HbA1c to be in control, what happened was, even though there was a reduction in inflammatory markers, WBCs, there was an increased triglycerides and LDL. And safety of this and sustainability is what is questioned. So make sure that you're not following any keto diet. What is the consequence? The consequence is lethargy, and their bone, their mineral density is also reduced. And there was a study where subjects got kidney stones and 8.8% of them had fracture due to following of keto diet. Paleo diet, I think this is the favorite diet of all, because there are a lot of studies which is being made as it is helpful. This is a Stone Age diet. Even though it was started by Etten and Connor, it was published only now, that is in 2010. So this is suiting the genetic makeup of current modern diet. When I say paleo diet, any questions? It is a Stone Age diet. So we do know this is connected somewhere even to our Ayurveda also. Dr. Sri Lakshmi will be able to put in a little word on that also, because she has done a lot of studies as to how Rajasic diet, Tamasic diet and Sattvic diet will help the diabetic individuals. There were no significant changes in blood glucose in most of the studies, but short-term HbA1c was not measured. What we even saw that was, even though there was an reduction in total cholesterol and the triglycerides, their arterial pressure also was observed, which all helped the individual. Is it beneficial or not? I would say it is very much debatable, because according to Diabetes Association, even though there is a reduction in HDL, there is we need to make sure that there is a connection with the individual. If the person has been following age-old diet and they want to continue with it, we make sure that we focus on the literature and present it to the layman in the right way. It had a preventive effect in terms of controlling the IBD also. Indians, I think this is one thing which all of us have to understand. 50% of carbohydrate, that too in the form of complex carbohydrates, whole grains, brown rice and whole wheat. 20 to 25% of protein, preferably from a vegetable source. Again, non-veg source, why I will explain, because it has more fat content also, and it again involves the cooking method that is being used. And remaining 25 to 30% has to be from your fats. And even though this is the most sustainable one which we can follow in a long term, and it is very less risky also. If is the talk of the town now. All of us are talking about intermittent fasting. So there are a few guidelines, not many guidelines. As I earlier said, there is no connection. The connection is what is important. Intermittent fasting may have effects on cardiovascular events also. So these are the studies. I'll just quickly go through, because my time is also up. So these are a few studies which I can share it later. So don't fade your health with a fat diet. And there was a discussion in paper which shows reducing carbohydrates slightly can help you to remit your diabetes as such, which was again discussed on, this is a LinkedIn profile which I just took up. Companies are marketing insulin. Mr. Viraj has told that how healthy lifestyle is also important along with physical activity. So what's our diet culture? So that is what we need to make sure. Are we following the diet which is designed specifically for us, or are we just going to ape the West and try to follow nutrition programs which will give us result in a short-term basis? So any other queries? You can come up with questions.
Any questions from the audience?
Sir, I think all of them are intermittent fasting they are following.
What will be the role of intermittent fasting in diabetes? Because see, many of the times you advise the tablets, like we tell the patients to take the tablets morning and evening, night. So if they are doing the dieting, intermittent fasting, so if they finish the dinner at 6 o'clock, from 6 o'clock to early morning, next day morning, 9 o'clock, they don't eat anything.
Exactly.
How do you manage this, because to avoid hypoglycemia?
Yeah, first of all, we need to ask them their eating habits and then suggest them. And we need, as you said, you are giving your drugs. They have to inform both the medical practitioner doctor as well as us regarding that, so that there is a coordination among us to inform them about it also. There are conditions, even they can go into hypoglycemia. If they are not informing us and doing it, they can go into hypoglycemia. There are even that has been modified. In intermittent fasting, there is a 12-hour window, which we are already doing. 12-hour window, 16-hour window, and every time when we sleep and we get up, there is a 12-hour gap. We are breaking the fast. So that is how we have to make sure that we ask the patient and then provide the diet, even if they are following it, so that they will be able to remit it. If they have further complications, if they have other disorders like kidney problems and all that, then we have to take care that we ask them to follow what they have been following earlier and then manage their diet.
Good morning, everyone, the distinguished delegates. And Ms. Naina has covered in detail all the different types of diets and how to go against the diabetes by using different weapons. I would say, like, at the individual level, the person has to accept the disease or disorder, and then she has to fight for her life. In the sense, like, she has to accept the diabetes, and then she should have mental willpower. Like, I have to come out from this. That will be a big weapon towards taking care of the diabetes. At the family level, all the family members, they need to accept the disorder of that particular person and help her out to come out. At the community level, like government and public health institutes and all, they have to design the programs in such a way, like at the workplace, or they have to be conducting conferences, seminars, and also a health audit should be done. And at the same time, even the urban developers and all, they should give provision for having the walking areas, safe walking areas, and also medical facilities, and providing the canteens. Canteens also, customized canteens, etc. Okay, so all of us have to come together to go against war against the diabetes. Thank you.
Thank you all for the patient hearing. And if there are any queries, please, I'm here around. You can please come and meet me also. Thank you. Thank you, doctor.
Thank you, ma'am. The session was very informative. I call upon the chairperson and Mrs. Asha Aravind to come on the stage and felicitate the speaker. May we all give them a huge round of applause, please. Let's encourage them. Come on. Thank you, ma'am. I now request Mrs. Asha Aravind to present the memento to the chairperson. Thank you, madam. For the next session, we have Dr. Kirti Shetty, diabetologist, Livewell Diabetes and Heart Center, Bengaluru, and our other chairperson is Dr. Diti Thakur. Thank you, sir. Thank you, ma'am. Moving on to our next session, we have Dr. Kirti Shetty, diabetologist, Live Well Diabetes and Heart Center, Bengaluru, and our other chairperson is Dr. Didi Thakur. Let's welcome them with a huge round of applause, please. Over to you, sir, for the further proceedings.
Good morning, everyone. Second topic of the day is benefits of early use of interchangeable glargine in type 2 diabetes patients who are uncontrolled on OHS. And I would like to introduce Dr. Anantharaman R., consultant endocrinologist at Megan Centers of Diabetes and Endocrinology. And he has pursued his MD medicine from prestigious PGA JIPMA, Pondicherry, and he was also a gold medalist, and he has pursued his DM endocrinology from JIPMA as well. And he has got several international and national publications. And he would like to enlighten us about early use of interchangeable glargine in uncontrolled diabetic patients. Over to you, Dr. Anantharaman.
So I'll start by thanking Aravind, the one-man army, who has organized today's excellent gathering. So we'll talk about another, soldier of diabetes, that is glargine insulin. So we have different soldiers now. We have not only one soldier. We have the commando and other, who are like CRPF. Is the CRPF same as the army? So let us see. So this is where we talk about the interchangeable glargine, translating evidence into clinical benefit. So insulin provides a great sense of well-being, if you are a diabetes care provider. So, when all else fails, we turn to insulin. And, that has been the mainstay of our treatment. So, though, we can talk about diet, exercise, medication. There are a group of patients. You all know that there are 4 or 5 phenotypes of diabetes. So some people's diabetes is milder, and some people's diabetes is more severe. They have more of insulin deficiency. They progress faster also. So we see that in clinical practice. There is a lot of heterogeneity. We do have patients who lose beta cell function very fast despite trying their level best in terms of diet and exercise, and also adherence to medication. They come to you regularly. Despite that, their beta cell dysfunction progresses. So progressive beta cell function is the norm in a small subgroup of our patients with diabetes, and insulin will be required. And oral therapy alters the decline in beta cell function. And also poor glycemic control has always been a driver for diabetes complication. And early insulin therapy, or rather than keep insulin for late, so there's a concept that when you actually failing 2 oral antidiabetic drugs, so if 2 oral antidiabetic drugs are there and if there is a requirement for a third one, that is the best time to think of starting an injectable therapy like insulin. Especially when you see that a person has deteriorated beta cell function rapidly, definitely we should think of adding insulin early. So why are we focusing so much on HbA1c control? You will hear in the rest of this conference a lot about SGLT2 inhibitors, DPP4 inhibitors, and reduction of cardiovascular mortality by using these agents, basically. So that's the latest trend in diabetes care, where we don't talk much about HbA1c, but we talk about endpoint reduction. But does HbA1c reduction also provide benefits? Yes, it does. So if you look at the UKPDS follow-up, so that is the only study where you actually start treating patients early. And what therapies were used in UKPDS? We used sulfonylurea, we used metformin and insulin in early intensive arm. So when you intensively treat patients early on using a basal insulin or insulin in general, so you actually provide the benefit of mortality reduction. But the same mortality reduction does not occur if you start treating the patient later on in their diabetes. See, if you allow the patient to have poor control for several years, say 5, 6, 10 years, you say we'll see later, we see later, and already they start developing some complications like retinopathy, nephropathy, and then you say, oh, now I need to control your complication. It doesn't really work. So that's what this slide says. This slide says that if you actually start treating patients aggressively early on, so you are likely to reduce mortality in the long run. But if you wait for damage to accumulate in the body through prolonged hyperglycemia, you will not give that patient the benefit of reduced mortality. Another important aspect is affordability of insulin. So when we talk about insulinization, the low and middle income country insulin volume, 19 countries with the 3 largest companies, 95% share. The 3 largest companies have got a global share of 97% of the world's insulin. So it's more or less a triopoly. You know what the companies are. I'll not talk about the company names. But, there is a triopoly of insulin therapy all over the world. So there are 11 countries where other countries have other nations have a, significant share. In India, India is one of the countries where the share is only 72%. But there are some very large countries where almost all the insulin that is available is actually from only 3 companies. So this can cause an increase in prices. So whenever there is a less competition in any market, the prices will increase and access to diabetes care reduces. So tens of thousands of people with type 1 diabetes who need insulin to survive, and more than 30 million with type 2 diabetes who require insulin do not have access to a reliable and affordable supply. 86% of people with type 2 diabetes are unable to access the insulin they need. So when you look at, this is data from the USA. So US dollar, per month what is required. So from 2006 onwards, the price of insulin has been steadily increasing. Okay. So even in our country, the price of insulin has increased over the last 10 years. But the increase has not been so steep because we don't have a triopoly. We do have, multiple players, providing insulin. So this may not appear very, a compelling reason for you to use an alternative insulin, but the presence of alternative insulin or a biosimilar insulin to a significant extent in our market is what keeps the price of insulin down. If the alternative insulin is not available, the prices of insulin will be double what it is right now of all the insulins. So that is one of the important, aspects that we need to understand. So let us look at the evidence. So we have talked about, the economic aspects, or the market aspects of why an interchangeable insulin or a biosimilar insulin is required. So what is the difference between switching and interchangeability? Okay. So in the US regulation, the Food and Drug Administration decides, gives license to various molecules on how it should be used. Okay. So switching refers to what we do as doctors or healthcare professional. A diabetes nurse or any diabetes care provider or a doctor can actually change one insulin to the other. They can tell, you can take either the glargine of Sanofi or you can take the glargine of the Eli Lilly. So that is called switching by the HCP. Interchangeability is something that the pharmacist can do. So the pharmacist sees that this insulin is prescribed by the doctor, but this is very expensive for the patient. So, and I have this less expensive insulin in my formulary, I can use this because insurance decides what the patient gets in the USA. But in India, pharmacist probably does not decide, and the doctor and the patient together decide in our country. But we need to understand, the federal drug regulation properly so that, we understand the data associated with glargine. So getting a US FDA approval is not an easy task. They have to, do several studies. So the Biocon's biosimilar glargine got India approval in 2009. Actually, Basalog got its approval in 2009. So the EMEA approval came in 2018. The US FDA approval came in 2020, and the interchangeable designation came in 2021. What is this interchangeable designation? So in order to be called biosimilar, you just need to do a, pharmacokinetic study to say that the insulins are equal. But if you want to have interchangeability in the label, you need to do a randomized controlled study comparing clinical outcomes. That is, you want to compare on the one side glargine is given and the other glargine of Biocon is given, on the other hand the originator's glargine is given, and you compare clinical outcomes, not just the insulin level in the blood, not just the blood glucose, not intermediate endpoints, but clinical endpoints are studied. Why is it important to study the clinical endpoints? Because adverse effects are documented only when you study the clinical endpoints. If you do not have a clinical study, you don't know whether the glargine insulin is actually causing some side effects. So safety is of paramount importance. You know that there is a originator glargine. Both of them work very similarly. Is it safe? So in order to study that, several studies were done. So this is the global trial list. So in order to get interchangeability in the US markets, so Biocon has done several studies. So, several phase 3 studies, global phase 3 study, InStride group of studies, InStride 1, 2, 3, 4, like that. So, and also there is a dedicated Indian phase 3 study of 215 patients that will be of interest to us actually. And in all these, they were non-inferior to the innovator. So this is the, entire clinical trial setup of Basalog. So PKPD study, basically InStride 1, PKPD study is a phase 1 study. That is enough to call something biosimilar. But if you want to say call it bioidentical, or if you want to call it interchangeable, you need to actually have these other studies. InStride 1, 2, and 3 studies were done. And post-marketing surveillance was also done in Malaysia. And of course, we do have extensive real-world evidence with more than 3,000 patients in India. So let's look at the InStride 1. So whether glargine insulin once daily is non-inferior to reference insulin when administered in combination with mealtime insulin Lispro in patients with type 1 diabetes. It's actually enrolled 558 patients. A type 1 diabetes study is the best study to demonstrate any safety of any insulin, because these patients are only insulin dependent, and any differences, even the slightest differences in the originator insulin and the Basalog will come out in this actually. So treated once daily, and follow-up was done for 52 weeks. It's a very prolonged study. You can see that it's a 1-year-long study. So HbA1c, came down from screening to baseline, and it stayed at baseline. So the purpose of the study was not to, intervene or improve the HbA1c control. The purpose was to see whether the two insulins were equal in the clinical trial. So the average HbA1c will be same in both. So the actual fasting plasma glucose were also comparable. You can see that the error bars are almost overlapping. There is nothing to choose between these two insulins. It's as if the patient is taking the same insulin. So both basal and bolus insulin levels did not differ between the groups. It's important to note the insulin dosage requirement also. Insulin dosage requirement as well was not different. Rate of hypoglycemia and other adverse events were comparable between the two groups. This is the most important point whenever you are studying for interchangeability. So any problem, if the insulin is producing any side effect, it could have been picked up in a very large population, especially if 500 people are studied over a period of a year. So non-inferiority study, this is again a non-inferiority study in type 2 diabetes, InStride 2. So again 560, this time type 2 diabetes patients, again similar design. So biosimilar insulin glargine, that is Basalog, compared with the originator insulin glargine. It's a 24-week study, slightly shorter study. This is the A1C. You can see that the error bars are overlapping. It is completely non-inferior. So actual glargine dose over time, there is no difference in the biosimilar glargine and reference insulin glargine. So rates of hypoglycemia and other AEs were comparable between the two. This is again the point which we want to study. We want to see whether there's any imbalance in the side effects between these two insulins when we use it in a clinical setting for a prolonged period of time, 6 months, 1 year, like that. So an RCT is the best way to examine whether there is a difference between two biological agents. So if you're just doing a real world evidence or a descriptive study, we can never make out actually, because the study is biased by so many things. So when you have a RCT, random allocation, so you definitely know if there is a difference. So InStride 3, again a type 1 diabetes, switched between Biocon's insulin glargine and reference insulin glargine. It's a switching study basically. It's slightly more, more rigorous, this one. Then, so patient was on biosimilar insulin, then went into the reference insulin, then again switched back to biosimilar insulin. You can see that there is almost no change in, HbA1c. So you can see that the HbA1c bars are almost interchangeable. Anytime hypoglycemia, overall incidence of any hypoglycemic insulin event were comparable between the two sequences. No severe hypoglycemic events occurred at any point in the study. Anytime hypoglycemia events were comparable in both the sequences throughout the study. So whether the patient took, you can look at both the sequences actually. So reference and Lispro was given. Only Lantus was given on the one arm. On the other arm, Basalog was given, then Lantus was given, then Basalog was given. So this will make sure that any differences are teased out between these two insulins in terms of hypoglycemia avoidance. So after these rigorous studies were done, FDA approved the first interchangeable biosimilar insulin product. It's a matter of great pride for us that a company from Bangalore is actually innovating and passing the, it's a tough test to pass. It's not easy. So let's look at the evidence from India. This is a retrospective study, not really extremely robust evidence, but 44 type 2 diabetes patients with financial constraints were switched to interchangeable biosimilar glargine. There was a good HbA1c reduction. This you don't see in an RCT that you'll actually reduce HbA1c when you give Basalog. But the problem is, it's a real world study. Here what's happening is a patient who's not able to afford the originator glargine is using a glargine which is more affordable and hence able to control the HbA1c better because the affordability issue has been addressed. So this is a real world issue which needs tackling on a day-to-day basis. We cannot ignore this. So this is the Indian switch study. So reference glargine standardization at baseline, and this is again a biosimilar insulin for 12 weeks, reference glargine for 12 weeks. This is an Indian study done in India. So 167 patients, the reference glargine was given for 12 weeks. This is patients uncontrolled with OAD, type 2 diabetes patients. It's again a 12-week study. So you can see that the fasting glucose was similar. HbA1c is also similar between the groups. So was found to be non-inferior to reference basal insulin. Of course, if you do in an RCT and you find it similar in USA, you are likely to find it similar in India as well. That is the power of RCT. So it will tell what is the effect of the molecule in the human being. So whether you do it in US or whether you do it in India, it's likely to be similar. There's no difference. So interchangeable glargine is likely to have a huge health economic impact. So see, the challenge with having a triopoly is that the price of insulin keeps on growing if you don't allow a very good quality competitor in the market. So challenges are that, it is reserved for patients who can afford the insulin. So eased out with insulin glargine, more towards affordable and optimal therapy, though I would like to see the price of Basalog also to come down more aggressively. So, I mean, it is about 20-30% lesser, but it will be better if they are bringing it down much lower for the benefit of our patient. But, but that is what it is. So late insulinization can turn to timely insulinization because of affordability, better affordability. The rise in complications, we can reduce morbidity and mortality. Economic burden is reduced and the healthcare savings and costs are saved, and thank you.
Thank you so much, sir. You have beautifully explained the early intensification of the therapy and late insulinization and all of that. But with that, sir, I would like to ask that what is the HbA1c level from which we should initiate the insulin therapy? Like it should be more than 11 or 8. Could we start with that?
I think more than the HbA1c level at which we start, what is the HbA1c goal that matters actually? So for a young patient, say if the HbA1c goal is 6.5%, so I would start insulin even if the HbA1c is 7.5. Okay, but I mean it is the wrong question to ask is what is the HbA1c level I should start insulin. In fact, even a HbA1c of 11% patient may be well controlled with just double OAD and diabetes treatment actually, and very good diet and exercise. The right question to ask is what should be the target. So if the target is very tight and if you want to go towards the target, the best option is actually a basal insulin once you reach a HbA1c of around 7.5. 9% plus we can we need to give a HbA1c.
Thank you.
9% plus is broadly considered as a consensus for considering insulin. I can hear you, sir. I think the rest cannot hear you.
Sir, thank you, Dr. Anantram, for a wonderful talk. Sir, earlier days, there were hardly 2-3 molecules to manage diabetes. I'm talking about the oral molecules. So once there is OSA, oral anti-diabetic failure, we were switching to advising insulin. Now with the availability of multiple drugs, especially after DPP-4, SGLT2, availability of these drugs at a lower price, affordable price. Now there is full stock of medicines, anti-diabetic medicines in the market. So large number of patients, they are put on cocktail of all these medicines, 1, 2, 3, 4, 5 drugs. Still diabetes not under control. And the problem is, good lot of these patients are the right candidates for insulin. They are refusing one side, patient refusal. On the other side, the inertia from the doctor's side. So good lot of these patients with their HbA1c above 10, 11, 12 also, they are on a cocktail of multiple drugs. So how to break this barrier and what is your advice on this point?
It's actually a very tough situation. I am also faced with the same situation very often, basically. So when a patient is on 3 OADs, failing 3 OADs, they request that, I don't want to take insulin, I would like to do, I would like to try OADs. We cannot say, no, we don't have any other option. There are options, in fact. We can give, 5 OADs also. I mean, it's not that I have not written a 5 OAD prescription. I think everybody in this hall has written a 5 OAD prescription. But that's not ideal because of polypharmacy. So when you add so many drugs, the side effects of all the agents will get added. So what I tell to patient is, if you're giving pioglitazone, it will cause edema and increase the heart failure. If you're giving SGLT2 inhibitor, that is going to cause, foreskin itching and vulvovaginitis. And, if you're giving DPP4 inhibitor, rare incidence of bullous skin disorder is there. So when you're giving sulfonylurea, there is always a risk of hypoglycemia. So like this, drug-drug interaction can be there. So because many of these drugs are handled by the liver, so when you take a fluconazole or when you take any other drug, phenytoin, anything like that, so there can be interaction. Drug-drug interaction can be there. So when you use insulin, you avoid this, number one. And also it may probably result in cost saving when we use insulin. So many of our patients are fairly lean and they require a much lower dose of insulin. They need not more than 20 units of basal insulin mostly. And they'll be much better served with insulin therapy. So this is how I try to counsel my patients actually. But then, probably they will not agree in the first round. Probably when they come back the second time or third time, they're ready to take insulin. We'll keep trying.
Thank you, Dr. Anantharaman, for enlightening us about the benefits of interchangeable insulin. Over to you.
Thank you for the informative speech, sir. Any questions, you can talk to the faculty in person over the coffee, right across the hall. I now request our one-man army, just like how Dr. Kirti Shetty sir said, Dr. Aravind Jagdish and the chairperson to felicitate the speaker. I request Dr. Aravind Jagdish to present the mementos to the chairperson. Thank you, sir. Thank you, ma'am. For our next session, we have our chairperson, Dr. Kanti A. Dr. Kanti D.A., currently working as a director and Asia Regional Head of the Medical Safety at IQVIA, a global clinical research organization. She was also an ex-Army medical officer. We welcome you, ma'am. We are very happy to have you. Over to you for the further proceedings.
Hi everyone, good morning. So we have the next session. So we've had a good session on the previous one. We had a good overview on how it happens. So I come from a clinical research background now. So I can relate so well to what's happening. So now we'll have another session on the role of DPP4 inhibitors and SGLT inhibitors in the cardiorenal metabolic risk reduction, and this will be by Dr. Praveen Gangadhar, who is a well-known diabetologist in Bangalore, and also he is part of Aravind Diabetic Center. So over to you, sir. Thank you so much.
Thank you. Morning, everyone. At the outset, I would like to thank Dr. Aravind sir for this wonderful opportunity, and also the chairperson for your kind words. We spoke about insulin. I think sir rightly, Anantharaman sir rightly spoke about the various armatorium we have today in the management of diabetes. Definitely in the last decade, we have these two new kids in the block, the DPP-4 inhibitors and the SGLT2 inhibitors, which have been part of the management of diabetes. But having said that, definitely it has slightly postponed the the initiation of insulin because of these agents. But again, you do have some set of patients who definitely would require insulin over the period. But what is more intriguing with these molecules is the non-glycemic benefits, mainly the cardiorenal metabolic risk. What are the goals of a therapy? Managing type 2 diabetes is a complex, this complex chronic therapy requires both pharmacological as well as the behavioral therapy to delay as well as prevent the complications. And ultimately, we need to make sure that we optimize give a good quality of life for our patients. And when you see over the years, I think probably the post-EMPA-REG and the LEADER trial, the entire management of diabetes has seen a paradigm shift. It's not just about the glycemic control or the glucose control. Because the two important complications which has come, I think when you look at the guidelines, they speak about the risk of atherosclerotic cardiovascular disease, diabetic kidney disease, as well as the heart failures. And that is why those glucose-lowering agents like the SGLT2 inhibitors as well as the GLP-1 analogs have come to the forefront because ultimately they focus on two important complications, that is your the cardiovascular benefit as well as the cardiorenal the protection what you see with these molecules. And specifically if you talk about the SGLT2 inhibitors, definitely they do also have about the weight loss benefits with it. Again, at the same time, they don't cause hypoglycemia, which is extremely important in the management of diabetes. Why is it important? Why are we focusing on heart failure? Why are we focusing on these molecules? Because diabetes per se itself is more of a cardiovascular disease, and you can see that in diabetes, mainly because of the hyperglycemia, the insulin resistance leading to hyperinsulinemia, ultimately leads to what you call as increased oxidative stress, altered substrate metabolism. You have the advanced glycated end products, which again increases your pro-inflammatory cytokines. It also increases your pro-fibrotic pathways, which can alter the extracellular matrix in the myocardium. And this ultimately can lead to what you call as the diabetic cardiomyopathy as well as the failing, mainly ultimately leading to heart failure. A similar mechanism at the level of kidneys ultimately leads to progression of your what you call as the diabetic kidney disease, and ultimately both these conditions are interrelated, mainly because of the fluid overload. You have a bidirectional relationship both with heart failure as well as the chronic kidney disease. And if you look at the cause of death in diabetes, almost 65% of the deaths are due to the cardiovascular disease. And again, if you talk, it includes both your atherosclerotic cardiovascular disease as well as the heart failure. And when you talk about not just diabetes, even pre-diabetes, which is a continuum of your the process of your hyperglycemia, is a risk factor for your cardiovascular disease. So that is why sometimes we are in this conundrum. You get a patient who is almost 6.3, 6.2, has all the risk for the uncontrolled hypertension, dyslipidemia. If you feel that this is a high-risk CV patient, then probably we need to decide based on the individualization whether we need to have an aggressive approach, because ultimately we are worried about reducing the cardiovascular disease in our patients. And again, when you talk about the other important complication, almost 40% of our diabetics, almost uncontrolled diabetes, develop diabetic kidney disease. Uncontrolled hypertension is also equally an important factor. Unfortunately, our patients think otherwise. Taking diabetic medicines would probably cause kidney failure, but we need to reiterate the fact that it's your uncontrolled diabetes as well as the uncontrolled hypertension, because it have a very, very insidious progression, and by the time patient becomes symptomatic, you would go into a phase where you would be almost in a phase when the stage probably would have already been in a stage 3 or a stage 4 chronic kidney disease. And again, this is the same slide which I spoke about the vicious interaction between both the heart failure as well as the kidney failure. We know that the worsening heart failure does lead to the compensatory mechanism, mainly to an increase in your venous pressure, increase sympathetic activity, the natriuresis. This ultimately can damage your kidneys and worsen the kidney failure. And you have the RAS activation, which ultimately leads to water and sodium retention, which can again worsen the heart failure. And that's one of the reasons why these agents, you can see this is the ADA EASD guidelines, and right from post the EMPA-REG and the LEADER trial, we did have the ADA EASD consensus from the first line. You did have your choices before saying, okay, metformin, after metformin you have whether sulfonylurea or DPP-4 inhibitors or SGLT2 inhibitors. But now at the forefront, it's not just these or choices, it's the complication. If patient is having atherosclerotic cardiovascular disease or a heart failure, obviously you have a preference of both GLP-1 analogs as well as the SGLT2 inhibitors. In fact, you can use both these molecules together if you want, based on the affordability as well as the risk factors. And if you have somebody with diabetic kidney disease, then the first preference obviously is with your SGLT2 inhibitors. And with the advent of trials like your DAPA-CKD as well as the EMPA-Kidney, the EGFR cutoff has been lowered as less as 20. Because if you remember when DECLARE came out, we had cutoff of almost 60, then we had EMPA-REG which was 45. But thanks to the beneficial effects of these molecules in delaying the progression of diabetic kidney disease, the EGFR is now lowered up to 20. So this is why how the entire treatment has kind of changed in the focus of the complication-centric rather than just looking at the glucose as a number. This is a snapshot of all the CVOT trials with our SGLT2 inhibitors. I think most of you are already aware of the landmark trials, be it the EMPA-REG, CANVAS, DECLARE-TIMI. These were the CVOT trials, the initial cardiovascular trials with the SGLT2 inhibitors. Then you have the specific endpoints, mainly the renal endpoints. We had first the CREDENCE trial with the canagliflozin, then you had the DAPA-CKD, then you also had the EMPA-Kidney trial. Obviously, when you look at these CVOT trials, one important thing is, at the baseline population are slightly different. So you cannot compare, you cannot extrapolate the results, what you got in EMPA-REG with something with DECLARE-TIMI. But one thing, which is a class effect, is the heart failure. Even the VERTIS CV trial, though we know that ertugliflozin is not available in India, though it didn't reach a statistical endpoint in overall CV death benefit or the CV benefit, and this had a baseline population similar to the EMPA-REG trial. But even in VERTIS CV, there was some beneficial effect in terms of for the heart failure as well as the delaying the progression of diabetic kidney disease. And again, you have the other heart failure trials, specific trials like the DAPA-HF. More recently, you had the EMPEROR as well as the DELIVER trial, which looked at use of SGLT2 inhibitors in both in diabetes as well as non-diabetics with preserved ejection fraction. And again, you do have, we'll talk about the trial data later on. So, and a snapshot, across all the CVOT trials, the SGLT2 inhibitors have become the backbone, has become one of the pillars in the management of heart failure drug. And what are the mechanisms? Why do these molecules have these cardiovascular benefits? If you thought it's only about the glycemic control, then probably insulin should have got the maximum benefit in just bringing down the HbA1c and translating those benefits. But SGLT2 inhibitors in particular have this non-glycemic benefits. Mainly it works on your preload, it reduces your preload, it reduces your afterload. It also works on your myocardial, it reduces it inhibits this myocardial sodium hydrogen exchange inhibition. We also call something as the energy substrate. There is an altered metabolism where use of SGLT2 inhibitors, there is increased use of beta-hydroxybutyrate, which is more an energy-rich fuel compared to the conventional fuels. And heart and kidney try to use this as a fuel, and that kind of translates into the benefits what we see with these molecules. So other advantage of the SGLT2 inhibitors is the non-glycemic benefits or the pleiotropic benefits. Apart from just the glycemic control, you have an advantage with your weight reduction, no risk of hypoglycemia, slight reduction in your blood pressure, and also translates the CV benefits, both for your heart failure as well as for your ASCVD risk reduction. This is the meta-analysis of both the DELIVER as well as EMPEROR. Basically, empagliflozin and dapagliflozin in people with heart failure with preserved ejection fraction. And you can see almost an hazard ratio of almost 0.8, almost a 20% benefit even in these people with preserved ejection fraction. And that's what make them to get into this guideline, what you would see. Even the 2023, the AHA guidelines recommend SGLT2 inhibitors as the first-line therapy, almost a class 2A recommendation for the treatment of heart failure with both preserved as well as reduced ejection fraction, apart from the conventional diuretics, the MRAs, the ARNIs, and the ACE and the ACE inhibitors. And when you talk about the other part, because since we are talking about a combo of the SGLT2 and DPP4, you have all the DPP4. We know that the gliptins are generally CV neutral, and if you talk about two important molecules, you have the sitagliptin and the linagliptin, which did have a CV neutral study. Even saxagliptin was CV neutral. The only risk with Saxa was the saver-to-me did show a slightly increased signaling with increase for hospitalization for heart failure. But I think in India we have the Sita, Lina, teneligliptin, though there are no CV trials, and also vildagliptin. But vildagliptin in general, the usage, we have the real world studies, and we also have the VIVID study, which was not exactly a CVOT study. But in terms of, overall, if you talk about the CV, the MACE outcome with the DPP4 inhibitors, generally gliptins are CV neutral agents. So what is the rationale for combining? So India is known for the fixed dose combination. You get all sorts of combination, but there should be some sort of rational combination when you think of combination. And there is a mechanistic view, what is the advantage of combining the SGLT2 inhibitors with the DPP4 inhibitors. This is a famous omnious octet slide. I think most of you have been already aware of this slide and the source of hyperglycemia. While combining both DPP4 inhibitors with the SGLT2 inhibitors, you almost tackle 6 out of the 8 the defects in the pathophysiology, and obviously has a better control. One important point when you're using an SGLT2 inhibitor is the slight increase in your glucagon levels, and this glucagon levels can actually increase your fasting hyperglycemia. That is the rationale behind adding a DPP4 inhibitor or a GLP-1 analog, which counter your glucagon levels. So ultimately, the fasting hyperglycemia is also tackled and ultimately has a much better benefit with this combination. These are some of the studies which are shown that this combo of SGLT2 and DPP4 with the DPP4, and as expected, you would see a better reduction with the combination as with monotherapy with the DPP4 inhibitors. And generally, any molecule for that matter, higher the A1C, better would be your reduction. And that is what you are seeing, that above 9%, you do tend to see a better reduction with this combination. And again, when you're talking about two molecules, one important thing when we talk is the risk of hypoglycemia. Both the combination of SGLT2 and DPP4 inhibitors generally won't cause hypoglycemia. But when you're adding this on a therapy with somebody on metformin, sulfonylurea, or on insulin, we need to keep in our mind to adjust the dosage. So it's very important you titrate the insulin dose, call them back after a week. Either you want to keep them on a monitoring or do the SMBG monitoring, and you need to adjust the insulin dose, because when you add this molecule, the insulin requirement can come down in some of the patients. So it's important to monitor. But per se, along with metformin, these two fixed dose combination don't cause hypoglycemia. And the other common worry with our people is the use of SGLT2 inhibitors as well as the mycotic infections and urinary tract infections. The most so it's with the mycotic infection, not the UTI. But when you add a DPP4 inhibitors, there are studies which shows that adding FDC of this has a reduced risk of UTI. And the probable mechanism they have claimed is the inhibition of the DPP4 enzyme in the bacteria. But generally, the chances are less. The basic cautions we need to understand is when somebody comes to you at a high A1C, osmotic symptoms, it's always better to control with insulin, get some sort of euglycemia, and then you think of these agents, then the chances of UTI or even the mycotic infections are much lesser with these combinations. These are some of the slides with a combination with sitagliptin. I think today we have all sorts of combinations available with the DAPA, and one advantage of DAPA and SITA is the OD dosing of these two molecules. And in India, we know that post the patency, we have these combinations, and you can see that the combination does have a slightly better effect in your A1C as well as your weight reduction as well as in your BP reduction. Then you have the combination of vildagliptin with the SGLT2 inhibitors. Though we know that primarily a vildagliptin is a VD molecule, and if you're talking about, we do have certain combination of vildagliptin with remogliflozin, but again, you also have the OD combination of vildagliptin with dapagliflozin. Again, adding DAPA, though the sample size was small here, you can see that over 6 months, almost 2 to 2.5 kg reduction was seen. A1C reduction may not be significant, but what you see is obviously the non-glycemic benefits in terms of you can see even the improvement in the AST and ALT, and we know that SGLT2 inhibitors do have beneficial effects in reducing the NAFLD risk as well as the progression of fatty liver. And again, one point we need to remember, this combination works much better in the Asian Indian phenotype. And we have a lot of meta-analysis as well as article which shows that the DPP-4 inhibitors as well as the SGLT2 inhibitors are more works better in the Asian Indian phenotype. This is again the complementary action which I already mentioned. And these are some of the already the fixed dose combination which is available in our country. You have the Empalina, you have the Dapa-Saxa, Ertucita is obviously available in US. We have the Remo and Vilda. And I think very soon, by another 1 month, you would probably have, even with Lina and all the combination possible. But I think choosing the right combination for the right patient is extremely important. Coming to the last part, so where do we place this combination? Obviously, you want to start off when a newly detected patient, you want to start off, somebody is not tolerating metformin and the A1C is more than 8%, definitely this is one of your choice. And again, you can use this as an add-on with metformin whenever you want an A1C reduction of around 1 to 1.5%. And again, people already uncontrolled on metformin with sulfonylureas, again, you can use it as a third-line therapy. And also you can, as I mentioned, you can also use with insulin. But having said that, you need to be careful when you're using with insulin or the sulfonylureas. The dose adjustment and monitoring is equally important, mainly to avoid hypoglycemic risk. And again, when you talk about the main problem, that is the heart failure, definitely this becomes your first line. And SGLT2 with proven benefit, you have the DAPA, EMPA, you have the CANA, which have all proven their benefits, as it's a class effect when it comes to heart failure. And again, when you want to choose a DPP-4 inhibitor in a heart failure patient, then definitely sitagliptin and linagliptin have slightly higher benefit because mainly of the TCOS as well as the Carmelina trial. And again, when you look at the chronic kidney disease, as I mentioned, there's a slight correction there. Now the EGFR is lowered up to 20, and definitely the SGLT2 inhibitors are your first choice. But having said that, whenever you initiate, do anticipate a slight drop in the EGFR or slight increase in the creatinine, which kind of recovers after 4 to 6 weeks. This is again the other indication for promoting. You use it for your weight loss as well as for your better glycemic control. So to overall summarize, the fixed combination of SGLT2, DPP-4 inhibitors are excellent combination, not only mainly for the Asian Indian phenotype, which has an increased risk of cardiometabolic renal risk. This combination not only controls your blood glucose levels, but also has your non-glycemic benefits in terms of reducing your risk of progression for your heart failure, as well as your progression of your diabetic kidney disease. Thank you.
Thank you, Dr. Praveen. So it was a extravaganza of knowledge to understand about each of the molecules as well as the combination in our regular practice. So floor is open for questions. There's a question there.
Thank you for a wonderful talk. See, suppose a patient is on a combination of, say, SGLT2 and DPP-4 inhibitors. The two things that we want is the cardiac benefit and the renal benefit, in addition to HbA1c, blood pressure, and various other things. A patient on SGLT2 and DPP-4 combination, in the subsequent follow-ups, there are two things that can be measured. As far as the heart is concerned, the ejection fraction, and as far as kidney is concerned, the EGFR. So subsequently, when it comes for the follow-up, how often you advise repeating the echo test and the ejection fraction and the EGFR, and can we see benefit, the cardiac benefit and the renal benefit that can be documented in terms of improvement in the ejection fraction, in terms of improvement in the GFR, in addition to HbA1c, blood sugar, and various other things. How do you do the follow-up? How often you do it? Can you see evidence that can be documented?
Thank you, sir. Very, very important question. I'll share some of the personal experience. I think the more common test which we would obviously do is to assess the renal function at baseline. So we do the creatinine, but more important than creatinine is the urine albumin creatinine ratio or the urine microalbuminuria, though the term is absolute. So we do get a lot of patients at baseline where you see you present with macroalbuminuria already on therapy of ACE and ARBs. And by adding an SGLT2 inhibitors, we do see a regression of these parameters. When you talk about the kidney parameters, I'm saying. So probably when I start at baseline, you would have the renal function. Safer side, I would repeat it after 3 months, because in 4 to 6 weeks, when you try to repeat a creatinine, there will be a slight increase in the creatinine. So it's very important we communicate to our patients regarding that slight increase as well as the decline. Coming to the cardiac parameters, I think routinely most of them do have a cardiac evaluation, but again, throughout we don't document an echo for everybody, but annual evaluation is something which is warranted. But there are already heart failure patients who are following up with the cardiologist, and sometimes the initiation happens from their end. And we do see that a lot of patients on an SGLT2 inhibitor, so I'm talking even before these results, 2 to 3 years back, EF was around 30%, 35%. They have come for follow-up. Actually, they have come down on the dosage of the diuretics as well as the ARNI dosage, whereas the SGLT2 inhibitors has been continued. And that again reiterates the fact that it's not 1 or 2 people, but at least 3 to 4 patients who have documented evidence where the EF also has improved. Though it could be multifactorial, definitely an SGLT2 inhibitor is there to help in this reduction, sir.
Thank you, Dr. Praveen. Yeah.
Thank you very much.
Thank you for this wonderful session, sir. Any further questions, you can talk to the faculty in person. Due to time constriction, please manage. Thank you very much, sir. I request Dr. Aravind Jagdish and the chairperson to facilitate the speaker, and I also request Dr. Aravind Jagdish to present the memento to the chairperson. Moving on to our next session, we have Dr. K.G. Suresh, diabetologist, Manipal Hospitals, Bengaluru, and Dr. Dhriti Thakur.
For everyone's benefit, there's a mic placed in the center of the hall. So if you have any questions, you can utilize that mic also.
Thank you, ma'am. Thank you, sir. We now have Dr. K.G. Suresh and Dr. Dhriti Thakur. We welcome you, ma'am. We welcome you, sir. Please give them a huge round of applause.
Good morning. It's a pleasure to introduce Dr. Anil Kumar. He is a consultant physician and diabetologist in Karnataka Institute of Endocrinology. So he has various achievements. He is a past chairman of KRSSD in 2017 and 18, and he has more than 25 original research publications both in national and international journals, and also he is in various projects of Karnataka government. And he has tsunami of achievements, you can see in the slide. And he'll be talking today on surfing the tsunami of hyperglycemia and relevance of DPP-4 inhibitors.
Yeah, I think, first of all, I thank Dr. Aravind for this talk. And as they said, Aravind is a one-man army. So he has organized several conferences, and I think if you have attended, he has organized virtual conferences also last time. Of course, it was an international conference. So definitely, I think this conference will be a huge success with a lot of national speakers coming to this conference. Now, the topic for my discussion today is, of course, Dr. Praveen slides and my slides. There may be some repetition. Surfing off tsunami of hyperglycemia, the relevance of DPP-4 inhibitors. I think we all know DPP-4 inhibitors were launched in about 2008. So it's almost 15 years. So I have to cover 15 years of these in 15 minutes. It may be difficult, but most of you have used DPP-4 inhibitors in your practice regularly. And of course, now with the loss of patency of both Vilda and Sita, everyone is using this DPP-4 inhibitors. So what are the challenges faced by Indian people with diabetes? So first challenge is high carbohydrate diet, that is the high glycemic food what we eat. the sedentary life, and then the thin fat Indian. Thin fat Indian means even if they are thin, the fat percentage will be more. And of course, the visceral fat will be more. And then the higher insulin resistance and the strong family history and the younger age of onset of diabetes. And type 2 diabetes we are seeing as early as 25 to 30 years now. So that's also very important in our practice. And then the early onset of cardiovascular disease, as we see MI at the age of 30 years and even less than 40 years, we see many patients having MI and acute coronary syndrome. These are all the unique characteristics of Indian patients. And of course, if you see this slide, this is, I think, a quite old, this one, because as we see type 2 diabetes, the beta cell function gets decreased progressively. And of course, HbA1c, PPG deteriorate. And our important thing is to get the HbA1c goal with minimal hypoglycemia and minimal weight gain. So in that aspect, definitely DPP-4 inhibitors and SGLT2 inhibitors will help us. What is the relevance of DPP-4 inhibitors in Indians? So in a study, it was shown that young, healthy South Asians have a higher GLP-1 levels and higher insulin levels when compared to Caucasians. So this is very important in our practice because our patients respond well to DPP-4 inhibitors compared to Caucasians. And one more study, this is by Anup Mishra et al. So he has shown that increased DPP-4 enzyme activity seen in non-obese Indian patients with type 2 diabetes. And of course, this increased DPP-4 enzyme activity was associated with fasting insulin, increased waist circumference, and increased intra-abdominal fat, triceps skin fold thickness, all those things. So definitely in Indian patients, the DPP-4 enzyme activity will be increased, so the DPP-4 inhibitors work well in Indian patients. And just to see, I think Dr. Praveen just told about some meta-analysis. If you see this, there will be a difference of lowering of efficacy of DPP-4 inhibitors between Asians and non-Asians. This is a study, meta-analysis by Kim et al. Published in Diabetologia, which actually shows, here they've included 55 trials, and they have shown that the DPP-4 inhibitors work better in Asian patients when compared to non-Asians. And again, one more meta-analysis. Here also they've included 62 randomized trials. This is by Park et al. They have also shown that the DPP-4 inhibitors work better in Asians when compared to non-Asians. And again, if you see this slide, the DPP-4 inhibitors affect the pathophysiological, the main pathophysiological defect of islet cell dysfunction. That is, both beta cell and alpha cell defect will be addressed by these DPP-4 inhibitors. And I think this is a very important slide. DPP-4 inhibitors act in a glucose-dependent manner. That means you can see only in presence of hyperglycemia, the DPP-4 inhibitors increase insulin secretion. But in absence of hyperglycemia or when there is hypoglycemia, DPP-4 inhibitors will not increase insulin secretion. So this, if you see, in contradiction to, so this is in presence of glucose, insulin will be secreted with the DPP-4 inhibitors. Whereas with sulfonylureas, even in presence of hypo or hyperglycemia, there will be secretion of insulin and there will be hypoglycemia, which is very common in sulfonylureas. That is one of the most important difference between these two drugs. And then just to go back to the history, when was sitagliptin was launched? Sitagliptin launched in about 2006, approved by US FDA, and 2007 approved by European Association. And then vildagliptin was approved in February 2008, again by European. It is not approved by US FDA still. Saxagliptin approved by US FDA in 2009, linagliptin in 2011, and alogliptin in 2013. And of course, we have teneligliptin also, but it is not approved by US FDA, only approved in Japan and India. So what are the structural differences? So I think when these gliptins were launched, in every conference there was a topic like, or whether all gliptins are same. So I don't think, after so many years of usage of these molecules, I think there are definite differences between different gliptins. Here if you see, all the gliptins are used once daily except vildagliptin, which is used twice daily. But now we have vildagliptin XR preparation, which can be used once daily. And then The other gliptin, saxagliptin, is the one which has drug-to-drug interactions and active metabolites. And all others doesn't have drug-to-drug interactions, and they don't have active metabolites also. And then again, a meta-analysis with DPP-4 inhibitors have shown that they reduce HbA1c by about 0.7%, 0.7 to 0.8%. Again, here, the reduction of HbA1c depends on the baseline HbA1c. If the baseline HbA1c is more, the reduction of HbA1c will be more with those patients. And again, my topic was DPP-4 inhibitors. So I cannot talk on all the DPP-4 inhibitors. Maybe just I will compare Vilda and Sita, which is the one being commonly used. I think 90% of our patients will be on Vilda and Sita, probably few on Lina and teneligliptin. So when we compare Vilda and sitagliptin, at about 24 hours, the vildagliptin has about 97% DPP-4 inhibition, whereas sitagliptin has about 80% DPP-4 inhibition. And then again, there is one more difference. Vildagliptin actually binds rapidly and dissociates slowly, whereas sitagliptin binds rapidly and dissociates rapidly. So that is one of the difference. So whether this gets translated into clinical practice, we have to see, but in practice, we are using both Vilda and Sita, and of course, we see almost same, maybe individual variation will be there. And then these drugs, Vilda or Sita or any gliptins, combined with metformin, definitely they have a synergistic effect. Here you can see that vildagliptin increases GLP-1 levels by about 2 to 4-fold. But when added to metformin, metformin actually raises GLP-1 levels by a different mechanism, probably by increasing the GLP-1 synthesis. So when these two are added together, you can see the curve. With monotherapy of vildagliptin, there is a slight raise in GLP-1. In combination, definitely it's more than double, almost 2 to 3-fold. So that's very important in practice because most of our patients will be on combinations. And again, this is a meta-analysis where they have the combination of metformin and vildagliptin or DPP-4 inhibitors, Sita, Vilda, and other gliptins. You can see the combination gives more than 1%, probably up to 1.5% HbA1c reduction. And in practice, with the baseline HbA1c more, probably you see more HbA1c reduction. So this is maybe the term, I don't know, is it suitable or not, tsunami of hyperglycemia. So we have several factors like uncontrolled HbA1c, FPG, dysfunction, impaired PPG, glycemic variability, associated comorbidities, and quality of life. I think DPP-4 inhibitors address all these different parameters. FPG dysfunction, you can see here, this study shows the difference between Vilda and Sita. Vilda reduces FPG by about 137.8 milligrams up to 137.8, and Sita 140. There is a slight difference between Vilda and Sita. And next, the PPG reduction. Again, there will be PPG reduction. I think PPG reduction will be more pronounced with vildagliptin, about 40% when compared to 37% with sitagliptin. So uncontrolled HbA1c, of course, several studies with gliptins have shown good results. With vildagliptin, we have EDGE trial, initial trial, and verify trial. If you just see these trials, EDGE trial is a real-world evidence where they have studied 2,957 physicians giving their results with HbA1c reduction of more than 0.7% in these patients. And then this is one of the smaller studies in India, that is combination of vildagliptin plus metformin in drug-naive patients. So at 12 weeks, they have seen a reduction of about 1.6%, at 24 weeks, about 1.9%. And again, one more, the verify trial. The verify trial, I think this is a very important trial. The early combination therapy compared to the monotherapy. The early combination therapy has shown good results. That is, the failure rate will be at about 60 months, whereas with monotherapy, it is 36 months. So nowadays, because of after this study, we are using more and more combination therapies. And then DPP-4 inhibitors actually repair the beta cell dysfunction and improve the insulin sensitivity. Specifically with vildagliptin, if you see the vildagliptin versus teneligliptin, this study, the HOMA-IR and the OMA-beta before and after with vildagliptin, the HOMA-IR, there was a reduction. At baseline, it was 3.56. At 3 months, it was 3.27. You can see a definite reduction of insulin resistance. But beta cell function also increased, but with teneligliptin, there is no difference in insulin resistance, but there is an improvement of beta cell function. So in that, we can just show that vildagliptin has action on both beta cell function and insulin resistance. And this is just to show that DPP-4 inhibitors have low hypoglycemia risk, and of course, this is true with almost all the gliptins. And the glycemic variability, this glycemic variability, they've compared Sita and Vilda, they have shown reduction of mean amplitude of glycemic excursions in both, and of course it was better with vildagliptin when compared to sitagliptin. And what are the, I think Dr. Praveen has covered all the gliptins about this. The vildagliptin has shown in a meta-analysis that is the cardiovascular neutral. The MACE events were almost equal between the vildagliptin and the placebo. And if you see all the trials, the TICO study has shown that there is no increase in cardiovascular events with sitagliptin. And SEVER-TIMI, this study, there were no increase in MACE events, but there was 27% increase in hospitalization for heart failure that I think we should remember when we practice. And then allogliptin also did not show any increase in MACE events, and vildagliptin, of course, there is no CVBT trial, but in most of the meta-analysis, it has shown no increase in MACE events. So based on all these results, except saxagliptin, all other gliptins are safe. Maybe saxagliptin you should be careful when you use in patients with heart failure. And then again, vildagliptin in presence of hypertension, probably it has an effect that it will reduce BP by affecting the VEGF levels. This is one of the important points. I think when we use vildagliptin, maybe in hypertensive patients, we will have an additional benefit. What about the quality of life? Definitely with gliptins, the quality of life is good because there will be minimal hypoglycemia, minimal weight gain. And now all the gliptins can be used in OD dosage because all are available, even Vilda is available in XR preparation. So now vildagliptin has been studied with 50 mg daily compared to 100 mg OD, and both have shown almost a similar HbA1c reduction. And now I think this already been discussed in the previous presentation. The combination of DPP-4 inhibitors and SGLT2 inhibitors. I think in practice, using only SGLT2 inhibitors definitely will have a lot of apprehension about UTI and genital infections. Now I think combination of DPP-4 and SGLT2 inhibitors will be a good choice in most of our patients. So combination has a definite synergistic effect. So as discussed, dapagliflozin or any other SGLT2 inhibitors will have increased glucagon levels that will be negated by addition of DPP-4 inhibitors. And then this is the slide repeated in the previous presentation. When used combination, the UTI and genital infections will be definitely less, and I think we have seen this in our practice also. And what are the adverse reactions? I think if you see all the drugs, maybe the safest drugs is still DPP-4 inhibitors because it's a well-tolerated drug. We have used this almost 15 years, I think, a time-tested drug, very minimal hypoglycemia, weight neutral, and even it doesn't have any problem of UTI or any genital infections. You can use in elderly, you can use even in cardiovascular patients, but now we can use it combination with SGLT2 inhibitors. And of course, if you see the adverse events, in our practice, I think in my practice over 15 years, I have seen mainly GI disturbances like vomiting, gastritis, diarrhea, even constipation. And then some of patients may have nasopharyngitis, recurrent nasopharyngitis without. Then we have to see and stop DPP-4, definitely it will come down. And then uncommon arthralgia. We have seen some patients complaining of joint pains. And again, I want to stress one important point here. I think pancreatitis was quite rare, But now with the use of DPP-4 inhibitors left and right, we should remember pancreatitis, because I have seen 1 or 2 cases of pancreatitis. We should analyze serum amylase and lipase. If it is more, definitely we should stop this drug and advise the patients regarding the follow-up. And then, as we all know, renal impairment. What happens in renal impairment? Only ninagliptin can be used without reduction of dosage, but other gliptins, sita, vilda, saxalo, has to be reduced depending upon the EGFR. EGFR more than 50, full dose. 30 to 50 ml, 50% dose, and less than 30 ml, we can use 1/4 dose with sita and allogliptin, and 50% dose of vildagliptin. And hepatic impairment, I think mild to moderate, linagliptin is recommended. Even in severe, it can be used. All other gliptins, sitagliptin, saxa, allogliptin can be used in only mild. Vildagliptin cannot be used in hepatic impairment. That we should remember. So I think, so ultimately the DPP-4 inhibitors, quite safe drug in our practice with very less hypoglycemia and weight gain. Now with combination of SGLT2, definitely it will be a very important drug in the management of type 2 diabetes. Thank you.
Thank you, Dr. Anil. So one thing, what do you tell about saxagliptin and dapagliflozin combination? One causes heart failure, one prevents.
Yeah, but I don't know. I don't advise that combination, because we have a SEVER-TIMI trial with increase, 27% increase in hospitalization for heart failure. And using in heart failure, I don't advise. Probably we have to use other gliptins with quite safer drugs, because they have studies, TICO study, and then even the linagliptin has a study. But vildagliptin probably has a meta-analysis, not, but we are using in our patients because it's available and we have used from many years, time-tested drug. Yeah, I think, no, allergic reaction, especially with sitagliptin, we have seen that initially few cases we have seen, and we have stopped the drug, and probably we have to treat as other acute reactions. Maybe if necessary we have to use steroids and then control the acute reactions. So maybe the percentage is quite less.
Yeah, it's very less though, but I've seen across all, maybe if one of my patient had reaction with vildagliptin, so I interchanged to sita as well as telini, but it didn't subside even after stopping the drug, but still conditions is going on.
Yeah, again I want to stress, but whether it is this reaction or pancreatitis, it's quite less, but we should be aware of this. Sure. But when the patient is complaining of, somebody will think it is for a different, this one, they may not stop DPP-4. So in that, definitely they have to stop and treat accordingly. Because I have seen several patients having serum amylase lipase being raised. So we cannot continue in such patients.
Sir, I have a question to you. Almost every patient, when we do ultrasound, we see either a fatty liver or NASH or alcoholic hepatitis. It is very common. Most of them asymptomatic. Some of them due to alcoholism, some of them due to non-alcoholic fatty liver disease, NASH and that group. So out of the two gliptins, the sitagliptin and the vildagliptin, there is some concern about the usage of vildagliptin, which is very widely used in patients with a hepatic disorder like this, the early changes in the liver. My concern is about giving these vildagliptin to these patients on a long-term basis. How safe are this vildagliptin in such patients, and how do you monitor? Where do you give them and where do you stop it? What is your take home?
No, as you said, it's very difficult. We start vildagliptin without doing any ultrasound scanning. For all patients, we will not do. Maybe they may have, if they have fatty liver associated with derangement of LFT, like ALT, AST being raised. In that, definitely I don't use vildagliptin. But if it is only fatty liver, if I have used vildagliptin and I will do the LFT and see if the LFT is quite normal, maybe now with the vildagliptin not to be used in hepatic impairment, probably we can change over to other gliptins because we have sita and other gliptins which are quite safe. But again, in practice, we don't do any, because as so many of our patients have fatty liver, so we don't do. But we can do liver function tests. We can repeat, if the liver function test is deranged, I think we have to stop vildagliptin.
Sir, why this teneligliptin not so commonly used?
Teneligliptin, of course.
Is it due to its QT interval prolongation?
No. See, it is not being approved by US FDA. That is one, this thing we will have in our mind. Because when it was launched, it was definitely, the cost was less than the other drugs and we all started using. Now with Vilda and Sita going out of patency, it's almost available at teneligliptin price. That's why they are using more and teneligliptin has come down. But regarding prolongation of QT interval, it is only with 160 mg and above. We use only 20 to 40 mg.
Yeah,
I don't think that's a problem with teneligliptin. We have used in many patients. I have not seen any prolonged QT interval.
The quality of action remains the same with teneligliptin and the other gliptins also?
No, it's almost same. Actually, it's approved in Japan, but in India also we had used many, before our loss of patency, teneligliptin was used left and right, and now its usage has come down. But I have not seen much reactions or any side effects with teneligliptin also.
Thank you.
Sir, thank you so much for a wonderful talk. Sir, with gliptins and SGLT2 taking over the market, do you think it is the end for SUs?
Now I think Dr. Aravind will come. So Aravind will be, I think, batting for sulfonylureas. So sulfonylureas, still it's not end. I don't think it will end, especially in Indian market, in Indian patients. There is no end for this one. Probably it may take another few years, maybe we don't know, 20, 25 years or more than that. So when DPP-4 inhibitors were launched, they were saying DPP-4 inhibitors will replace sulfonylureas. So that has not happened since 15 years. I don't think it will replace. Probably we are using combinations like DPP-4, sulfonylurea also, because our patients don't accept insulin. So we have to use combinations.
Thank you so much, sir. Thank you so much. Thank you so much for a wonderful talk.
Thank you very much, sir, for that wonderful talk. I request our main man behind the summit, Dr. Aravind Jagdish, and the chairperson to felicitate the speaker. Let's give them a huge round of applause, everybody. I know for a fact that doctors are a little serious, but today, let's all celebrate, let's all smile. I also request Dr. Aravind Jagdish to present the memento to the chairperson. Moving on to our next session, now I request our esteemed chairperson, Dr. Karthik Muni Chudappa, diabetologist, Diafine, Karthik Hospital, Bengaluru, and Dr. Janardhan, consultant diabetologist, Bengaluru, on stage for the further proceedings. Respected delegates, coffee and tea will be served to your respected places. Also, it is available throughout the day across the hall. Please feel free to have coffee and tea. Thank you, sir. Thank you, ma'am.
So, good morning, everyone. And I thank Dr. Aravind Jagdish to have us here as chairpersons for this wonderful talk. We all know that the development of type 2 diabetes is a complex interplay between environmental factors and genetics. And we also know that if one parent is a diabetic, the chances of developing diabetes in the offspring is 40%. And if both the parents are diabetics, then it is 70%. And this correlates very well when you compare it with monozygotic and dizygotic twins as well. And also, if one of your first degree relatives is a diabetic, chances of developing diabetes is 3 times higher. And also, genetics in type 1 is very easy to understand, but whereas when it comes to type 2, it's polygenetic and it's more complex. And to talk on this complex issue, we have with us Dr. B.K. Singh from Aurangabad. Over to you, sir.
Thank you, Chairperson, especially Dr. Karthik, for your kind introduction. At the outset, I must thank the one-man army, Dr. Aravind, and I pay regards from the people of Bihar to you. Thank you, Dr. Aravind. Today's topic from my side is genetics in type 2 diabetes. You all know that genetics is a real bit challenging topic and rather difficult to understand also, but I will try to keep it in just simple as I can. As you know that the diabetes is a chronic metabolic disorder having raised plasma glucose either due to lack of insulin secretion and or action. It is considered spectrum of disorder having type 1 diabetes in one hand and type 2 diabetes mellitus at another hand and many intermediaries in between. The development of type 2 diabetes mellitus is the result of interaction between the environmental factor and strong hereditary components. More than 90% of the total diabetic patients suffering from type 2 diabetes mellitus, obesity, lack of physical activities, stress, smoking, unhealthy diet, small and large babies, pollution and toxin may play a role to increase the risk of type 2 diabetes mellitus. Advancements of the genetic studies in 1980 made possible to identify genetic loci of hereditary components. If you can see, my presentation will be the heritability of type 2 diabetes mellitus, the genetic architecture of diabetes mellitus, identification of diabetic risk genes, parent of origin effects, protective rare variants, functional and transactional studies, and translation of genetic information in clinical practice. As said by Dr. Karthik, the estimates range from the 20 to 80%, and whose one parent is type 2 diabetes mellitus, having 40% lifetime risk of developing type 2 diabetes mellitus, and it increases to 70% when both of the parents are diabetic. Higher concordance rates in monogenic diabetes, around 35 to 70%, and dizygotic twins, 17 to 35%. And the T2 type 2 diabetes mellitus clearly shows the familial aggregation without following standard Mendelian inheritance, and the first degree relative of type 2 diabetes mellitus individuals are 3 times more prone to developing this type 2 diabetes mellitus. The type 2 diabetes mellitus shows very high prevalence in some isolated population like the Prima Indians. It is around 50% at 35 years old and 70% in the 55 to 64 years of age. And the population of the Nararu, a small island country in the Pacific Indians, is having 31% in that particular group of the patient. If you can see the risk of developing diabetes, and that is a beautiful diagram, shows that the BMI and the fasting impaired glucose, fasting plasma glucose is considered, you can clearly see that if the BMI is more than 30 and the fasting plasma glucose level is more than 100, you can see the more than 28.8% of the patient which may have developed diabetes if the patient is having the family history positive. Similarly, you can see that in all group of the patient, whether the BMI is more or fasting glucose is normal or it is more, you can see that all of the patient having the family history positive, the chances of developing diabetes is quite more. Genetic architecture of diabetes, the first gene which is, you can see that the KCNJ11 genes and the TCF7L2 genes, the FTO genes, the IRS1 genes, and HMGA1 gene. This is the all development from the 2000 to 2014s. And recently, it was in 2018, there are 128 signals and 113 distinct loci is seen, but fine mapping of expanded set of type 2 diabetes mellitus loci on single variant resolution using high density imputation and islet specific epigens mapping shows that 403 loci in the Caucasians and probably the 430 in the Asians group of patient. There are many way to study this genetic linkage, and one of the study is the linkage study. And the linkage is the tendency for the genes to inherited together because they are close relations on the chromosomes. And linkage analysis is a simple but poor resolution in identifying genes in the polygenic disorders. The CAPN10, it is the first type 2 diabetes mellitus gene to be discovered by the linkage study when a locus on chromosome 2 was associated with type 2 diabetes mellitus in 1996. And the most important gene, the TCF7L2, is the greatest success of the linkage study related to the discovery of a variant of TCF7L2 gene. It was discovered in the type 2 diabetes mellitus susceptibility gene after a strong signal was mapped on the chromosome 10q in a Mexican American population. This is very important, the transcription factor 7 like 2 genes is very important in the lineage. The second is the candidate gene studies. The gene is already suspected of playing a role in the pathogenesis of type 2 mellitus are studies. The PPAR-G is first candidate gene associated with type 2 diabetes mellitus, and PPAR-alpha is a molecular target of thiazolidinones, and the insulin sensitizing anti-diabetes medication used for the diabetic care. The IRS1 and IRS2 genes, the KCANJ11 genes, it encodes the ATP-sensitive K-channel target for the sulfonylurea activating mutation is well-studied cause of the neonatal diabetes mellitus. Most important factor is KCN0 or ABCCD gene are important for the neonatal diabetes mellitus. The YFS1 gene and HNF1 alpha and HNF1 beta and the HNF4 alpha these are all motor genes which is for monogenic diabetes mellitus. The most important study is the genome-wide association study, and this GAVAS is an approach that involved rapidly scanning marker across complete set of the genome, and many GAVAS for diabetes were published in 2007. And recently 403 loci in Caucasian and probably more than 430 loci in Asians are identified by fine lab mapping of the type 2 diabetes mellitus loci. The TCF7L2, as I said earlier, the transcription factor like 7-2 gene is the most significant and consistently replicating gene. It was initially discovered by linkage study and later confirmed by the GAVAS. An increased level of TCF7L2 protein is associated with impaired insulin secretion, impaired incretin effect, and increased hepatic glucose production. The other genes are HHEX gene, the CDKN2AB genes, IGF2B PD gene, and MTNR1B genes. These are all genes, but most important the TCF7L2 gene. So we can see, in genetic variability, whether mother or father, which is more important in creating the diabetes patient, the risk of type 2 diabetes mellitus in offspring is greater if the mother has type 2 diabetes mellitus than the father. And this is a Botnia study, the parental history of NIDDM influenced the insulin response to oral glucose load with male offspring of a diabetic mother showing the lowest insulin values. That is very important. The mothers are more, the chances of getting offspring diabetes more with the mother is diabetic. A large-scale family-based study determined that the variants of KCNQ1 and KLF14 shows is stronger when the risk allele is transmitted from mother than the father. It is another study. And this BMP8A gene expression, that is mRNA, in blood shows stronger correlation between father and offspring than the mother and this offspring. There are many protective variants, rare variants are there that will protect your diabetic patients, and one of the gene is SLC30A8 genes. A rare loss of function mutation in the SLC30A8 protects against the type 2 diabetes mellitus, and carriers of this protein truncated mutation have 60% lower risk of type 2 diabetes mellitus. That is very important. If the patient harboring this gene or there is a gene mutation, the chances of getting diabetes mellitus is less, 65% less. And similarly, the BMP8A genes, knockdown of the BMP8A genes in INS cell increases beta cell survival, decreased cytotoxicity, and the decreased apoptosis. So these two genes are the protective genes, and similarly many more genes may have an property effect which is to be identified. So how can this study can be translated into the functional or functional level? The functional and translational studies are there. The ADRA2A locus was recently identified in the type 2 diabetes mellitus risk locus, and this is the adrenergic alpha-2A genes. The variants of alpha-2 receptor genes are associated with the impaired insulin secretion as a consequence of increased expressions of ADRA2 receptor in the pancreatic cells. And you all know that this, if there is ADRA2 or is 2 genes expression is more, the chances of catecholamines level is more, and so the insulin secretion will be the less. A randomized clinical study was performed by blocking the 2-ARA by yohimbines, the ADRA2A antagonist. And when a plant alkaloid enhances the insulin secretion in type 2 patient with the RS553668 risk alleles. Means that if you can use this ADRA2A antagonist, you may get the beneficial effect in the insulin secretions. And this study shows that the insulin effect in patient carrying the ADRA2A genotype could be corrected by the AG8A2ARA antagonists. That is one step closer to the individualized, precise medicine. So if you study this genetic analysis and you can transport it, translate it into the precise medicine practice. You can see this study in the yohimbine dose-dependent increased insulin secretion in type 2 patients with risk variant. If the patient is having no risk, or if it is a heterogeneous group, or it is a homogeneous traits, you can see that the 20 milligram of yohimbine have a clear-cut increased insulin secretion in a homogeneous traits. So this particular study shows that if you can use the ADRA2A antagonist, that can increase your insulin level and maybe have protective effect on the diabetic patient. So this translation of this genetic information into clinical practice is very important, and that is why you use this genetic testing, and genetic testing in young relative type 2 patient carrying susceptible genetic variants, and assessment of validated at risk genetic variant on hypoglycemic drug response. The cardiometabolic represents a catalog of potential causal variants for analyzing the large cohort data of different ethnic origin and other metabolic conditions related to the type 2 diabetes mellitus, like the obesity and other disorder associated with this, with hypertension and dyslipidemia. This all it can be used in a diagnostic of metabolic disorder. These genetic variants with a validated cis or trans effect on gene expression and the circulating protein level can serve as a biomarker. That is very important, that can you use this protein level as a biomarker to diagnose whose patient may be able to develop diabetes mellitus in future. So the pre-existing drug targets such as the PPBR, a gamma or the SUR1 can be validated in that particular genetic analysis. So identification of the potential new target for the drug is also important. So to conclude my talk, I know that the genetic is a bit difficult for me, maybe for you also. But advances in the newer genetic technology had discovered more than 120 common variants contributing to the risk of type 2 diabetes mellitus. The genetic landscape of the type 2 diabetes mellitus certainly is yet incomplete. Many of the patients, if you can see that there is a 40 to 40% of the patient may have, but if you genetic eligibility in the populations. So we are our study is yet incomplete, and many more studies are still going on. And dissecting the architecture of type 2 diabetes mellitus has emerged in the form of genetic studies, meta-analysis, and the sequencing in the families. Current division of type 1 diabetes mellitus and type 2 diabetes mellitus is probably not appropriate. More precision subdivision into subgroup may facilitate the investigation of type 2 genetics, pave the way of individualized treatment. We still have to look for technological improvement which will lead us to better diagnosis and therapeutic tools or even cure of the disease. Thank you very much for your patient hearing.
Thank you, Dr. Singh, for giving a very interesting and very informative information on genetics, because which normally we don't concentrate much on that one. But in a general population, whichever the diabetic who come, you ask whether your parents are diabetic. Most of them, they say they are. It may be in a different ages. It is. Now the genetic portion is getting advanced. As you show there, a day may come, they may think of curing the disease. But my another question is, see, Yohambine was used more than 30, 40 years back as an aphrodisiac drug.
The Yohambine is usually a plant alkaloid used in the aphrodisiac patients to increase the sexual life or anything else. But later on it was developed that if you use in a diabetic patient, the patient may have a better control. That's why the Yohambine comes to the action, and later then this ADRA2 alpha gene was identified, and it was correlated with that particular group. So that will lead to the translation that the Yohambine can be act as an anti-diabetic drug, or it is a drug that can increase the insulin secretions.
Congratulate you for having given a very nice subject, very easily and understandable. Thank you.
Any questions from the audience?
Sir, do you have any Indian studies with regard to genetic studies with regard to type 2 diabetes? And in Indians, which is the most common genetic genes associated with type 2 diabetes?
I exactly don't know whether any studies are going or not, but the most diabetic center have some studies regarding the type 2 diabetes mellitus. But many of this genetic analysis on the monogenic form of diabetes mellitus. But I don't think, because the GAWAS study is mainly going on Sweden and the Norway countries, and they are more pioneer in developing, because gene mapping is needed. We all know that the TCF7L2 gene is quite frequent in our population also. So that is the most important gene. But exactly the gene mapping in the certain geographical area or certain ethnic group, I don't think any study from India is yet come.
Thank you.
Sir, thank you, sir. That is a wonderful talk and a very complex subject. I have got a very basic question, simple question. See, there are two things. One is the genetic predisposition on one side and the lifestyle modification on the other side, both fighting in opposite directions. The genetic predisposition trying to push the person to diabetes, and lifestyle modification trying to prevent him from becoming a diabetes. So the battle always continues. My point is, if there is because the genetic predisposition is non-modifiable, we cannot change genetic predisposition, whereas lifestyle modification is in our hands. My basic question is, if there is a good lifestyle modification, can we beat the genetic predisposition and escape from diabetes?
Yes, definitely, sir. The lifestyle modification or the modifiable risk factor is very important. That is in your hand. If you are in a risky person or you have a risk, but there is something is going on, and there is a study are going on. We have last seen in the Delhi conference that this astronomy or the is correlating with this disease factor. There is a studies going on something to that.
Sir, can I take this?
Yes.
So my name is Vinay Dhandania, sir. This is a really very interesting question. Why we are talking about genetics in type 2 diabetes is basically for precision medicine. If you know that this gentleman is having this genetic defect and is going to have a medicine which is going to be very, very appropriate for him, is going to be very, very helpful in the future. Like we pick up a monogenic diabetes, someone who has been treated like a type 2 diabetic, also having a family history in 3 different stages. And you pick them up and you know that sulfonylurea is going to be the drug of choice for monogenic diabetes. So that is where the role of genetics comes into picture. And lifestyle modification has definitely a very proven role. We had this DPP study, Diabetes Prevention Program study in US. We had Indian Prevention Program in India for type 2 diabetics, where they picked up high-risk populations. Like Sir clearly demonstrated that if my father is a diabetic, my chance of getting type 2 diabetes is 15%. But if both the parents are diabetic, my chance of getting diabetes is 70%, isn't it? But if I am put on a very good lifestyle measures from the very beginning, after knowing this genetic risk, probably I'll prevent the onset of diabetes by 60%. And if at all not preventing diabetes, I may even delay the onset of diabetes by probably 20 years. So a person who is going to get a diabetes at the age of 30 will get a diabetes at the age of 50. So that is another advantage of putting them on lifestyle. So only if you know genetics of diabetes, you can actually tell your patients, suppose that both the couples come to your clinic, sir, we both are diabetics. There are many a times they both come for consultation, isn't it? Now, treat them, but also tell them that your children are at very high risk. Take care of them. That is what is going to be very, very helpful in near future when you are talking about genetics and prevention of diabetes.
Thank you, sir.
Thank you.
One thing I want to, Dr. Binay, you have raised point nicely. I want to say something regarding this, that the lifestyle, many of the patients, many obese patients does not develop diabetes. Why? If you can see that, if you can analyze the genetic analysis, there may be have a protective gene in that particular group of patient. So there is definitely the genetic factor and the lifestyle is the environmental factor, both are important. But if you are not exposed in genetically, you may not develop the diabetes in near future. So that is more important. One of the important point is that only patient, those who are genetically susceptible, is chances of getting diabetes. So that will be further validated by the gene mapping. But here is a point that very subset of patient, many have many obese patient, many of the hypertensive, but doesn't develop that. Why? That is the question in your mind. That will indicate that the genetic factor is also very important. Thank you.
Thank you for this informative session, sir. I request the organizing chairperson of this event, Dr. Aravind Jagdish, and the chairperson to felicitate the speaker. I also request Dr. Aravind Jagdish to present the mementos to the chairperson. Moving forward, our next chairperson is Dr. Kannan Natarajan, diabetologist from Apollo Clinic, Chennai. We welcome you, sir. Along with him, we also have Dr. Vinay K, Secretary, RSSDI, Jharkhand State, and Consultant in Diabetes at NMMSS and Orchid Medical Center, Ranchi. We welcome you, sir.
So it was a wonderful talk by our Dr. B.K. Singh on the tough area of genes. I thank Aravinda and the ADC organizing team for giving me the great opportunity. So dear friends, now we have the important session which is relevant in our clinical practice on issues. See, in a real world clinical practice, our day starts with issues and our day ends with issues. Even though there are a lot of clinical evidences on issues behind with Wikipedias, we have TOSCO IT, we have guide trial. More than that, we have advanced also. Recently, the issues proved the benefit on cardiovascular outcomes regarding with the Carolina and compared with linagliptin. Linagliptin has the heart failure signaling by 1.28, but there are no any signaling with glimepiride. Still, but we have some inertia over the initiation of issues because there is the incidence of hypoglycemia, weight gain, and so on, so forth challenging. We don't know about the cardiovascular burden also with issues. Our aim to have the potential HbA1c control, that is a molecule, but among the molecule, which molecule we have to prefer and which molecule we have to write. So among the black swan, which is green swan among the issues, that we have to enlighten by our own, my dear Aravinda. I don't know, there are no need for any special introduction for him. He's a single man army with multiple faces, multiple hands. We can be easily utilized by Aravinda. It's a great pleasure and honor to invite Aravinda to give on this esteemed talk. Welcome, Aravinda.
Can we have a big round of applause for Dr. Aravinda?
Thank you, everybody. At the outset, I would like to say that Saturday morning, fourth Saturday, being a holiday, it's all, that too, that swearing in is going on nearby in Rajbhavan also. In spite of this traffic congestion and all those things, it's heartening to see interested academician coming and attending our conference. Thanks to one and all. So my talk is on interesting topic, that is modern sulfonylureas and metformin, the green swan of OADs. So the wording is so good, the green swan of OADs, because this is the one molecule which we are using since past 3-4 decades, and we are very happy with this molecule. So what does the latest data says about this green swan? So preface to sulfonylurea, if you take, sulfonylureas have been used for several decades for diabetes therapy, but certain factors have rendered this class of drug a subject of controversy. In this context, modern sulfonylureas such as glimepiride have emerged as a potentially safe and effective candidates for both monotherapy and combination therapy with other anti-diabetic drugs such as metformin. Several clinical studies have now validated the beneficial effects of glimepiride. That is what we have to keep it in mind. A few such studies have also established glimepiride as a relatively more potent anti-diabetic drug versus other sulfonylureas. So is there a green swan in type 2 diabetes management in India where economy plays an important role? Definitely yes. So if you take the green journey of sulfonylureas since 1946, like almost you can say from 1947, since our independence, so this is there. You can see from 1940 to the various pathways of sulfonylureas innovation going on from 1946 up to the latest on the extreme right-hand side. You can see the 2023, that the JADE study. You can see the sulfonylureas, glimepiride plays an important role in the management of type 2 diabetes. We have a robust experience and evidence of evergreen sulfonylureas in the current era of newer glucose-lowering drugs. Like you see, if you see this PubMed search, that is the National Library of Medicine, when you type sulfonylureas, you get 25,968 results. That much amount of popularity it has got. It is second best published literature evidence on oral glucose lowering drugs on the PubMed. So which is the first one? Obviously, nothing to beat. Insulin is the first choice. Next, modern sulfonylureas is a green swan of OADs. Why? It has got a robust experience and evidence with aging gracefully because of its elegance, guiding light. Modern sulfonylureas usage continues to lead in India as well as globally across type 2 diabetes continuum. The flexibility of prescribing along with other AHAs, including insulin, incredible speed, like earlier, greater and durable glycemic control, trust of more than 1 lakh doctors in India, safety, efficacy, affordable, available and appropriate. molecule across type 2 diabetes continuum, it gracefully works across the type 2 diabetes continuum. So the modern sulfonylurea is the green evidences from India. You can see the various articles from JAPI, Curious, 2020, 2021, 22. There are so many articles published with regards to sulfonylurea's role in the management of type 2 diabetes. So we can't say that sulfonylurea is outdated, it is going away from the treatment armamentarium, never. Even if you see the ADA, ACA, ACE guideline, still the sulfonylurea has a role to play in the management. So another, you can see the further evidences in India, like in IgEM 2015, in 2017, 2018, 19. So there's so many published data. Even in 2022 also, you are having the data we are seeing it here. So the global green side of modern sulfonylureas control glycemic levels, reduce macro and microvascular complication. They are safe, highly accessible, affordable, and have high patient acceptability. Sulfonylureas continue to be supported by robust, long-standing evidence. Sulfonylurea has many important attributes and remains as an important OAD, especially in the global context of a limited resource. So modern sulfonylureas is going green globally. This is evidenced by JADE study. So sulfonylureas are popular oral glucose-lowering drugs, class often combined with metformin, good glycemic control, and safety profile associated with the use of sulfonylureas support their position as a key treatment option in patients with type 2 diabetes. So the green wall of evidence, safety of modern sulfonylureas, you can see here the cardiovascular safety. They often questioned about sulfonylureas, the cardiovascular safety. So this should not be no longer be a concern when choosing sulfonylurea, especially glimepiride for people with type 2 diabetes. You can see the various studies supporting it, like Carolina trial, which showed the sulfonylureas are non-inferior when it comes to cardiovascular safety when compared to linagliptin. So there are so many studies like SAFE study, then articles published in Glucocrinology of modern sulfonylureas, Tosca-IT study. All this shows the beneficial effect of sulfonylurea. The latest shade of green, that is the CV safety, it significantly lowers the all-cause mortality, cardiovascular mortality, and number of hospitalization and emergency visits for heart failure and hospitalization for acute myocardial infarction or stroke with glimepiride. The long-term continuous glimepiride use is associated with a better survival, fewer hospitalization, and emergency visits for heart failure. So the high dose of sulfonylurea, usually like up to 2 to 4 milligrams per day, is associated with a lower cardiovascular mortality. So this American Diabetic Association statement, the cardiovascular safety in type 2 diabetes with sulfonylurea as the second-line drugs, you can see on the right-hand side bottom, the second-line sulfonylureas for glucose lowering are unlikely to increase the CV risk or all-cause mortality. Sulfonylureas are cost-effective and have widespread use, should remain as a part of the global diabetes treatment portfolio. The pleiotropic benefit, it's a well-established shades of green. It's got a immunomodulatory, anti-inflammatory effects, like modern sulfonylurea exert antioxidative, it exerts anti-inflammatory effects by decreasing high-sensitivity CRP, interleukin-6, interleukin-34, and TNF-alpha levels. Glimepiride improves the insulin sensitivity, increases the glycogen synthesis, and inhibits gluconeogenesis. On the right-hand side, you can see the emerging shades of greens. It increases the adiponectin levels, increases the testosterone level. It decreases triglycerides, total cholesterol, and LDL. It decreases the VEGF. So all this, what this shows is the newer studies only emphasize the safety of sulfonylureas, which we are using since past 2 to 3 decades. So this is an interesting study. That is a comparative study of DAPA versus glimepiride effect on insulin-regulated aminopeptidases and interleukin-34 in patients with type 2 diabetes. You can see on the bottom the conclusion of the study, the both glimepiride or dapagliflozin significantly improved glycemic control, insulin resistance, with no significant difference between them in type 2 diabetes patients. However, dapagliflozin has a borderline significant effect on IRP and did not affect interleukin 34 significantly, while glimepiride has a significant effect on interleukin 34 but not on IRAP. IRAP is insulin-regulated aminopeptidases. Since both drugs have improved the levels of NT-proBNP, they can be recommended for diabetic patients who are at high risk for developing cardiovascular disease. So modern sulfonylurea is flexible with other oral hypoglycemic drugs. You can see, starting from 1, it can be used in comorbid condition. Modern sulfonylureas are preferred over the conventional sulfonylureas in patients with diabetes and cardiovascular disease. It can be used in newly diagnosed and long-standing disease. It can be used in special population. It can be used in Ramadan as well. In overweight and obese patients also. In monogenic diabetes, especially in MODY 1, 4, and 3, and even in type 2 diabetic patient over 90 years also, there are few studies which show if you use it carefully, it can be managed well. So modern sulfonylurea, you can see the co-usages with other AHAs, like you can be used with glitazone, alpha-glucosidase inhibitors, SGLT2 inhibitors, DPP4 inhibitors, as well as with insulin, taking care the patient doesn't go to hypoglycemia by reducing the dosage of insulin. So the efficacy of evergreen modern sulfonylurea is a review article you can see here with the clinical evidence and practice-based guidelines on the utility of basal insulin combined oral therapy in the current era. The glimepiride plus metformin combination shows synergistic action in terms of glycemic control and better safety profile by reducing hypoglycemia, weight gain, and cardiovascular safety compared to the older generation sulfonylureas. Combining basal insulins to oral therapy appears to be effective in improving glycemic control and lowers insulin dose requirement, injection frequency, and hypoglycemia event. So the emerging green, the modern sulfonylureas in the management of MODY, you can see it is a response to the HNF1A and HNF4A and ABCC8, MODY respond well to sulfonylurea. So this is where the sulfonylurea has a role to play in MODY as well. So this is another article, another paper sharing about the position of sulfonylureas in the current era, the review of national and international guidelines. You can see here this article from Vishwanath Mohan. The sulfonylureas continues to play a vital role in the management of type 2 diabetes. Majority of the international and national guidelines reviewed suggest newer sulfonylurea as the second line therapy for treatment of people with type 2 diabetes. So emerging power of green, global and region guidance, whether international guidelines have snubbed sulfonylureas? No, they have not snubbed at all. You can see the various guidelines suggesting to use the sulfonylureas appropriately according to the patient need by ADA, IDF, ISPAD, NICE, WHO, EASD, and even in ACE. Even in Canada, Colombia, Australia, Nigeria, Uganda, Middle East, China, Korea, Singapore, of course in India, Austria. In all these countries, still they say the use of sulfonylurea is going to be there in the management of type 2 diabetes. You can see the further countries. So nearly 22 to 23 countries say that sulfonylurea is still there. So the 7 shades of modern sulfonylureas is the sweeping experience, sufficiently available, sublimely affordable, supremely effective, safety proven CV safe, splendidly acceptable, and surpassingly researched. So we must never forget 80% of the people with diabetes live in lower middle income countries. We need medication. Those are effective, affordable, available, acceptable, and minimum adverse event. So modern sulfonylurea, glimepiride has a definite role to play in our clinical practice. I'm sure in this hall, all of us are using sulfonylureas in our day-to-day practice. So this is where the modern sulfonylureas plays an important role, which should not be forgotten with the advent of newer molecules. So the modern sulfonylurea is this green swan of OADs because of various aspects as shown in the previous slide. So let's take a small step towards making the change. So go green planet. Thank you for your patience hearing.
Thank you, Dr. Aravinda, for that excellent presentation. And we all know that sulfonylurea, along with metformin, is the backbone of our clinical practice in type 2 diabetic patients. So we can have any questions.
Aravinda, it was a wonderful talk, and again the whole clinical insight, entire journey of your issues, especially focusing more on glimepiride. So I have a small doubt, Aravinda. See, in this modern era, we have been using third generation issues like glycoside and glimepiride. But if you see regarding with the ischemic precondition, one of the important pleiotropic benefit that may be attributed by glycoside glimepiride. But there are certain data. Glycoside scores over glimepiride on ischemic precondition. What is your take home on that?
Yeah, see, that is the commonest question always asked when it comes to modern sulfonylurea, whether to use glycoside or glimepiride. So until now, before the Carolina studies, we had data showing glycoside scoring over glimepiride. But after the Carolina study, when it was done actually to show the superiority of linagliptin, it was a blessing in disguise for the glimepiride. So glimepiride was shown non-inferior. So since then, the glimepiride is considered to be equally safe according to when compared to glycoside as well.
Thank you, Aravinda.
You are the successful captain of the one-man army. Very successful. Fighting against diabetes and educating all the doctors, you are doing a wonderful job, but a big thanks to you. I have a small question. See, all these decades, the last few decades, sulfonylureas, to start with glibenclamide, and then of course the glimepiride was enjoying the major share in the market. It was number 2 molecule, next only to metformin. Now the other molecules like DPP4 and SGLT2, all the other new entrants have made their name and they have taken a bite of the glimepiride share and they have made their market. And in the process, they have pushed this glimepiride from 2nd position to 3rd, 4th, or 5th position. It is pushed to the back seat, and these DPP4 and SGLT2 have come to the forefront and they have occupied the 2nd position after metformin. My question to you is, where exactly you put it? Metformin, glimepiride, DPP4, SGLT2, 1, 2, 3, 4. Where do you place it?
So that's a very apt question. So that is a very practical question in our day-to-day practice. So if you see the various guidelines, so if you take the ADA guidelines, if you take the ACE guidelines, or if you take our RSSDI guidelines, in all these things, what they say is first is the lifestyle modification, next comes the metformin, then after metformin, so they have given the various parameters because DPP4 inhibitors, SGLT2 inhibitors, they are wonderful molecule. Nothing to deny on that because we have got a sufficient data. So when it comes to ASCVD risk factors or when it comes to CKD risk is there, use them appropriately, comfortably. When it comes to cost effectiveness, when it comes to robustness of reducing the HbA1c, definitely sulfonylureas plays an important role. But as we all see in our day-to-day practice, when the HbA1c is more than 8 or 8.5 and we want the sugar to be reduced fast, either we think of insulin. If not insulin, the next question we'll always think of sulfonylureas. So it is a clinical judgment where you want to use. Because ADA, ACE guidelines are all the guidelines which says it gives a guide to the treating doctor. But ultimately it's left to the treating physician where to use it appropriately. So you use it, like if a 30-year-old gentleman comes to you where HbA1c of 8.5, no cardiovascular risk, nothing, no CKD risk is not there, definitely the drug of choice would be after metformin is sulfonylureas. So like that, the appropriate use is needed. It doesn't mean the newer molecule has come and sulfonylurea is snubbed. Sulfonylurea is going to stay in the treatment armamentarium. It is going to be treated because we have the robust experience of using since past 3 to 4 decades. So that is where the green swan of sulfonylureas, it will be there in the management of type 2 diabetes.
Aravind, in your clinical practice, what is the maximum dose of glimepiride you've been using? The why I'm asking this question is I've seen physicians using up to 12 plus mg as well, cross prescription. I don't think so. After 8 mg, there is no benefit out of that. So what is the say on this?
Very good question, Dr. Kirti. Only thing is the dosage recommended is up to 4 milligrams, definitely it will work well. Up to 8 milligrams, you can still go. After 8 milligrams is not recommended. So 4 to 8 milligrams, up to 8 milligrams.
Exactly.
Yeah. Apart from 8 milligrams, you can see some 4 milligrams TID. It will be there. So 12 milligrams, you're just pushing for the beta cell to work more. It may be not possible at all.
And after the GRADE study, do you think that there will be any change in this usage of sulfonylurea?
Yeah, it will be. It should be an important thing, but definitely it will be make a change. But using it will be a challenge always.
Yeah, and as you discussed, even the dosage. Some people write 1 TID, I don't know, 4 mg TID or even 2 mg TID. Of course.
That might be what I always, when I see the prescription, I always feel that is because of the peer pressure from the patient. Don't put me insulin at any cost. So they put the 12 milligram of glimmer. That doesn't work.
What's your comment? Actually, the sulfonylurea works better in the acidic media and metformin in the basic media. So this combination of sulfonylurea and metformin.
So both of them as a mutual synergistic action, since we are seeing since several decades. So it continues to adjust them accordingly, and it has been clinically resulted. We are seeing it.
Yes, exactly.
So I still remember the textbook says 2.5 milligram of glibenclamide is as good as 7.5 if it is given 30 minutes before a meal. So the efficacy of sulfonylurea multiplies 3 times if it has been given in acidic media, as you rightly said. Similarly, initially to start with metformin, you can start with meals or after meals because of the GI intolerance. But once the patient starts tolerating it, even before giving a meal, the metformin does much better off. So the only tricky thing is from day one, don't start a fixed dose combination. But once the patient has settled down with the shift in the molecules, later on you can start the fixed dose.
To avoid gastropathy, diabetic gastropathy.
One thing I can tell you that we keep quoting UK PDS studies, isn't it? Left and right, there is no presentation without the UK PDS data. And if you see how the UK PDS study has been done, in a newly diagnosed type 2 diabetic patients, they're randomized into 3 arms, metformin, sulfonylurea, and insulin. And in spite of starting on things like chlorpropamide, then shifting to glibenclamide as a sulfonylurea, then metformin, and the simple insulin, the human insulins, they could not suggest anywhere that there was something like increase in beta cell deterioration with the sulfonylurea arm, or there was a beta cell preservation with the metformin arm or with the insulin arm. Meaning to say it's the disease which is there, and even by using drugs like sulfonylurea, metformin, and insulin in the initial stages of disease, you can prevent the progression of disease as well as you can reduce the onset of complications in type 2 diabetes. The important thing is you need to have a good glycemic control at the end of the day. Pushing medicine doesn't help. You need to have an HbA1c less than 7%. And if you add on things like controlling blood pressure and lipids, you are going to have additional advantages which you haven't seen in UK PDS.
Thank you.
Thank you very much, sir. And I would like to wish you congratulations because you're indeed a one-man army like everybody says here. To put up the show like this, it's definitely not easy and you deserve all this success. Congratulations, Dr. Aravind Jagdish. Thank you, sir. Moving on to our next session, we have our first chairman, Dr. Syed A. Javas, diabetologist, Diascope Multi-Specialty Healthcare, Bengaluru, and the second chairperson, Dr. B.M. Suraj, diabetologist, Mallige Medical Center, Bengaluru. We welcome you, sir.
welcome Dr. Basuraj. His topic is evidence to practice, the practical subject. Evidence to practice clinical perspective of diabetes management with the new generation insulins. To introduce Dr. Basuraj, an endocrinologist from Narayana Multi-Speciality Hospital, Bangalore. And without much wasting the time, this personality is such that Basuraj knows everyone, his background. He's a very good endocrinologist, heading the Department of Endocrinology at Narayana. I request him to please go ahead with his subject.
Thank you, esteemed chairpersons. Thank you, Dr. Aravinda and ADC for giving me this privileged opportunity to stand in front of you and put out our thoughts on the quintessential element of the management of diabetes, the insulin. Dr. Aravinda has set up a very good stage for me. Sulfonylureas. Okay, we have always been discussing about metformin. I hope the first metformin talk and we all understand. Then comes sulfonylureas and then comes the insulin. So he talked of the green swan, but I bleed blue. So the insulin comes in here. We all understand, we all as a part of humanity are grateful to Banting, Best and Collip to have given the patent of insulin for $1 each. That was on the 23rd of January 1923. Following that, insulin has saved so many millions of lives for people management with type 1 diabetes. Similarly, as science proceeds, as science progresses with newer innovations, newer discoveries, newer inventions, there have been more modern sulfonylureas, more newer class of drugs for the management of diabetes, and also more newer insulin for us to use in our patients with diabetes. So what I'll be discussing in the next couple of 10-15 minutes is try to understand from evidence to practice. So that's my financial disclosure. So now the newer generation of insulin, we understand that there are these bolus insulins and there are these basal insulins. So with this, I'll be covering on two major of the insulins, the ultra-long basal insulin, the digludec and the co-formulations of digludec and aspart. So let's start with the ultra-long basal insulin. Insulin digludec, we understand, has got a very unique mode of protraction, providing longer duration of action and better predictability. Digludec per se has got a diaxa formation, which is admixed with phenol and zinc. Dissociation of phenol leads to resulting multi-hexamer chain formations. Then zinc dissolves in, slowly causing individual hexamers to disassemble, releasing dimers and then monomers are absorbed from the soluble depot into the circulation. So digludec, we have got a plethora of data which is available, which has consistently proven the hypoglycemic benefits across the BEGIN trial, the SWITCH trial, DEVOTE trials of more than 16,000 patients. BEGIN and SWITCH 2 were smaller trials, phase 3 and phase 3B, whereas CVOT trial of DEVOTE, which is roughly to the tune of 6,500 patients, CVOT, which showed that there was a 53% relative risk reduction of hypoglycemias nocturnal and 40% RRR, relative risk reduction of severe hypoglycemias. EU treat type 2 diabetes was a real world evidence from European states, where they also had data of type 1 diabetes patients, roughly around 1,500 and 800 plus patients of type 2 diabetes. They showed that in real world caused a decreased overall risk of hypoglycemias. Now there are certain of PKPD studies done in type 1 diabetes patients. If you see on the left hand side is the proportion of the area under the curve, glucose infusion rate. The amount of the glucose which needs to be infused after a stable steady state plasma concentration has been achieved during the study. So that is what it means. So now if you see digludec versus glargine in these 22 type 1 diabetes patients, we could see that there was a better round-the-clock coverage with digludec versus that of glargine U100, when glargine U100 required almost 60% in the initial 12 hours, and later on it did decrease. That means there was higher variability with that of glargine as compared to that of digludec. Digludec also has a lower day-to-day variability versus glargine, amounting to the tune of 62% relative risk of variability reduction of glargine 100 versus digludec. So this is the switch pro RCT, wherein patients were switched from Lantus to that of your Digludec. What happened? They had, all of these patients were elderly patients, had more than one hypoglycemic risk factors, roughly around 1,500 patients. What they saw, this was again a CGM-based evidence. So what this CGM-based study told that overall 20 minutes per day was the extra time which was available with the usage of Digludec within time in range, that is between 90 to 180, which was selected here. And when it comes to the safety parameters, your hypoglycemic parameters, the level 1 hypoglycemias were lesser to the tune of almost 8.5 to 9 minutes in the day, and level 2 of nocturnal hypoglycemias of almost 4+ minutes in a day. So we all understand about the adverse cardiovascular effects of the, not just the lower levels of the hypoglycemia, but also the duration of the hypoglycemia. Longer the duration of the hypoglycemia event, more is the cardiovascular adversity, which is again related to prolongation of QT interval, arrhythmias, and so on and so forth. So overall, there was a 12.7 minutes of excess reduction in the time below range. Hence, telling that probably Digludec gave a better TIR and better nocturnal TBR with Digludec versus Glazine. So then again, there's a confirmed study, real-world evidence of used data set of patients which told us that there was a 30% lower rates of hypoglycemia with Digludec versus Glazine U300, and the change in the proportion of patients experiencing more than one episode of hypoglycemia was significantly lower with Digludec versus Glazine U100. So insulin Digludec has shown a significantly lower risk of hypoglycemia versus Glazine U100 in evidence from the real world practice. Digludec lower within day variability versus Glazine U300. Again, a type 1 diabetes patient doing a PKPD study, same AUC-GIR, glucose was infused. Then they saw that probably it was a better GIR, glucose infusion rate, with that of the Digludec as compared to that of Glazine U300. Lower day-to-day glycemic variability. You can see that the variability in this study was higher with that of Glazine U300 versus that of Digludec. So Digludec is also more potent. This we all understand with all of our practical experience, that versus Glazine U300 might require a slightly higher dose to control the same level of euglycemia, or rather controlling the fasting glucose. Dose with Glazine U300 has a slightly 20 to 30% higher requirement as compared to that of Digludec. Again, similar kind of a thing was again given by this statistical model depending on the AUC-GIR, where almost 30% better potency was seen with Digludec. So again, same bright study, it was seen that it was a lower dose requirement with Digludec as compared to that of Glazine U300, and better FPG control with Digludec. So see, in the same lines, we also understand that our own RSSDI clinical practice recommendations do mention that both are almost similar with terms of Glazine U300 versus Digludec, are almost similar in terms of action. Both are good potent basal analogs, but Glazine U300 requires a slightly higher dose of insulin requirement to control the same level of sugars. Because of the flexibility which Digludec gives, there's a better adherence with Digludec as compared to that of other basal insulin analogs. It gives a tremendous flexibility of using it in difficult type 1 patients, juvenile patients, in very busy patients. It gives you a tremendous flexibility of taking the insulin according to their will and wish. So there was a significant 27% higher number of patients who were on Digludec as compared to that of any other basal insulin. So in short, ideal basal insulin has to be flat, peakless activity profile, minimizing the risk of hypoglycemic events, longer duration of action, allowing flexibility, and then minimum variability. So most of the parameters are being taken care by Digludec. So then going on to the co-formulations, IDEC aspart, we understand it's the world's only co-formulation insulin which is available with a combination of 70% Digludec and 30% rapid-acting aspart. The two insulin components do not interact within the solution and in the subcutaneous tissue, thereby retaining their individual properties. So we understand once daily IDAG-Aspart. This is again a very interesting study done in type 1 diabetes patients wherein they had used degludec and aspart initially for 5 days to achieve the steady state plasma concentration, and then PKPD were looked on by giving once IDAG-Aspart, and then they looked at the glucose infusion rate, almost in a similar kind to take up. So it did show that IDAG-Aspart had a good basal coverage plus a bolus coverage also. So it gives a tremendous, again, flexibility depending on the lifestyle to use it according to the meal pattern, whichever the patient with diabetes or the people with diabetes tend to choose. I have a breakfast which is heavier, I take it in the breakfast. I have a lunch which is heavier, so probably then my prandial and the basal component is taken care by this. So again, some of these Indian data from IDAG-Aspart, ARISE India study, adults with type 2 diabetes, 185 of them, and IDAG-Aspart as per the local practice, so almost 43% of them received once daily versus 56% of them received twice daily. The change in HbA1c from baseline was looked at. The mean change in HbA1c was 1.6%. Change in fasting plasma glucose was 52.2 milligram per deciliter, and the mean at AUS was 140 as compared to 190 milligram per deciliter at baseline. So the reduction in hypoglycemic episodes, the global cohort of the ARISE data. So this, the left-hand side, the table which you see, the bar diagram which you see, was the number of hypoglycemic events which occurred 4 weeks prior to initiation of IDAG-Aspart. And the lighter blue was the number of hypoglycemic episodes within the last 4 weeks at the end of the study. So there was again a very statistically significant reduction in number of non-severe hypoglycemic episodes, and also the severe hypoglycemic episodes were also better with IDAG-Aspart. So treatment with IDAG-Aspart resulted in a lower number of non-severe and severe hypoglycemic episodes. Again, impact on the quality of life and the treatment preference. Single center survey done in adult type 2 diabetes with IDAG-Aspart. Again, an Indian study wherein 95% of the people manage their day-to-day activities better after IDAG-Aspart initiation. 90% of them had better QOL with reduction in number of pricks. 87% of them found it comfortable to inject IDAG-Aspart in different social situations. So that gives us a tremendous confidence on the IDAG-Aspart here. So reduction in the pill burden. Many of our patients are worried, sir, how many pills do I take? I've got a fistful of medicines, especially the ones who are having cardiovascular diseases. The kinds of one which I see at Narayana are the same ones. So in them, discussing about the insulin options, various insulin options, including IDAG-Aspart, is a good option. So 70% of patients on 3 OADs could be shifted to 1 or 2 OADs because of the better glycemic control, and 50% on 2 OADs a day were shifted to 1 OAD a day. So reduction in the pill burden with IDAG-Aspart initiation was seen in majority. Cost effectiveness, this is again a perspective which the estimated cost and the estimated cost of IDAG-Aspart again depends again on the kind of practice, the kind of patients we see. You can probably pick up your choice. IDAG-Aspart, a prudent choice for Indian scenario because of the lower hypoglycemic risk, mealtime flexibility, simple regimen, convenience of the device, and better quality of life, cost effectiveness, reduced pill burden, glycemic control, and so on and so forth, with also improvement in the glycemic parameters. With this, some questions will be taken.
Thank you, Dr. Basavaraj. That was a good presentation. I think, as you clearly mentioned, probably insulin, long-acting insulin, which contains both basal and bolus. Probably, I think it is, we as a clinicians probably should encourage our patients to go on to, if required, probably the insulin along with OHAs. Probably, and we take a lot of complications will be taken. Thank you for that presentation.
Absolutely.
Any questions?
Dr. Basavaraj, hi. Aspart combination, the Rhizodec that we use. With this combination, the twice daily dosing is something that is difficult to comprehend for us as physicians based on the longevity of action of the degludec component. How would you get yourself convinced and convince the audience to make sure that this is a molecule that we could use, though typically speaking it lasts for 24 to 36 hours, you still can probably use it twice daily and not have this peaking of effects of the degludec component?
Yeah.
Throw some light on this.
Sure. Personally speaking, even I'm not in very much favor to pick up the twice daily. But in some patients who have got twice two pickings where the sugars go up on two different items, so there we usually tend to see that people tend to give it. They're not wrong in doing so because degludec again doesn't have any stacking effects. So probably we are not worried about the hypoglycemic effects, which too much coming forward for twice degludec also. But be careful in up-titrating the dose of the insulin very carefully. But having said that, I would again prefer to stay on a once daily. If at all I use Rhizodec, it has to be once daily. I use it mostly once daily and not twice.
Yeah, and I think you're right in saying that if in case there are twice peaking, rather than using this combination, we could probably use a short-acting insulin during the second spike whenever we expect.
Yes.
And that would be a more rational combination
Absolutely.
than using this twice.
And that would give us a lot of flexibility also to adjust the dose of the second prandial insulin,
Right.
depending on the kind of the food, kind of the sugar levels. Titration would be a lot more easier by using a second prandial insulin, an analog or a regular insulin for that matter.
Absolutely.
So I think that would be more feasible or more practical, pragmatic than using Rhizodec twice.
Thank you. Thank you so much.
These co-formulations have 30% aspart and 70 been injected in the same proportion to the patient, 30%, 70%?
Yes, I think it gets dissolved uniformly.
It's not getting dissolved.
Okay.
This is what you said, right? That
No,
is
no.
what the science behind this co-formulation is. It's not getting dissolved. It's suspended in the co-formulation.
I think if it both are in the liquid matter of state.
So do you
then
think
there's
that every shot will have the same proportion of 30%,
Yes,
70%?
that is what
How
again
is
I
it
think.
possible?
That's what again has been proven in most
Exactly.
of
There
the
is no
PKPD
data to
studies.
support that. There is no data to support that every shot has the same 30%, 70%.
Okay. So there was
So
a
that
small
is why you have a better option of something like basal plus, where you give the short-acting insulin separately and a long-acting insulin separately. This actually co-formulation gives you a variability in postprandial glucose control. And we have couple of CGM data to actually support this as well.
Okay. So
Whenever you inject, it's not just possible, like every shot will have that 30% and 70%. There's no such science in that particular device.
correct, I understood, but a couple of a small PKPD study did show that there was not so much of variability.
So
So,
the PKPD
with
study
type 1
doesn't.
diabetes.
The PKPD study doesn't show that the spike is same with the same dose of injection all the time.
Yeah, that's again a study in a controlled environment. I understand, but practically, yeah.
So that is
if
what
you
I'm
would
saying.
have-
The basal plus is a better choice than this co-formulations.
Yeah.
So you can have aspart separately and degludec separately.
But then, yeah, I understand. But if the patient is again on your side of the table, trying to understand what you are trying to tell, but then again convincing someone with I'm not trying to justify here, but sometimes some tricky patients you tend to get that, doctor, only one insulin I'll take, and you need to cover up that prandial part also. Then I think
Do you think all the prandial will be covered by one shot of Rhizodec?
not all the prandials.
Exactly.
One prandial,
So
wherein
one
I'm
prandial
saying.
doesn't solve your problem.
Yeah, correct. It
So
again
you will
needs
need you will need another shots to control your
yeah,
prandials. isn't
definitely.
it?
It needs a lot of individualization.
Yeah, yeah,
definitely. Yes, as you have mentioned.
Thank you, sir. Thank you, Dr. Basura.
Thank you.
Dr. Aravind, thank you. I think next time probably we want a ADC guidelines.
Thank you for this wonderful session, sir. I request Dr. Aravind Jagdish and the chairperson to come over to the stage and felicitate the speaker. I request Dr. Aravind Jagdish to present the mementos to the chairperson. Thank you, sir. For the next session, I request Dr. Aravind Jagdish to take over.
So now we have got ADC oration. That is, Dr. My center is in Bangalore. We doing a healthcare institution specializing in the treatment and management of diabetes. We are organizing this every year. This conference is going on successfully with all your support and willingness to participate in an academic meet. As a part of this, we selected this ADC oration. Today we giving this ADC oration to none other than Dr. V. Mohan. Because of his time schedule, because of his busy committee, he is a chairman at Dr. Mohan. He is also a chairman of Madras Diabetic Research Foundation, deeply interested in research. He has published over 1,500 papers and thousands original articles. His research has attracted 180,000 citation and has H index of 140. And he is, can we have the recording please? Yeah.
Hello everyone. At the outset, I would like to convey my heartfelt thanks to my good friend, Dr. Aravinda, Chairman and Chief Diabetologist of Dr. Arvind's Diabetes Center in Bangalore, and the organizing committee of the annual ADC Summit. I've always admired Dr. Aravinda for his enthusiasm and the novel ways in which he does so many programs. And the annual ADC Summit is one example of that. I'm very grateful to you, Dr. Aravinda, for inviting me to talk on this subject of early GDM. What are the clinical implications? Normally, I don't speak on the subject of GDM at all, but recently we have been doing a lot of work in this field, particularly the later part of this talk when I talk about the recent publication in the New England Journal of Medicine, which we believe is going to be a game changer, which is the reason why I wanted to talk about this. Now, let me start with what is early GDM. GDM is usually diagnosed between 24 to 28 weeks of gestation, that is in the second trimester. But when it is diagnosed before 20 weeks, that is in the first trimester of pregnancy, it is called as early gestational diabetes or eGDM. This is not a topic which is often discussed in conferences, so I thought I will talk about this particular topic as it's going to gain a lot of importance, particularly in the Indian context. Now again, so that we are all on the same page, we can now divide, depending on when GDM is diagnosed, into two. cGDM or conventional GDM, which is diagnosed between 24 to 28 weeks, or you can say between 20 to 28 weeks of gestation, and early GDM, which is diagnosed before 20 weeks of gestation. And we'll get into the details as we go along. Now, how do you diagnose early GDM? In 2010, after the HAPO study was published, the IA-DPSG criteria was proposed for GDM. And in this criteria, the IA-DPSG proposed that in the first trimester of pregnancy, if the fasting plasma glucose is between 92 to 125, you know that 126 and above is overt diabetes. So somebody has 200 fasting in the first trimester of pregnancy, obviously diabetes complicating pregnancy. But if the value is below 92, they consider it as normal. But between 92 to 125 was considered as GDM. This is likely to undergo some revisions. I'll explain to you later on, but this is the current definition. Now, one of our PhD students, Hannah, took up the subject of early GDM or eGDM as part of her PhD thesis. Of course, that was based on a study called as a STRIDE study, and I'll come back to that. But this is Hannah's excellent systematic review, which she published in Acta Diabetologia a few months ago, where she looked at the entire literature on early GDM, and to my knowledge is one of the best review articles which has been published by Hannah and colleagues. And of course, we have Dr. Saravanan Ponusamy from University of Warwick, who is also among the authors. And we have Kevin McNamara, Vincent Versace, Eric Martin from the Deakin University. And they are all co-authors because they are all Hannah's PhD grades. Now, what did Hannah report? What she reported was that there are 58 studies which are screened for GDM before 28 weeks. And she tried to look at the prevalence of GDM, early GDM or eGDM reported in these studies. And surprisingly, she found that it varies from 0.7% to 36.8%. Such a huge variation because different diagnostic criteria were used in different studies. And therefore, they got this wide prevalence. Now, the risk factors for early GDM turned out to be some of the usual ones, of course: body mass index, previous history of GDM, family history of diabetes, multiparity, and so on. Now, in the same review, we also looked at the birth outcomes. And we found that if you had early GDM, macrosomia, cesarean delivery, induction of labor, hypertension, preterm delivery, shoulder dystocia, all that you see with the conventional GDM was also seen with the eGDM. Now, as far as the management is concerned, in the conventional GDM, you know that only about 15% or so need insulin. If you have early GDM, the need for insulin is actually much higher. And one more point which came out was, when the studies looked at what happens postpartum, how many of them develop diabetes, it looked as if the eGDM women had a higher incidence of conversion to diabetes after the delivery. So in this systematic review, the points that we made was that well, early GDM is definitely an entity, and this eGDM shows differences in clinical profile and adverse outcomes because it is more severe than the conventional GDM, more insulin resistant, higher blood pressure, triglyceride, perimetrial mortality is more, hypoglycemia is more, need for insulin is more. But having said all this, the literature has very confusing results because many of them are small studies, they have not used uniform criteria. So what we wrote in that systematic review is many more properly planned studies using definite criteria, prospectively done, have to be done. That is the conclusion of our paper. Now let me go on to talk to you about this study called as a STRIDE study. STRIDE is an Indo-UK study, and the full name of the STRIDE is Stratification of Risk in Early Pregnancy, and the full name of it is Ethnic Specific Risk Stratification Early Pregnancy. What it means is, can you screen somebody in the first trimester and predict who will get GDM in the second trimester? Because until then, only second trimester is considered as real GDM. So can you develop a kind of a risk score? Now, STRIDE is very important because one of the largest studies done on GDM, 3,000 women in the age group of 18 to 50 years were recruited. And look at the recruitment before 16 weeks of gestation. That means really at the time of booking itself, they were included. Now, the STRIDE investigators are shown here. So we have Saravanan Ponusamy from the University of Warwick. And of course, many of you know Dr. Umar Ram, who is our obstetrics colleague from the Sitapati Clinic in Chennai. Almost all our studies in GDM, it has been Dr. Umar Ram who's been a collaborator. And of course, you know Anjana and myself from MDRF. Now, apart from our centers in Chennai, we also had from Puducherry Jipmer as one of the collaborating sites. And we had other sites in Chennai like VHS, Andhra Mahila Sabha, EV Kalyani Medical Center. We also had the Fernandez hospitals, very large OG hospitals in Hyderabad. So you can see that 6 collaborating sites participated in this. So what we did was, we screened about 3,000 women, and if they had normal glucose tolerance according to IADP's criteria, they were NGT. Now, if they had in the first trimester, if they had fasting between 92 and 125 as shown here, they were called as early GDM. Now, among those who had normal fasting, we went on to do a GTT in the second trimester, as is normally recommended, and some of them turned out to have conventional GDM. So now you can see we have 3 groups. The NGT group, normal glucose tolerance group, 1,500 people, conventional GDM, 359 individuals, and the early GDM, 566 individuals. So fairly large numbers. This is one of the largest studies to compare the eGDM with the conventional GDM. So what did we find? Forget about the NGT. If you look at the conventional GDM and the eGDM, you'll find that the booking weight is higher in the eGDM BMI is higher, waist is higher, glucose values are higher, HbA1c is slightly higher. So it looked as if the eGDM had a worse metabolic profile than the conventional GDM. Maybe that's why they're getting it in the first trimester. Now we try to look at the risk factors for eGDM compared to the conventional GDM. In the original, the systematic review, we reviewed all the studies published. It's a kind of a hodgepodge. But this is a carefully done study from a few centers in India, and this Indian data. And you can see that the risk factors for eGDM were age, BMI, HbA1c, history of GDM in previous pregnancy, family history of diabetes, of which the first 3 or 4 turned out to be very important. So BMI, age, HbA1c is very important for diagnosing this. Now, you may say, what about this early GDM? When did we first propose that early GDM should be looked for? We can take pride in the fact that the Indian guidelines, even in the year 2006, almost 17 years ago, according to DIPSI, we have said that South Asians, that is Indians, are a very high ethnic group, and therefore all pregnant women must be screened for not only GDM, but to rule out overt diabetes also. In the first trimester, we normally screen to rule out overt diabetes, and then many turn out to be normal. But then we have this group in between, as I said, who have neither diabetes nor normal. They are the early GDM ones. So this guidelines that it has to be screened was there in 2006. But what is new now is what to do if you diagnose eGDM. That has never been done so far, and it's the first time in the world that such a thing is being done. And that is what TOBOGM is all about, the TOBOGM study. What is TOBOGM? TOBOGM stands for Treatment of Booking Gestational Diabetes Mellitus, so TOBOGM. Now, TOBOGM is the first multi-center RCT done in the whole world for diagnosis and treatment of hyperglycemia in pregnant women before 20 weeks gestation. That means in early pregnancy, as compared to 24 to 28 weeks. At 20 weeks or before, if you get it. And TOBOGM wanted to see what will happen if you treat these women. Okay, so it is a properly conducted RCT, which is the reason why it got published in the world's topmost journal, the New England Journal of Medicine. And I'm very happy that Dr. David Simmons and colleagues included me as a primary author in this. And we also have Dr. Umaram and Dr. Anjana also added as part of the TOBOGM research group. And this was published quite recently on May 5th, 2023. But ever since its publication, this paper has been really creating waves, because for the first time, how to diagnose early GDM and how to treat it in an RCT has been proven. That is what is new about this. Now, this is just showing you all the TOBOGM collaborators. We had 17 sites, of which 14 were in Australia itself. You know that Australia is where the HAPO study was done by David Simmons, and it's the same team which is doing this. So the same group which did the HAPO study, IAD, PhD, the same group is looking at the TOBOGM. But what happened was they also added Austria, you can see Vienna there. They also added Sweden here, and they added India. And we are very happy to be part of to represent India on this trial. And that is what is shown here. So we included singleton pregnancies without pre-existing diabetes. We took those with high risk factors, for example, BMI more than 30, past history of GDM, macrosomia in earlier pregnancies, so that there is a greater chance of recruiting these women. Since it is a study, we have to get a high pickup rate. Now, this is a very important slide, and I'll go through it for you. So what we did was we recruited these women before 20 weeks of gestation. And what we did here was we actually did, if they had either diabetes or pre-diabetes, they were excluded. If they had normal values, what we went and did was we did a GTT. Because the GTT, the IAD PhD criteria for the conventional GDM, we used here. Now, based on this, what we did was, of course, we had GDM women. About 800 GDM women were picked up, and the rest, of course, did not have GDM. These 800 GDM women were divided into two. One was the intervention group, where we treated them. The other 400 women were the control group. We didn't treat them. You may ask, isn't it unethical to diagnose them and not to treat them? No. I'll tell you why. Because there is no evidence that treating GDM in early pregnancy is useful. What if it produces harm? So that is why an RCT is done, and that's why it gets published in New England Journal. It's the first time in the world that such a thing is being done. So we had these 400 women. Now, even the women did not know that they had GDM. The physician treating also did not know that they had GDM, because the results were not given to them at all. Otherwise, it will contaminate the results and you won't get a proper study. We did something also very clever. We took another 800 women who did not have GDM and put them through the same protocol. Sometimes you get a placebo effect. If you just put somebody through a thing, you will get much better results. So these were called as decoys. It's a very clever move to include these 800 women who did not have GDM also. And the other 2,400 women, of course, we left them alone. They did not have GDM. So you have 4 groups here. One is the treatment group with 400 GDM, the control group of GDM whom we did not treat, 800 women who did not have GDM, but they just taken through the study as if they are part of the study, but we didn't do any intervention or anything for them. And then we had, of course, the non-active group where we did not do anything. What did we find? Now, this is the most important slide. We looked at first what is called as a primary composite outcome, which included preterm weight, birth weight, trauma, respiratory distress, need for phototherapy, shoulder dystocia, neonatal death, stillbirth, and so on. There was a significant reduction in the intervention group, 24.9% in the primary outcome, compared to the control arm, which is 30.5, and you can see that the relative risk reduction was 0.82. That means there was an 18% reduction in the primary composite outcome of those who were treated. And you can see that the confidence interval is from 0.68 to 0.98. It doesn't cross 1. Therefore, it is statistically significant. So for the first time, we are able to show that if you pick up women in the early GDM stage and treat them, they actually get benefit in terms of the primary outcomes. We also had some secondary outcomes, pregnancy-related hypertension, neonatal lean mass, not that we expected much difference there. And of course, there was no significant difference between the two groups. So the primary result is in the primary outcome. Now, we went further. You remember the blood sugar value at which we diagnosed is 92 to 125. Okay. So what we did was, we, of course, if it's above 110, we actually excluded them. So 92 to 110 fasting is what we had done. So we took one group, which is what's called as the low band GDM. That is 92 to 95, very, very mild GDM. And people even argue, is this really GDM or not? 92 to 93, does it become GDM? Okay, so we took that group. It's called low band. And then we took a high band from 96 to 108. Okay, and similarly at the 1 hour also we had 180 to 189 in the low band, above 190 in the high band, and in the 2 hour 153 to 160 in the low band, 160 to 198 in the high band. So essentially we are saying, if you divide them by severity of the GDM, is there any difference? And the results are shown here. If you look at the primary outcome in terms of, in comparison with the control group, those in the higher glycemic band, it was statistically significant. And look at the hazards ratio goes to 7.78. That means it is highly significant. Okay. So those in the higher glycemic band did much better. The lower glycemic band, they did also, some improvement was there, but it did not reach statistical significance. You can see it's crossing the midline. Now, one more point that we picked up through the toboggan study is that, you remember we took everyone below 20 weeks of gestation. We divided them again into those who were diagnosed before 14 weeks of gestation and those who were between 14 to 20 weeks of gestation. What we found was, if you diagnose them very early, before 14 weeks, they did much better and the results were much more significant compared to those whom you diagnosed late. Again saying that the earlier you diagnose the eGDM, it is better. So what are the new findings from toboggan as far as GDM? It provides proof of benefit for treating eGDM. Beneficial effect of treatment in early GDM is demonstrated in RCT for the first time. Results are more significant in those in the higher glycemic band and those screened before 14 weeks of pregnancy. So these are, ladies and gentlemen, are my take-home messages about early GDM. Early pregnancy blood glucose screening is mandatory even before 14 weeks of pregnancy, as it helps not only in identifying pre-existing diabetes but also early GDM. Toboggan study has shown for the first time in the world that beneficial effects in terms of reduction in composite primary outcomes if the eGDM is treated. There were no significant adverse effect. That's the other thing you may ask. Did the baby become too small? Was there any other adverse effect? No adverse effect was seen in toboggan. Future toboggan publication, this is only the first publication. A series of publications will now come out where we will focus on cost effectiveness of the screening and what is the most appropriate diagnosis and treatment. Should we be doing GTT for everyone in the first trimester as we did in toboggan? Toboggan being an RCT and a study, we did GTT for everyone. Maybe we can just do fasting, okay? Or maybe you can do just HbA1c. That future studies will be able to tell. And then the best treatment also, as far as toboggan is concerned, each of the 17 sites was asked to treat GDM as they treat in their country. We didn't say, give them insulin, do this, do that. But is that the best treatment? Is metformin to be used or is insulin to be used? That will need further studies and probably further publications from toboggan will answer that. So this is my final take-home message for you. If you have listened to this talk, early GDM or eGDM must be identified and it must be treated. It is very relevant for India because I think India and South Asia has one of the highest rates of not only GDM in general, but also of early GDM. And with that, I'd like to thank you for your patient hearing. And once again, thank Dr. Aravinda for organizing this wonderful meeting and for asking me to participate and to give this talk on early GDM. Thank you very much.
So thank you, sir. Like till yesterday night, he was trying to come, but unfortunately, he was not able to come because of so many commitment he has got. But I'm sure this was a unique topic he has selected, and he in fact told this is the first time this new paper has been presented in our conference. So I'm sure all of are benefited with this, because since it's an oration, there will be no questions. So before moving on to next session, we'll have a small inauguration of lamp lighting because most of us are here, so we'll do. It is not a big inauguration; it is only a 5 minutes inauguration. Photo.
I request our senior delegates and faculty members, Dr. B.K. Singh, Dr. Anil Kumar, Dr. Vinay K., Dr. Mohan Kumar, and Dr. Aravind Jagdisha to facilitate the program. Thank you all. Moving on to our next session. The first chairperson for our next talk is Dr. Tirthankar M., diabetologist, Kalyani Clinic and Diabetes Care Center, Bengaluru. And our second chairperson is Dr. Mohan Kumar, ex-Joint Director of Health and Family Welfare Department. He is currently working as an assistant professor of Geriatric Medicine at Bangalore Medical College and Victoria Hospital. We welcome you, sir.
Good afternoon, everybody. After that thought-provoking symposium by Dr. Mohan, we'll be continuing the other deliberations. I would request Dr. Mohan Kumar to introduce the next speaker.
I am Dr. Mohan Kumar. Good afternoon, everybody. Dr. Mohsin Aslam is a consultant physician and clinical researcher at Asian Institute of Gastroenterology, Hyderabad. Alumni Academy for Young Leaders, CUHK University of Melbourne. Young Investigator Award he has received from ID.
On the topic or a condition which is very commonly encountered in our, so we all know pancreas is a double entity organ with both exocrine and endocrine component reciprocally interacting and closely cooperating for the digestion, absorption and metabolism of the nutrients what we consume orally. So it is not common to see that disorders of the exocrine pancreas will affect the endocrine system and vice versa. We all are familiar with the condition that patients with chronic pancreatitis develop a peculiar form of diabetes called pancreatogenic diabetes caused by destruction and fibrotic injury of islet cells. However, very less is known about the influence of diabetes on the pancreatic exocrine function. So what is pancreatic exocrine insufficiency? Digestion is mainly mediated by the major pancreatic enzymes like lipases, amylase and proteases. So the reduced secretion of these enzymes from the pancreas or rapid destruction of these enzymes or inadequate contact between the food and these pancreatic enzymes in the intestinal tract results in the nutrient maldigestion, and this condition is referred to as pancreatic exocrine insufficiency. So what are the causes? There are pancreatic causes like exocrine diseases of the pancreas and non-pancreatic causes. Among non-pancreatic causes, type 1 and type 2 diabetes is the most common, followed by celiac disease, and the prevalence of Crohn's disease also is increasing in India due to westernization of the diet, Zollinger-Ellison syndrome, and GI and pancreatic surgical procedures. So the main clinical consequence of pancreatic exocrine insufficiency is fat maldigestion and malabsorption, resulting in steatorrhea that is characterized by frothy, foul-smelling and buoyant stool because of its high fat content. Other non-specific manifestations include abdominal pain, flatulence, altered bowel habits, weight loss in adults, or lack of weight gain in children. So the prevalence of pancreatic exocrine insufficiency is found to be quite common in diabetes. Different studies have shown the prevalence of pancreatic exocrine insufficiency ranging from 21 to 74% in type 1 diabetes and 28 to 54% in type 2 diabetes mellitus, which is quite high. In one of the cross-sectional studies performed in India with 89 type 1 diabetic patients and 95 type 2 diabetic patients, nearly 30% of the type 1 and type 2 diabetic patients had some form of pancreatic exocrine insufficiency. That means almost 1/3 of the patients presenting to us will have some form of either clinical or subclinical pancreatic exocrine insufficiency. So the pathophysiological mechanisms for pancreatic exocrine insufficiency are not clearly elucidated. These are all proposed mechanisms. One is the insulin has a trophic action on pancreatic acinar tissue. So in patients with type 1 diabetes where there is absolute insulin deficiency, or patients with long-standing type 2 diabetes where there is insulin insufficiency, this trophic action is lost, resulting in the pancreatic acinar atrophy and loss of exocrine function. Other thing is microvascular complication, that is tissue microangiopathy, resulting in the ischemic fibrosis of pancreatic acinar tissue, resulting in exocrine insufficiency. Autonomic neuropathy, there is a loss of entopancreatic reflexes resulting in exocrine insufficiency. Inflammation, as in autoimmune conditions or like post-viral infection, what we have seen post-COVID. In this, because of the inflammation, there is a destruction of the entire mechanisms. So what are the risk factors? In patients which should suspect of exocrine insufficiency, patient with early onset of diabetes with long glycemic control despite adequate lifestyle modification and adherent to treatment. So how do we diagnose? It is often difficult to detect pancreatic exocrine insufficiency in patients symptomatic in the early stages. The classical symptoms of steatorrhea, pain abdomen and weight loss develop only when there is a severe pancreatic exocrine insufficiency. So there should be a high index of suspicion of PA in diabetics especially those with poorly controlled diabetes and long-standing diabetes, and those who present with GI manifestations. So these patients more commonly present with altered bowels, abdominal discomfort, and flatulence. Diabetic patients often complain of symptoms of fatigue and difficulty in controlling blood sugars. Although there are many causes of diarrhea in diabetic patients like small intestinal bacterial overgrowth and diabetic dysautonomia, this should be suspected in patients with long-standing type 1 and type 2 diabetes. However, other causes of this GI symptoms should be ruled out like gastroparesis, celiac disease, and side effects of diabetic medicines, particularly metformin and alpha-glucosidase inhibitors, should be excluded before considering PEI. So what are the diagnostic tests available? There are several direct and indirect tests available. Direct tests such as 72-hour fecal fat estimation, cholecystocanin or secretin stimulation test are the gold standard, but they are hardly performed because of the cumbersome nature, and also they are invasive and they are performed only in the research settings. Indirect tests like fecal chymotrypsin, it has a good single sample is sufficient, but only thing is these are unstable and this cannot be done in patients who are already on elastase 1. It is currently the most commonly used test to detect PEI. Values of more than 200 microgram per gram are considered normal, and less than 100 is considered severe pancreatic exocrine insufficiency. So in one of the studies, another study showed that steatoria can be detected in nearly 60% of the patients with diabetes who had reduced elastase levels. So that means nearly 40% don't have any symptoms. So if you don't perform any these elastase levels, we are missing out on nearly 40% of the patients. And this test is now available across a few centers in India. Advantage of this is that elastase 1 is stable and unaffected by exogenous pancreatic enzyme substitution, and patient need not stop taking enzymes before conducting the test. However, it should not be performed in patients who are having diarrhea because the results may be falsely low. Again, this 13C mixed triglyceride bed test, it is the most recent test to detect PEI. It is fairly accurate. It could also be used to monitor. So now coming to management, the mainstay of management is enzyme replacement therapy. However, there is no guidelines or data on enzyme replacement therapy in patients with diabetes. So we follow the guidelines recommended for the treating chronic pancreatitis. These are the preparations available and approved by FDA for treating pancreatitis patients. So these enzymes can be used for the management of diabetes also. So the lowest recommended dose is 25 to 40,000 units of lipase per mil, and then titrated upwards according to clinical response. The maximum recommended dose of PERT in adults is 75 to 80,000 units of lipase with each meal. This is quite high. This is from the Western data, and the cost being very high, it's not possible to use in our population. Optimal action could be achieved by taking preparation along with or immediately after taking food. So enzyme replacement therapy also has an impact on glucose metabolism, the insulin requirement, and beta glycemic control. A study performed in Canada with high patient number with reduced HbA1c and diabetic patients with reduced elastase levels had shown that after an enzyme replacement therapy, there was a reduction in HbA1c and insulin dose could also be reduced. So how does this enzyme replacement help in improving the glycemic control? So because of the maldigestion, there is a decreased nutrient reaches the lower intestine, so decreased GLP-1 release from the intestine. So once absorption improves with the enzyme replacement therapy, there is an improved secretion of GLP-1 from the intestine and better insulin release from the pancreas and better glycemic control. So apart from also helping in improving the blood control, it also helps in controlling the quantitative or qualitative malnutrition and metabolic complications of diabetes. So adequate pancreatic enzyme replacement is needed in management of diabetes. So for optimal digestive enzyme action, the enzyme preparation should have survived the gastric acid milieu, get released into the duodenum along with the chyme, and contain the correct dose of lipase. So among the enzymes supplemented, the lipase is the most vulnerable by the gastric acid milieu. So, and the survival is as low as 1% in the intestinal lumen if it is not mixed with the substrate, that is fat. So the high concentration of lipase in the pancreatic enzyme supplement is needed to achieve the optimal dose. So pancreas has a huge reserves of enzymes, and only 10% of the total daily lipase output, that is only 60,000 units of lipase, is required for fat digestion. And total daily dose of at least, so the total daily days of at least 20,000 per meal of lipase is needed for fat digestion. So as the initial response of pancreatic exocrine insufficiency to PERT could be erratic, so to supplementation should be start with a higher dose of 25 to 40,000 of lipase with each major meal in Indian patients, and then later on it can be up titrated or down titrated based on the patient's response. Also, factors such as size of the patient, size of the meals, and nutritional status of the patient also determine the starting and maintaining dose of the enzyme replacement therapy. So coming to adverse effect, it is generally well tolerated with few side effects. It is rather an intraluminal therapy rather than a systemic therapy. The most common side effects include abdominal pain, nausea, vomiting, and constipation or diarrhea. So to summarize, patients with diabetes mellitus have an increased risk of developing pancreatic exocrine insufficiency due to pancreatic acinar atrophy. Symptoms of pancreatic exocrine insufficiency do not manifest until duodenal lipase levels fall below 5 to 10% of the normal postprandial levels. Clinical consequences of PI is fat maldigestion resulting in steatorrhea and weight loss. Upon clinical suspicion, a pancreatic function test should be performed for identifying subclinical pancreatic exocrine insufficiency. Enzyme replacement therapy is the main pharmacological treatment of PI, and these are most effective when given with meal rather than before or after it. Thank you. And I would like to invite you people for our conference on diabesity, which will be conducted at AIG Hospital's auditorium on 27th and 28th of October.
Thank you, Dr. Mohsin, for that excellent talk. Until now, diabetes has been always considered as an endocrine disorder, but you have thrown a lot of light on the exocrine dysfunction as well. One thing I would like to highlight to all the practicing physicians is that enzymes don't work unless the gastric acid secretion is suppressed. So we have to adequately give PPIs to the patient before we give them pancreatic supplements, especially the enzymes. And these enzyme preparation, the enzyme preparation, they also have an effect by reducing the ductal pressure of the main pancreatic duct as well. So the house is open for any discussion.
Fantastic talk, Dr. Mohsin.
Thanks.
As you just mentioned in your talk about the various confounding factors that we have in making a clinical diagnosis of an exocrine insufficiency in type 2 diabetic individuals, in your practice that you have seen, do you have any clinical markers during the timeline of diabetes? Do you have a duration at which we could probably have a high suspicion? Are there any clinical markers that you could probably suggest where we could have a high index of suspicion? The second question to that was, in the situation where we have lack of diagnostic tests which are easily available, do we have a process of a clinical trial of medications and then see if the patient has some improvement in these symptoms, and then if that is the case, we could probably go ahead and do a reverse confirmation of this diagnosis? What's your take on this?
Thank you, sir. So, like as I already mentioned, longer duration of diabetes and those who are poorly controlled diabetes, yes, we have to suspect. And also patient having GI management, particularly altered bowel habits and bloating sensations, they complain. Yes, and yes, I agree there are not many centers performing, and even certain centers like Lalpat they are doing, but the values what we are getting is not accurate. So we can just give a trial of enzyme replacement therapy, and just after that if there is a clinical improvement in symptoms and blood control, you can continue with the enzyme replacement therapy. Yes, sir.
I would like to add one more point, that these symptoms almost are similar to metformin intolerance as well. So it may be worthwhile to discontinue the metformin for some time and see if the patient doesn't improve, then we can consider this exocrine insufficiency as well. Yes, sir.
Yeah. Dr. Mohsin, don't you think the pathology in type 1 and type 2 are totally different? Type 1 is insulin deficiency, type 1 is insulin deficiency, type 2 is hyperinsulinemia.
Yes.
So the trophic changes which is not seen in type 1 is not explained in type 2. There are inflammatory cells in type 1 where there is amyloid deposition and there is an ectopic fat deposition in the pancreas in type 2. So I think the pathology don't match. So the hypothesis which you suggest for this increase in exocrine insufficiency could not be, similar in both the different types of patients. The other component is we see autonomic neuropathy as a cause of altered bowel movements in both type 1 and type 2 diabetic patients, more in type 1. I think autonomic neuropathy should be ruled out very, very intensively, and the small gut infection, the small gut disease is also a very, very important reason for this manifestation. So I think type 1 and type 2 diabetes are not similar as far as the pancreas is concerned. And at the same time, with 95% of the exocrine pancreas and 5% of the endocrine pancreas, do you think the 5% is good enough to cause 95% damage in diabetes patients?
No, sir, that's what I told. It's not proven mechanisms. They're all proposed mechanisms.
Yeah. So
and yes,
there has to be a different mechanisms for type 1 and type 2. This is what I'm trying to stress upon. You cannot make a common suggested hypothesis for both of them.
No, yes, definitely. That's what I've told. In type 1 diabetes, there's a complete insulin deficiency, and that might contribute to, with a small amount of acinar atrophy.
Yes.
And also, type 2 diabetes, there is mild deficiency, so that might or might not contribute. And other mechanisms are also there, like tissue microangiopathy, which might, in type 2 diabetes, it may contribute to this. It might be in both type 1 and type 2 diabetes. Microangiopathy might result in acinar atrophy. And also, yes, enzyme replacement therapy might help because as you saw, autonomic neuropathy, we have to rule out other causes before labeling as PI. If after treating also there is no improvement in symptoms, then we can consider PI as also one of the possibilities.
There are no questions. I thank Dr. Mohsin Aslam for his wonderful talk, and I also thank Dr. Aravind for inviting me to become a chairperson. Thank you very much.
Thank you very much for this informative speech, sir. I request Dr. Aravind Jagdish and the chairperson to facilitate the speaker. May we all give them a big round of applause, please. I request Dr. Aravind Jagdish to present the mementos to the chairperson. Moving forward, our first chairperson for the next session is Dr. Sudhir B.S., Diabetologist, Bengaluru. And the second chairperson is Dr. I.A. Khan, Consultant Physician and Diabetologist, Shifa Hospital, Bangalore. We welcome you, sir. We welcome you, sir. Over to you for the further proceedings. Thank you.
Calling us and asking us to chair the session, and we will call upon the next speaker. Basically, on the we've gone through the pharmacotherapies and other things in the diabetic management. Now it's the turn of the exercise as a prescription. So how much of that is relevant in our prescription? So isn't it? So that I'm sure Arun Raghavan will throw light upon. We'll ask Dr. Safi to just introduce our speaker.
Dr. Arun Raghavan a diabetologist at Dr. A. Ramachandran Diabetes Hospital in Chennai. He will throw light on the importance. Yeah.
Thank you, chairpersons, for setting the context and introducing the topic as well. Very, very good afternoon to one and all. I'm sure all of you have been having very fruitful sessions during the morning deliberations. At the outset, I would also like to thank Dr. Aravind sir for having invited me. Sir is someone who's come, who's always, I've seen him with a very friendly demeanor, and his energy has always been infectious. And of course, he's always been inspirational as well with his commendable work that we've seen over the years. And congratulations, sir, for putting up a grand show in close proximity to all the drama that's happening outside. I'm sure it is not only an eventful day for us, but for the entire Karnataka itself.
Tamil Nadu also is not new for this dramas.
Absolutely. So on that note, I'm going to don the hat of a physical trainer today and see if I can do a notch better than a physician to manage type 2 diabetes, right? Now that being said, we all know that diabetes management entails not just medications, but it also entails exercise and nutrition. But think about this. How much of time do we actually dedicate on nutrition and exercise? Predominantly, much of our time is dedicated on titrating our insulin and medications to whatever the blood workup throws up, right? That is what most of the time that we dedicate upon. Nutrition is, of course, something that we touch. Some of the infrastructures, institutions also have dietitians, nutrition, so on and so forth. But seldom do we actually dedicate or focus on exercise. Of course, we may have a passing comment. We also ask patients at face value and agree whether they are adherent to exercise or not. That's about it, right? We don't spend too much of time. But we do need to understand all of these components need to be in some state of equilibrium in any patient's journey with diabetes. Now let's see how we can change our approach and also see what exercise brings to the table. Now we are aware there is no ambiguity that exercise indeed improves glycemia. We are also cognizant of the fact that blood glucose control, glucose metabolism, as well as the lipid metabolism is favorably affected by exercise. There is also reduction of BMI, and of course there is finally, you can preclude complications with continuous physical activity. Now, how does technically exercise affect diabetes? Now, I'm going to spend few moments on this slide. Before I deliberate on this slide, let's look at some acute adaptations that happen with exercise. So even small bouts of exercise will increase the cardiac output, cause fatty acid oxidation, improve glucose uptake as enumerated in this illustrative slide, increase fat oxidation, increase the blood flow, vasodilation, transport of fatty acids, so on and so forth. And with consistent exercise over time, you tend to reap benefits, right? As shown in the next illustration, what happens with exercise over time? You, of course, have all the acute adaptations that you've seen with exercise. On top of that, there is also improvised cardiovascular function. So there is reduction in the resting heart rate. There is improved cardiovascular function. So there is also improvement in the blood pressure. There is improvement in the skeletal mass. There is reduction of not only fat, but more metabolically active visceral tissue, visceral fat, so on and so forth. So with consistent exercise, definitely, there is much more benefits. Now, going back to this slide. So how exactly does exercise improve glucose uptake? Now, on contrary to earlier beliefs that now there are two different mechanisms. One could be insulin dependent, the other is insulin independent. Now, exercise itself can help in translocation of the GLUT4 from intracellular to the plasma membrane, which enables skeletal muscle glucose uptake. Now, this GLUT4 increases with constant exercise. Now, this is independent of insulin, to contrary of earlier beliefs. So, exercise itself helps in increase of GLUT4, thereby improving skeletal muscle glucose uptake. This could happen because of different signaling mechanisms. And of course, as I mentioned, when skeletal muscle increases, the surface size increases, there are increase in insulin receptors in the muscle, thereby improving insulin sensitivity. Constant exercise also improves the mitochondrial function in the skeletal muscles, improves the activity of the mitochondrial oxidase, thereby regulating the lipids better. The entire lipid levels in the cellular level are low, which also alleviates improvement in the insulin resistance. So these are the mechanisms by which exercise seems to benefit hyperglycemia. So coming to the next part of the aspect of how exercise could play a role, I'm going to introduce you to myokine. Some of you must have heard of this. This irisin is of active research. Now, myokine irisin is produced by skeletal muscle in response to exercise. There is a lot of interest on this cytokine. So what does irisin do? Now, irisin gets secreted by skeletal muscle in response to exercise, as I mentioned. Now, irisin increases the mitochondrial density, thereby inducing or expansion of the brown tissue, and also promotes thermogenesis. So thereby it reduces the white tissue, which is the more metabolically active visceral fat. So when the white adipose tissue comes down, white adipose tissue is capable of producing the pro-inflammatory cytokines, which kickstart cascading pathways, which increases systemic inflammation and also reduces insulin signaling. So when this adipose tissue comes down, it mitigates the production of pro-inflammatory cytokines. So that's how myokine, the irisin, seems to work. There is a lot of active research happening, not only on irisin, as you see the other cytokines such as osteokine as well as adipokine. So there will be, of course, more data coming on these cytokines. Now that we've seen the technical aspect, let's move on and see broadly what are the types of exercise that we can look at. So aerobic exercise, not much of skill involved, pretty easy, pretty straightforward. Any patient can start off with. Of course, cycling and jogging is pretty easy. Swimming is something which you may need to learn some skill. Rise activity from China, and overall yoga, which is about thousands of years, have also had some publication from, in fact, Karnataka to demonstrate that there are benefits in terms of HbA1c reduction. Aerobic is nothing but the conventional cardios. It improves the lung capacity, improves the cardiovascular function, improves reduces oxidative stress, improves insulin sensitivity. Quite easy to carry off aerobic training. Resistance training is something that requires a little bit of skill. You may need some machines, you need free weights such as dumbbells, kettlebells, barbells, so on and so forth, or at least a resistance band. But then if you learn skill, you could even do resistance training with your own body weight. Diabetes is an independent risk factor for low muscular strength, and that is where resistance training can be really useful, particularly over the age of 40, where it helps to retain. It is still recommended because it reduces the chances of injuries, reduces the chances of niggles, and also improves joint mobility, thereby improving the efficiency to perform aerobic or a resistant physical activity. Balance training can be particularly useful for patients with neuropathy, peripheral neuropathy, etc., where side walking, standing on one leg, walking backwards could all help. Now, which would you suggest to your patient finally? Would you tell your patient that you should do aerobic exercise, or would you recommend resistance training? Now, this is data to show aerobic exercise, or multiple studies have shown benefit. Likewise, resistance training has also shown benefit. So which would be best for your patients? But remember, on a lighter note, the only bad exercise is the exercise that never happened. So on that note, any exercise is good, right? So this is a study which actually meta-analysis compared both resistance as well as aerobic. Neck to neck, you can't much see the difference between both. There may be a slight numerical balance favoring aerobic exercise. However, recent data, you can clearly see the benefits in all metrics, including body fat percentage, BMI, insulin resistance, total cholesterol, HDL levels, LDL levels. So it favorably influences all these metrics. Pretty recent study, and emerging data suggests that alternating between aerobic exercise and resistance training perhaps is the best way forward. That is what mounting evidence now recently, a lot of evidence is favoring of alternating exercises. So consensus statements suggest aerobic exercises improve the HbA1c level to the tune of 0.5 to 0.7%. However, if you look at resistance training, it needs to be moderate to high intensity to have meaningful effects of blood sugar reduction. And another point on sedentary lifestyles, sitting is the new smoking, they say. So you have to be physically active nowadays. You have these Fitbits, etc. They give you nudges to walk. In case if you're not tech savvy, you have to tell your patients kindly at least get up every hour and move here and there so that you do not become a victim of sedentary lifestyle. ADA recommends that patients should engage in at least about 150 minutes of moderate to vigorous intensity. Moderate to vigorous intensity means about 50 to 70% of the maximum patient's heart rate or at about 3 to 6 METs. Younger patients could also have a vigorous activity, thereby they can reduce the quantum of time to about 75 minutes a week. So vigorous activity means about 75 to 90% of your max heart rate. So younger patients with type 2 diabetes can opt even for vigorous activity. And as we've seen through the data, ADA also suggests that patients with diabetes should engage in at least 2 sessions of resistance exercise. No 2 days should be consecutive, but with regards to resistance exercise. So you should alternate between both aerobic and resistance exercise. ADA also recommends flexibility as well as balance, as we've seen before. Now aerobic, you can start off again with mild intensity, step up to moderate intensity, and even step up to vigorous intensity to about 3 to 7 days. No more than 2 consecutive days between executive bouts, meaning you cannot be idle for 2 consecutive days. Resistance training for moderate intensity, you have to do a maximum of 15 reps, but not more than 6 to 8 sets for each muscle, only about 2 to 3 weeks, no 2 consecutive days. High intensity interval training is something which has garnered a lot of attention in the recent past. Much of you may be aware of it. The virtual training programs by Apple and other newer virtual programs are all hit. This increases your heart rate to the capacity of 75 to 95%. So not all patients may be ideal for the HIIT training, although HIIT training has a lot of favorable data because it kind of blends in both the aerobic as well as the resistance training within it. So it is a very useful training, maybe very, very useful for younger patients. And finally, patients who are not motivated, etc., please make sure you create breaks in their sedentary behavior. Data suggest over 8 hours, every additional hour after 8 hours increase sedentary life. Please not to be sitting idly. When is the time to exercise? Now we've seen some mixed results. That this is one of the latest publications showing that exercise deserts, as they have termed the nomenclature, even short exercise bouts after lunch seems to be helpful in reducing the blood sugar level, probably because of the disrupted circadian rhythm as well as the reduction of insulin sensitivity during the evening time is what the author discusses. But we still need more data, more research in this area to actually suggest which could be the best time to exercise. Pre-exercise health evaluation, if you start with mild to moderate, I don't think risk factors and as of cardiovascular stress tests, so on and so forth. Other word of cautions for patients with comorbidities, autonomic neuropathy, there could be impaired thermoregulation, so patients have to be hydrated, they have to avoid extreme temperatures. Peripheral neuropathy, non-weight-bearing exercises could be more appropriate. Diabetic retinopathy, avoid high-intensity exercises. Of course, exercise is completely contraindicated. Between knowledge and action, remember each patient is different. We always individualize therapy when it comes to the number of agents that we have. We look at cost, we look at patient's profile, we look at so many other factors. I think similar kind of concepts have to be applied even pertaining to exercise. All patients may not be equally motivated. Patients can be coming from different demographics, different timelines, etc. So you'll have to talk, bring in a conversation with the patient, and then advise patient accordingly. Finally, to conclude, there is mounting data to suggest alternating between aerobic and resistance exercise is probably the best way forward for patients with diabetes, as it helps not only to retain muscle mass, but it also helps overall in blood sugar control. It gets you best of both worlds. And diabetes patients should be encouraged to not be sedentary. Finally, as I touched upon, I'd like to conclude. Thank you so much for giving me an opportunity.
Thank you, Dr. Arun, for throwing light on the importance of exercise. I think there's a little, we are running out of time also. So maybe one question is what we can take at the most. And I'm sure it's a few weeks, so there's always plenty of questions to throw at, but we'll stick to at least one question if it is possible. I think everybody are well convinced. That should be fine. Yeah, I think we'll wind up.
Exercise is always convincing.
Yeah. You can join for the felicitation.
Thank you very much, sir. The speech was indeed very informative. Thank you, sir. I request Dr. Aravind Jagdish to present the mementos to the chairperson. Moving forward, now I welcome our esteemed chairperson, Dr. T.J. Pradeep Kumar, diabetologist, Brookfield Hospital, Bengaluru, and our second chairperson, Dr. Kanti A. We welcome you, sir. We welcome you, ma'am.
Very good afternoon, dear delegates. I thank my dear friend, Dr. AJ, the boss, for this annual convention. We keep looking forward for this meets. We missed it during the pandemic period, but we're back with a bang. Thank you so much for involving us in this particular meet today. So I would love to introduce our speaker for the day today, Dr. Rakesh Sahai. He's no stranger to this crowd who's here. As we welcome Dr. Sahai onto the stage, he is currently the professor and head of Department of Endocrinology at the Osmania Medical College and Hospital in Hyderabad. He is currently the president-elect of the Research Society for Study of Diabetes in India for the year 22-23. He is also the immediate past president of Endocrine Society of India. He's also been the vice president of the South Asian Federation for Endocrine Societies. He's been felicitated with quite a few achievements. Most noteworthy of them are the Fellowship of National Academy of Medical Sciences, Fellowship of the American College of Endocrinology, Fellowship from RSSDI, and also the Fellowship of Indian College of Physicians. He's been bestowed with various awards, and he's got more than 180 publications to his credit. So let's put our hands together to Dr. Rakesh Sahai on the topic that he's going to discuss. Is going to be quite interesting on inflammation and diabetes. Over to you, Doctor.
Thank you, Dr. Pradeep, for the kind words of introduction, and thanks to Dr. Aravinda for inviting me to be here and to speak on this topic of inflammation and diabetes. So this has been there's been a lot of interest in this area because of the fact that today we have therapies directed towards that, but also there has been a lot of interest on the role of inflammation. As you said, we've just heard about exercise. Exercise also has a very significant anti-inflammatory role Dr. Arun was speaking about all the inflammatory cytokines, how they have an important role in modulating the diabetes, and getting the better cytokines up would actually improve the diabetes. So what I'll do in the next 15-17 minutes or so is discuss about the role of chronic inflammation, how it is having a significant role in chronic cardiometabolic disorders. Then I'll go on to discuss about this low-grade inflammation and its role in the progression of diabetes and progression from normalcy to pre-diabetes to diabetes, and also in the development of complications of diabetes, and also discuss briefly about the role of hydroxychloroquine, which has been being used in the management of diabetes for some time, and also discuss about its CV renal safety, and then discuss about its positioning in current therapy. So if you look at inflammation is a normal response to various threats that are perceived by the organism or by any individual. So here what we see is that there is a difference between what is acute inflammation and what is a persistent low-grade inflammation. So acute inflammation is certainly beneficial for protection against various viruses, bacteria, and various trauma and all these situations. And when it persists and then becomes a pathological condition. So from physiology it becomes a pathology when it persists as a low-grade inflammation over a period of time. So that is what is the challenge. And if you look at this slide, which tries to bring out the differences between acute inflammation and chronic inflammation, as we said, acute inflammation is mostly mediated by vasoactive amines secreted from the polymorphonuclear cells, and which has an immediate onset and subsides over a few days, and ends up in healing and once the inflammation is resolved. Whereas chronic inflammation is something which is sort of initiated by mediated by different types of cells, where cytokines, growth factors, reactive oxygen species are the ones which are upregulated and which are playing an important role, and the monocytes, macrophages are the major players there. And this ultimately has a long course of it has a prolonged time period over which it works, and it ends up with tissue destruction. So that is the difference between these two sort of aspects of inflammation. So what we have seen is that over the years we have got a lot of information to see the link between chronic inflammation and the various cardiometabolic disorders. This cartoon actually brings out the role of inflammation in terms of causing alterations in the adipose tissue, in terms of causing alterations in the immune system, leading to upregulation of various cytokines like TNF-alpha, IL-6, IL-1 beta, which are all the pro-inflammatory cytokines. And then at the level of the adipose tissue, it works on it. Causes upregulation of certain adipokines like TNF-alpha, IL-6 again, which are released from the adipose tissue, and then we have downregulation of some of the protective cytokines like the adipokines like adiponectin, which is downregulated, and again so all these ultimately culminate in damage to the tissues and leads to endothelial dysfunction, oxidative stress, lipotoxicity, inflammation, and endothelial dysfunction, finally culminating in cardiovascular disease. So this is how inflammation, low-grade systemic inflammation, has various mechanisms through which it is causing endothelial dysfunction and leading to cardiovascular disease. And the major sort of factors which are aggravating the inflammation is the presence of obesity and presence of other factors like dyslipidemia, hypertension, hyperinsulinemia. All these are actually interacting in the causation, and also in the they are being influenced by the inflammation. So if you look at the molecular mechanisms, as we've seen, that there is activation of the endosomal NADPH oxidase, which is caused by all these cytokines. As you can see, most of these pro-inflammatory cytokines are playing a role in causing NADPH oxidase activation. and then causing excessive generation of reactive oxygen species and leading to activation of the NF-kappa B. And all this leads to, culminates in the development of the spectrum of cardiometabolic disorders, diabetes, metabolic syndrome, atherosclerosis. And if you look at the role of inflammation in diabetes, in causation of diabetes, probably what we said is that because of the fact that all these mediators are increased, they have a significant role in many of the pathways. I mean, what I would like to just focus is on the, while we have understanding about the entire ominous octet, I'll just focus on the two major defects, that is the insulin secretion and insulin resistance. On both these, inflammation has a significant effect, as you can see, that because the inflammatory factors lead to increased free fatty acids, reduced adiponectin, increase in leptin, higher demand for insulin, and also at the pancreatic beta cell level, there is immune cell recruitment is leading to islet inflammation and dysfunction, and that leads to islet insulin deficiency. So we have inflammation having a role in aggravating the insulin resistance, and also at the same time potentiating the insulin deficiency also. And the important, I just wanted to highlight here this concept of what is called as metabolic inflammation, because we are seeing with growing obesity, we have we see a significant role of metabolic inflammation in causation of diabetes, and also hepatic steatosis, which is a very common accompaniment, which is a very common disorder seen amongst people with diabetes and metabolic syndrome, particularly amongst the overweight and obese individuals with diabetes. And if you look at the role of inflammation in the progression from diabetes to the complications, there is again an important role that inflammation has to play in this aspect, because of through several mechanisms, again because of increasing the production of the advanced glycation end products, the hypoxia leading to inflammatory signaling cascades, local activation of the pro-inflammatory cytokines, and ultimately culminating in tissue damage in the various sites of microvascular damage that we see, nephropathy, retinopathy, and neuropathy, all being aggravated by inflammation. Now, if you look at the markers of inflammation, we have very clear evidence from various studies which have looked at the association between inflammatory markers and the development of diabetes, and we have very good studies which have seen, which have shown that increased levels of CRP, increased levels of fibrinogen, and even the white blood cell count itself, and decreased adiponectin levels being closely having a close association with the levels of diabetes, the prevalence of diabetes, and we can see the odds ratio for say CRP in different studies ranging from 2 to 4 in terms of increasing the risk for clearly we see that inflammation, there are simple markers of inflammation could show us the extent of association between inflammation and diabetes. Then we have several meta-analyses which have looked at all these, putting together all these studies and putting together all the effect of all these individual markers of inflammation, and clearly we see that there is a close association between CRP levels, the TNF-alpha levels, interleukin-6, and decreased levels of adiponectin, all of them correlating with the higher risk for development of diabetes. And C-reactive protein is a very simple marker which has been shown many years back, as you can see, has been shown to be more than 20 years back. We have this data which is showing the clear relationship between higher levels of C-reactive protein and more than threefold increased risk of development of diabetes. And so if you look at now from there, let me shift gears towards the evidence that is available for managing inflammation and bringing down, improving the glycemic parameters. So if you look at probably the first evidence that was that actually brought down the role of anti-inflammatory molecules like hydroxychloroquine was the data that showed that those who were users of hydroxychloroquine versus non-users for rheumatoid arthritis over several years of follow-up, what was seen was that those hydroxychloroquine users had lower rates of development of new onset diabetes as compared to those non-users, and that actually gave us the clue that tackling inflammation can have a role in terms of preventing or managing diabetes. So from this study, what was seen was that use of hydroxychloroquine for more than 4 years was associated with 77% lower risk of development of diabetes. And if you look at how hydroxychloroquine brings about this difference, it reduces inflammation, it reduces, in addition, it reduces the insulin degradation. And also, we see that there is a close association between the hydroxychloroquine use and increase in insulin levels, as you can see from these studies which are done in diabetic rats. And so as the blood hydroxychloroquine levels were increasing, there was increase, insulin degradation was decreasing and blood insulin levels were increasing. And then we have then data from non-diabetic pre-diabetic individuals or non-diabetic the pre-diabetes individuals showing some improvement in their in the levels of beta cell function and insulin sensitivity as was measured in these subjects. And there was a 20% improvement in insulin sensitivity and improvement in beta cell function to the extent of about 45%. These were small studies done over 17 or 15 patients here, and then the anti-inflammatory effects of hydroxychloroquine were studied in patients with diabetes. Also, this was a study from India which has shown that when this was a study involving 120 patients with type 2 diabetes who were treated with insulin glimepiride, who were already on insulin glimepiride and metformin, where hydroxychloroquine was added to one of the groups, and what was seen was that there was an improvement in the decrease in the levels of HSCRP and decline in the HbA1c to the tune of about 1.3% over 6 months of usage. And so reducing CRP by more than 1 correlated with a reduction in HbA1c to the tune of about 0.8 to 1.3%. So reduction in the HSCRP by hydroxychloroquine may be predictive of subsequent reduction in CV events in patients with diabetes also. So the effect of hydroxychloroquine, we had this randomized controlled trial with looking at hydroxychloroquine versus pioglitazone, and it was shown to be non-inferior to pioglitazone. Apart from that, this is another study which is looking at the effect of hydroxychloroquine on insulin sensitivity, insulin clearance, and inflammation in insulin-resistant adult patients with type 2 diabetes, which showed that hydroxychloroquine improves the glucose disposal relative to placebo by about 1.5 milligram per kg per minute, and this corresponds to a mean 26% improvement in skeletal muscle insulin sensitivity because of increased glucose disposal. There was a corresponding enhancement in systemic glucose clearance also. So clearly these data show that tackling inflammation with a molecule like hydroxychloroquine has a significant effect on the glycemic parameters. And we have data to show that the hydroxychloroquine has effects on inflammation and adipokine levels, the decline in IL-6 levels and improvement in adiponectin levels were also shown in these studies. Now, looking at the effect of hydroxychloroquine on beta cell function, insulin resistance, and inflammatory markers in patients with type 2 diabetes. This was a study done by Rajesh Rajput from, and he has looked at the use of hydroxychloroquine over 12 weeks. And with the addition of hydroxychloroquine, what was seen was that there is a significant improvement in both beta cell function and insulin resistance in 30 patients with type 2 diabetes. And if you look at the effects on the various adipokine, I mean, like there was a reduction in HbA1c which was statistically significant. IL-6 levels, HSCRP levels came down, adiponectin levels went up significantly. So clearly there was a benefit in the inflammatory markers which translated into a glycemic benefit also. Now, we also have studies which have looked at by Arjun Vaidya, who has looked at the maximal and optimal dose of hydroxychloroquine, because we have the concern about the retinopathy associated with hydroxychloroquine, which is much less with hydroxychloroquine as compared to chloroquine itself. So they have looked at different doses of hydroxychloroquine, 200 versus 400 mg, and the patients were followed up for 6 months. And what was seen was that even at 200 mg, you could see, you did find improvement in the reduction in the insulin requirement, as which was comparable to which was probably lesser than what was seen with the 400 mg dose, but still there was a significant improvement even with the 200 mg. So insulin dosage also decreased significantly in both the groups. 3 units decline in the group which received 200 mg of hydroxychloroquine, 9.8 units reduction in the dose that was in the group that was receiving 400 mg of hydroxychloroquine. And studies were also looking at the glycemic variability. This is again a study by Rajesh Rajput et al. From again from Rohtak, who has looked at the glycemic variability parameters, age, mode, and the average blood glucose levels, and they have shown that there is a favorable effect of hydroxychloroquine on reducing the glycemic variability. As you can see in the graph, the reduction in glycemic variability was clearly shown in the group that was receiving hydroxychloroquine. And there's a ongoing phase 4 study which is being done to look at a larger study plan to involve more than 600 patients from across the country. This is also in its initial phases has shown improvements in the HbA1c levels and reduction in the fasting glucose and postprandial glucose levels. And the improvement in lipid profiles also has been noted in this study, and the tolerability also studied in this study. In this study, tolerability aspects looked into this study showed that there was a good tolerability of this molecule, with very few patients developing hypoglycemia, and that's because of the other medications, the concomitant medications that they were on. And if you look at the development of retinopathy, 9 patients were noticed to have retinopathy, which is all mild. 8 patients, and in most of these patients, it was unlikely to be related to HYQ. So HYQ or hydroxychloroquine could be an effective and well-tolerated therapeutic option for patients with type 2 diabetes. So clearly we have a lot of data which has shown that hydroxychloroquine, this is a recent study published in 2021 in Journal of Endocrine Investigation, and where they have looked at the efficacy and safety of hydroxychloroquine as add-on therapy in patients who are not controlled on 2 anti-diabetic medications. And here also it was shown that there was a reduction in HbA1c by 0.78% at 12 weeks, and with the use of 300 mg hydroxychloroquine, 200 mg hydroxychloroquine, 300 mg led to a 0.91% reduction and 1.2% reduction with 400 mg. So clearly we have seen that there is a graded response which is seen with 200 to 400 mg of hydroxychloroquine use in patients along with other anti-diabetic medications. So the retinal toxicity is another aspect that has been studied extensively, and what we see is that patients using hydroxychloroquine in the doses of 4 to 5 milligrams per kg per day, the risk is very low in the first 5 to 10 years. For daily consumption of 4 to 5 mg, the prevalence of retinal toxicity remained less than 2% within the first 10 years of use. So this is what has been shown from extensive data which is available on patients who have been using this molecule for several years, over several years for indications like rheumatoid arthritis or for SLE or for other indications. And the recommendation, I'll just take half a minute to wind up now. And this data has clearly shown that the risk of retinopathy is very low, and it is and we have this study from Kolkata also, which has looked at the prevalence of retinopathy amongst patients who are using hydroxychloroquine, and they've shown that uncontrolled type 2 diabetes who had comorbidities of RA, when treated with hydroxychloroquine, not only prevented the progression of diabetic retinopathy, but also delayed the new onset of NPDR and loss of visual acuity. So clearly, we have data that shows that there is safety from the retinal angle. And when we look at CV safety also, we have data from patients who are treated with rheumatoid arthritis who have been showing lower rates of cardiovascular disease. So with this, I would like to just go on to the last part, that is speaking about what is the current place in therapy. So different guidelines have mentioned the use of hydroxychloroquine after its approval by DCGI in 2014. It has been mentioned even by the RSSD guidelines for selected patients in whom blood glucose levels are not controlled with 2 anti-diabetic medications. It finds a place in therapy. So finally, I would like to say that this molecule finds a place in the management of diabetes who are not, in patients with type 2 diabetes who are not to other medications. In doses of less than 5 milligram per kg per day, it is recommended as the risk is very low, and it may be beneficial even in terms of reducing the cardiovascular inflammation, and it may be a suitable option for patients less than 60 kgs. A 200 mg dose may be suitable. For those with between 60 to 80 kgs, a 300 mg dose may be a suitable option for patients with diabetes. With that, I'll conclude, and I'll be happy to take any questions. Thank you.
Thank you so much, Doctor. Due to paucity of time and running behind schedule, I'll probably wind up with the permission of my co-chair on what has been your personal experience of using HCQS. What are the specific indications?
Effect, inflammation present in the form of, those who have associated, you had one study where they looked at patients with diabetes with RA, where they've used it and shown a significant benefit in terms of management of diabetes, also in terms of the inflammation also. So I think those are indications, because we have several patients with diabetes who have inflammatory arthritis, inflammatory disorders, and certainly it has a role. There are other sets of individuals where it may, who may not have very clear inflammatory arthritis, but who have significant joint pains and other issues, where again I've seen that there is a significant benefit in such patients. Routinely using it in all diabetics, probably you don't see a great benefit. I think it's in these subsets of patients with diabetes that certainly there's a role for management.
Thank you so much, and over to my co-chairperson.
Thank you so much, Doctor. It was a very good presentation.
Thank you, sir. I request Dr. Aravind Jagdish and the chairperson to felicitate the speaker. I also request Dr. Aravind Jagdish to present the mementos to the chairperson. We have a last session before the lunch break. Please note, for delegates, the lunch has been arranged in the first floor, and for the faculty members in the hall right side. So please have a short lunch break after this, and we'll wind up. After this, we'll wind up the session. Thank you, sir. So we have a last session before the lunch break. And for this, we have the chairperson, who is Dr. Ashok S.N., diabetologist, St. Martha's Hospital, Bengaluru. And the second chairperson, Dr. Babu Rajendra Nayak, chief diabetologist, Sri Tulsi Girish Diabetes Hospital from Bijapur. We welcome you, sir. After this session, there will be a short lunch break. For the delegates, the lunch is arranged in the first floor, and for the faculty members in the hall that is in your right side. Thank you.
Good afternoon, everybody. So I should thank Dr. Aravind for giving me the opportunity to chair this session. So this topic is cluster-based classification of diabetes. To start with, type 2 diabetes. The pathophysiology and phenotype differ significantly by ethnicity, particularly among Asian Indians who are known to have, which makes Asian Indian phenotype, which makes them more susceptible to develop diabetes compared to Caucasians. So the recent subclassification of diabetes is a remarkable development. So almost 4 replicable clusters were identified, out of which 2 were more unique to Indian population. So, clustering is mainly important because of prognostication and to prevent complications and to plan therapies. So here is our renowned speaker. So over to you, sir.
Good afternoon. Thank you, chairpersons. And outside, I would like to thank Dr. Aravinda for inviting me for this particular symposia. I've been attending it virtually for the last few years, but thank you for calling me here. And the topic given to me is cluster-based classification of diabetes. Now, before we really start, now this is an area where probably more and more of research is needed. It's giving us an insight into how far we can go to achieve the precision medicine. That's the whole idea of this cluster-based classification. And this is the common definition of what we apply to diabetes. But one thing is important, it is a heterogeneous group. Particularly the type 2 diabetes is a heterogeneous group. And pathophysiology as well the phenotype differ as per the ethnicity. And globally, if we look at the various phenotype, there's so much variable. So it doesn't really apply that one size fits all as far as the management of type 2 diabetes is concerned. And we all are aware of the fact that type 2 diabetes is not a homogeneous disease, or it's just about one type of disease. It comprises the whole spectrum. Though the garden variety looks same, about more than 85% is the usual type 2 diabetes which we see, but then you have other branch subtypes as well. LADA is one of them. Moody's to LADA comes into type 1 diabetes later, but basically all the genetic forms which lead to type 2 diabetes. So basically, it's a heterogeneous disease. And for any heterogeneous spectrum, you need a proper identification of the patient, and along with putting up the proper management tool in order to manage those patients. So that is why these clusters could be of some help there. So this is, though it is of 2019, but what it shows even in the recent IDF Atlas, that we are, or the people with diabetes in India is about 74 million. Now, with that much of prevalence and that much of incidence, we are really stretching our infrastructure. So probably from management, we are going to go into the preventive diabetology, which probably is is required. And we are working towards that. Preventive diabetology will take the center stage, then managing of the diabetes. So that's extremely important. And why do we really do it? Because of the various complications associated with diabetes, be it macro or macrovascular. That should be our goal in order to prevent the complication of diabetes, or at least prevent the progression towards the complication is extremely important. So in order to strategies to address the epidemic, or in some, I would rate now it's pandemic basically, we need to formalize some kind of strategies. So is universal screening possible? It's quite an impossible task actually. We are trying to attain that, but it's not possible. And along with that, aggressive management already diagnosed diabetes. Now this in our clinical practice, we are very well aware of the fact that this is a big problem or challenge because of the limitations, which is doctor's time or patient seriousness. Those are a lot of other factors as well, which prevents us to take that aggressive or the intensive management of managing diabetes. So the cluster-based classification of diabetes helps in assessing and deciding management of individuals at high risk of developing complications, and that is the whole idea of managing diabetes. So regarding the clusters, obviously the whole idea of clustering came in when it was discovered, or the new novel way of subclassification in the Scandinavian population was reported by Alkist et al. And that was the whole idea shifted toward that, and thereafter probably globally in almost all parts of the world, the clusters were identified. And one thing was sure, that there was a lot of variability at every place where it was undertaken, the cluster-based classification was undertaken. But more or less, in generalized terms, it really, the Scandinavian, reported patients clusters almost matches most of the clusters which were undertaken by different organizations or different countries. So that becomes the baseline on which probably we all have been working on. So why cluster-based classification is needed? We all are aware of the fact that prior to 1960s, probably there was hardly any classification of diabetes. So in 1980, WHO came out with the standard insulin and non-insulin diabetes. And then the ADA, obviously thereafter, came out with the type 1, type 2, the GDM, and the specific type of diabetes. So can even taking all those into spectrum, could we really manage all the patients? No, because that was the problem. Type 2 diabetes still had a lot of variability and a lot of heterogeneity. And among patients, there were wide variations, complication, metabolic control, and prognosis. So the same algorithm may not work for all. So this is why we need more precision of personalized medication or management. So the present classification probably was not appropriate in prognostically all patients after diagnosis. So a revision was essential, and that is why the whole idea of clustering came. So these are the major goals of clustering of the diabetes, that is implications for prognostications, and thereby manage accordingly, and prevention of complication is the idea of the whole goal. Now during that period, 2020-21, whole lot of papers came because there were, after that Alkist et al. Publication or report in those population of Scandinavian population. Now various other pilot studies were undertaken, and they were reported and in various journals, and most of them actually matched the clusters which were described by, reported by Alkist. Now, let's look at the first cluster which were described, on which were the basis for identifying these subtypes. It was in the Scandinavian population, taking roughly around 14,000 individuals, and there was 5 unique clusters which defined on certain six factors. And these were the 6 factors: age, BMI, glycated hemoglobin, GAD antibodies, and looking at the insulin resistance or beta cell dysfunctions. So basically these are the factors on which clusters were identified, work was done on that, and ultimately landed with these 5 clusters which are identified. The SAID, which is the severe autoimmune disease, is basically the type 1 diabetes, or you can fit in LADA there. And then you have the SID, which is a severe insulin deficit diabetes. MARD is mild age-related diabetes. SIRD is severe insulin-resistant diabetes. And MOD is mild obesity-related diabetes. So these are the 5 clusters, all were actually presented with the different clinical presentations, and these patients were having different complications as well when they were looked into. So let's look into the cluster 1, which is the SAID. Obviously, these are basically the type 1 LADA, as I said, and they have antibody positivity, but they can be different way of presentation. There could be normoglycemia, there could be asymptomatic dysglycemia, or symptomatic hyperglycemia. So they are basically with a low or depleted insulin secretory capacity, with a low BMI and poor glycemic control. So they have high prevalence of diabetic retinopathy along with the SID as well, and the risk of fractures were seen. So basically they have to imagine with only insulin. Now let's go to the other cluster, cluster 2, which is insulin deficit diabetes, and it features a mild to severely low insulin capacity secretory capacity and low BMI and develops relatively at an older age than the SAD, that is autoimmune disease. Again, there is a poor glycemic control, and again, there are chances of diabetic retinopathy is high along with neuropathy and fracture risk. So it almost looks like SAD, but it is a little bit less severe than the autoimmune disease, and the therapies which actually targets the insulin resistance are not worth even considering in this group of population. Only that they confer the highest risk of developing DKD and also carries the risk of cancer and dementia. Basically, I'm just trying to put out a few of the salient features of the clusters. So basically, this is one group which probably increased development of atherosclerotic CVD. Now, if you look at MOD, or MOD has a lower prevalence of obesity-related complication, hypertension, dyslipidemia, NFLD than the resistance group. But the glycemic control is relatively good with minimum complications. So it is of a lesser concern as far as the glycemic control is concerned. And the last one is the MOD, which again is age-related diabetes. And here, because of age-related, there is a decrease in the insulin secretory capacity, insulin sensitivity, few microangiopathies. But in elderly MOD group, the importance of mild cognitive impairment is extremely relevant along with osteoporosis and fracture. So this is one group which, in spite of having good glycemic control, can present with complication which could be dreadful for the elderly MOD individuals. So now let's come to the topic which our chairperson was discussing, is the Indian clusters. Why do we really to look? Practically every country tried to look into the various clusters once this theory of clustering came into, and we Indians also wanted to look into, because we are specifically different from the Caucasian population and different in the phenotype. And that is why we are known as Asian phenotype and differs on various parameters. Even in Asian phenotype, let me tell you, we do differ from the Chinese population as well. So basically, we or the Southeast Asian population may be a little different from the Mongolian and the Chinese as well. So we need to understand our own group, and that is why the clusters in Indians were taken into consideration. And a study was undertaken by, in South India by Dr. Mohan et al., including Dr. Anjana, and I think a good paper came out in JAPI. Dr. Bansi Sabu, Sasang Joshi, and Dr. Tivaskar were along with Dr. Anjana and Dr. Mohan. So this is what I was talking about, the Asian Indian phenotype. Basically, this is the different characteristic which makes us a little different and makes us more immune to the complication, particularly the cardiovascular mortality and morbidity. We have a lower birth weight. We are thin fat Indians. We are lower age of onset of type 2 diabetes, a lower threshold for BMI for type 2 diabetes. So at a lower BMI, we get type 2 diabetes. Lower serum insulin levels, insulin resistant. We have a rapid decline. So we don't have a big population of pre-diabetes, because the pre-diabetes get rapidly converted to diabetes if you really don't manage well. So we should not be very happy about that fact that we don't have enough pre-diabetes, because the pre-diabetes actually rapidly converts into diabetes. The low levels of adiponectin, and there is a difference in gut microbiota. We have an increased incidence of NAFLD, and that could be the crux of the whole problem, that we have more of type 2 diabetes, and along with that, more of visceral fat. So these are the various phenotype characteristics which makes us different from the Caucasian population and more susceptible to type 2 diabetes. So what are the various clusters which was identified Indians by our South Indian group, but that basically reflected in the ICM INDAB-B study as well, which was undertaken in 15 such states. So more or less, these groups represents India as a whole, though it was not done universally in India. So we have 4 major groups: SID, which is similar to the severe insulin deficit diabetes as we talked about, and MAD, which is mild age-related diabetes, which too were common to what we saw in the Scandinavian population. But what was different? Different was the identification of two other clusters, that is IROD and CRID. That is insulin-resistant obese diabetes and the combined insulin-resistant and deficit diabetes. So these two were novel to our population, and that's why it's so important that we understand our population, our diabetic population, and identify the subgroups so that we can manage them better. So these are the various characteristics of the different clusters which we found in the Indian group. If you look at the SIDH population, it was 26.2%. The maximum population, which was similar to the Scandinavian population as well, that was with the mild age-related diabetes, that was 35.8%. But the novel clusters also had a huge population, particularly the insulin-resistant obese diabetes, and we know that this could be a indicator that we have quite a good number of the complications of atherosclerotic CVD. And if you see the combined group, it has about 12% of the population. And this combined group has lots and lots of issues as far as the complication is concerned. And again, that also increases the, not only the microvascular disease, but also the macrovascular disease. So if you look at the various characteristics, the SIDH population, yes, early onset diabetes, relatively low BMI and waist circumference, low HOMA-B and HOMA-IR, and high HOMA-IR, low HOMA-IR, low C-peptide levels, high HbA1c, and increased risk of retinopathy, as we saw in the other clusters. And if you look at the MARD, it's again same thing. They're older than the patients in other clusters. They have a reasonably high HDL-C and fairly preserved C-peptide level, milder diabetes, and a low risk for complication. Let's look into the two unique novel clusters in India, the IROD, that is insulin-resistant obese diabetes, where insulin resistance is the preliminary or the primary culprit, but there could be a little deficiency as well. High BMI and waist circumference, high C-peptide level, and increased risk of diabetic kidney disease. As far as the combined insulin-resistant and deficit diabetes is concerned, it occurs at the lower age of onset, and high triglyceride and low HDL-C, which again is the Asian phenotype dyslipidemia, which is seen more in the combined group, and increased risk of retinopathy as well as diabetic kidney disease. So this is what the characteristic or the clinical presentation and the mode of complication which we see in different clusters are represented in different groups. And if you look at the microvascular complications, various clusters, it is definitely, apart from the SID, which is basically the, you can say it is more behaves like a type 1 diabetes, it is the combined insulin resistance and diabetes which has more retinopathy and more CKD in the IROD population along with the CRID population, and CKD both in IROD and CRID population we have high numbers. So considering all this stuff, there has to be a basis of clustering the disease. Definitely we need to identify the subtype. Along with the identification, we need to plan out the management accordingly, and as far as practicable, go to the personalized or precision medicine. So according to current guidelines, metformin and comprehensive lifestyle plays the majority of the cases as the initial initiation medication. But then you have this kind of 5-step approach for a diabetes management. But pathological based management extremely important. Everything revolves around the visceral fat. We Indians have more visceral fat than the subcut fat, and this is how we are differentiated from the Caucasian population. And the majority, that is the reason why we have less, because of the fat deposition in the pancreas and along with the ectopic fat deposition elsewhere, you have a different spectrum around our population, and that will guide us the treatment modality which should be chosen for different group of populations. So basically, wherever I have a less insulin secretory capacity, sulfonylurea, glinides, DPP4, GLP-1 receptor agonist and insulin can be the drug of choice. Wherever you have the ectopic fat deposition, the primary molecule will be metformin or bigonides, thiazolidine, and then after SGL2, DPP4, GLP, etc. So again, extremely important, if you understand the pathophysiology or the different clusters, probably it's become easier for us to plan out the management and at least prevent the complication in that group of population. So currently, what are the strategies as far as management, cluster-based management is concerned? One thing is important, wherever there is insulin deficiency, is mild oral and insulin secretagogue can be used. And metformin happens to be the first of a third, as I already have explained that. And diabetes may also develop in MUD cluster, where probably again metformin could be the first line of drug. SID here, SGL2 should not be the one which should be used because the chance of diabetic ketoacidosis and sarcopenia is high. Let's look at this management in various clusters, and this gives an idea about what should be the initial management. You just look at the mode where actually barring the pharmacotherapy, the non-pharmacological therapy becomes a major factor in modifying the to include that in the management. Weight control, diet and exercise become more pertinent in the MOD. And again, MUD, the major factor again rely along the age of the patient and how you plan out whether it should be conservative or intensive, etc. But as because the glycemia is not of major concern, you should actually individualize the patient and plan out the therapy. But the problem again remains with the multifactorial therapy in adults with MUD, which can be a hindrance, and along with the cognitive dysfunction, lack of adherence compliance, these could be our major challenges. And the population with the insulin-resistant diabetes, yes, that is you have to have a multifactorial or multifactorial therapy, which should be both pharmacological based, where weight reduction should be primary way of managing this group of patients, and along with you have to have pharmacotherapy which can address the weight as well. So this is the way to go about as far as management in various clusters is concerned. So what are the advantages? Again, reiterating what I said, it accurately subclassifies diabetes into different subtypes, helps us to plan the therapy based on the pathophysiology, helps to predict the prognosis and prevent diabetic complication, and most important, it is basically it helps us to come to a nearer to precision medicines. So to conclude my talk, it's extremely important all cause and cause-specific mortality in patients with diabetes have changed over time, indicate transition from the vascular causes. Compared to the traditional classification, we are coming now to the newer classification. Even lots of authors have identified different subtypes. One of the reported journal has said about a Lee et al., who's actually divided into subtypes 1, 2, and 3. So basically everyone is coming out with different subtypes, and then that come closer for us to identify the patient's phenotype as the pathophysiology and plan out the management. So it could be a suitable tool for optimizing the personalized therapeutic strategy, and identifying a distinct subgroup of individuals with type 2 diabetes could be an important implication towards the ultimate goal of coming to precision diabetes. Thank you, friends. Thank you.
Thank you, Dr. Vijay, for excellent talk on cluster-based cluster of diabetes. I think it's a pre-lunch session. Everybody is hungry and everybody is looking towards the lunch arena. So can we take a quick question from one or maximum two? I think everybody wants to get hypertriglyceride and hyperglycemic now, or in a hyper mood. So thank you, Dr. Aravind, for giving us an opportunity to be here, and congratulations to you and to your team.
Thank you, sir. I request Dr. Aravind Jagadish and the chairperson to felicitate the speaker. I also request Dr. Aravind Jagadish to present the mementos to the chairperson. We now disperse for a short lunch break. For the lunch, for the delegates, the lunch has been arranged in the first floor, and for the faculty members, it is in the hall, which is right across you. Please come back for the interesting session, which is there in the afternoon, for the warrior oration and the Kempegowda oration with the topics treating type 2 diabetes in 2020-23, common mistakes that must be avoided, and with the topic Artificial Intelligence in Diabetes Care by the prolific speaker, Dr. A.K. Singh from Kolkata. Thank you, sir. Thank you, sir.
Good afternoon, colleagues. On behalf of Aravind, we will start with the orations, which is the Kempegoda oration from Shashank Joshi. It is an audiovisual one, obviously, so it will be a quite informative one. We've had the interaction with Shashank Joshi also, and he feels that the pertinent topics that needs to be discussed in such forums has to be taken up also. So I think we will start the Kempegoda oration from Shashank Joshi. It will be an audiovisual one, requesting all of you to watch the same.
Hello everybody. At the outset, I am grateful to Aravinda J from Bengaluru, who is one of our most prominent diabetologists in our country, for allowing me the honor of the Kempegoda oration. I am humbled and I am grateful to him for this. I very much wanted to be with all of you in person. Unfortunately, due to unavoidable circumstances, I am doing this virtually with everybody. The topic I am going to discuss today is on artificial intelligence in diabetes. And I am again grateful to Dr. Aravinda J from Bengaluru, one of the foremost diabetologists in the country, for allowing me to talk on this subject very close to my heart. We all here listen. What we listen, we adapt after we learn it. And artificial intelligence has entered all our lives. And I have had some expertise in this area through my learnings through my two engineering friends, which I met by accident, who now work with Twin Health, Dr. Jahangir Mohammed and Dr. Maluk Mohammed. Once again, I thank the entire ADC for conferring this honor of Kempegoda oration. And in particularly, I would like to thank Dr. Aravinda J from Bengaluru for this. So we all know that technology has invaded all our lives, and diabetes is no different, because even in diabetes, technology has invaded very fast. We had the old glucose monitoring devices, the blood pressure monitoring devices, the body composition and weighing scales. And the data, due to the availability of Bluetooth and Internet of Things, was able to be processed through various computers or tablets or phones, and all that were getting into mobile and web applications. Ultimately, we have a lot of data. Initially started retrospectively, now we have prospective or live data also. And for us as a healthcare provider, we or our team members have to decipher this information overload or data overload. So patients are the ones, or people living with diabetes are the ones who get that data, and through technology we are able to deliver it to a care team station, which then now has got onto our mobile phones as apps. And from that we are able to do insulin and medication recordings, glucose recordings, diet recordings, weight recordings, and ultimately we are able to export this data and communicate. Originally, it was a snapshot through the SMBG pathways, and we were able to get prospective and retrospective snapshots like clicking pictures of a camera. Then, of course, CGM technology has revolutionized diabetes care, and we are able to get a proper video recording, even live video recording. And therefore, ability of us as diabetes experts to predict which horse will win the race has become more science-driven and rational. So we usually make decisions on planet Earth either by guesswork or using gut in the past, maybe in the last century. But we have been able to tap engineering and mathematics to develop prediction models using artificial intelligence. And therefore we don't look at whether one is lucky or one is wrong, but we are able to use scientific methods so that we can be accurate, precise, and get into a predictive algorithms. So artificial intelligence is mimicking human cognitive function. That is the meaning of artificial intelligence. And artificial intelligence is bringing a paradigm shift in healthcare by converting various healthcare data and analytic techniques. And we are able to detect early, screen early, diagnose early, treat early, and we can do outcome prediction and prognosis evaluation. And we actually can create a digital twin. This digital twin is nothing but a personalized precision medicine where there is a digital twin of a virtual model of a physical entity with a dynamic bidirectional link. And this is transitioning our traditional healthcare into a very precise healthcare. We are able to pick up lifestyle changes, medication changes, glucose metrics, and we are able to enable the new learning, the new knowledge, the new hypothesis, the new testing, the new comparisons, and then devise and develop highly personalized treatment in interventions. So what is this concept of whole body digital twin which my friends discovered? It is a virtual replica of a real world person, a physical virtual biochemical profile and fingerprinted, which is powered by artificial intelligence like whole body digital twin technology. It has the ability to collect and store, visualize and analyze using digital health devices and sensors, IoT, mobile internet technologies, databases, big data analytics and visualizing tools, including AR, VR, and then based on the inputs, do healthcare monitoring, medicine control, emergency warning systems, treatment plan and protocols, and devise some two-way real-time information exchange and predict individual and patient evolutions and eventually aim at treatment, algorithms and remissions. Modern medicine is full of such examples. Like the digital twin healthcare, similar projects occur in the cardiology world as a 3D model of the heart, or the cardio insights, or the AI-based digital heart design systems, or the blue brain project of the brain, or the aneurysm prediction, or the human airway system, or the multiple sclerosis, or the COVID model which we had. So this whole body digital twin is nothing but human digital twin participating in diabetes management. It is a California-based twin health, which is applying digital technology by modeling patient metabolism. This model, the twin health model, tracks nutrition, sleep, step changes, monitor patient's blood glucose, liver function, weight, and many more data. In fact, it monitors more than 300 metrics. And we are ongoing doing randomized control trials, and Bangalore are one of the centers where these trials are done by Dr. Shaman and his colleagues, where a daily precision nutrition guidance is based on continuous glucose monitoring system, food intake data, machine learning algorithms in type 2 diabetes. So diabetes technology has arrived, and clearly we recognize that in 2021, this is now becoming a standard of care. And it's clearly recognizable that today we are living in an era where we are able to do optimization of the same. And we are clearly adopting this approach. We are also looking at getting diabetes remission for cardiometabolic disorders. And for that, we need to understand the spectrum of chronic metabolic diseases. We know mitochondria is a seed, not just for diabetes, but for obesity, hypertension, dyslipidemia, inflammation, fatty liver, kidney disease, and cardiovascular disease. We have the ABCD model of adiposity-based chronic diseases, the DBCT model of dysglycemia-based chronic diseases, and eventually we are all running in a spectrum of cardiometabolic chronic disease model. And most of our people living with diabetes are living with diabetes with A1C not below 7%. At least 3/4 of them don't have that. And we are burdened with complications of chronic metabolic disorders. But metabolic inflexibility is at the heart of it. It is the mitochondrial inflexibility, where the healthy mitochondria normally allows alternative switching of glucose substrates and pyruvates. And normally when we eat too much, or chronic overfeeding syndrome, or when we have obesity or type 2 diabetes, what is happening? The alternate switching of metabolic fuels of glucose substrates and pyruvate is lost. And clearly we recognize that normal mitochondrial activity balances the fuel intake and normal insulin sensitivity and secretion. So there is a net mitochondrial oxidative activity and fuel availability which is there in biology. And in the muscle, which is the seat of the mitochondria and insulin resistance, the carb oxidation in the fed state, the lipid oxidation in the fasting state, what happens with metabolic inflexibility is that there is an inability of the human body to suppress lipid oxidation and switch to carbohydrate oxidation in response to meal or insulin stimulation. And when there is metabolic inflexibility, we get onset of the entire cardiometabolic spectrum. So fundamentally in type 2 diabetic patients, the mitochondrial respiration is down-regulated to 35%. There is decrease in skeletal mitochondria and oxidative capacity and function and skeletal muscle mitochondrial content. And clearly we see that when this occurs, there is glucotoxicity and mitochondrial dysfunction. And then there are insulin signaling defects. So when the mitochondrial pyruvate uptake and lipid oxidation is down-regulated, the substrate utilization of ATP generation is reduced, the phosphorylation of insulin-like substrate and nitric oxide is down-regulated, and the glucose entry and endothelial dysfunction is down-regulated. And then we get microvascular complications, glucose excess, lipid excess, and blood pressure. So clearly, we now know that mitochondria is the seat of skeletal insulin resistance as well as pancreatic beta cell dysfunction. So it's clearly recognizing that when we have too much of glucose, too much of free fatty acids, when there is long-term exposure of glucose and free fatty acids, it surpasses the adaptive threshold, ensuring excessive lipotoxicity and glucotoxicity, and the ATP generation is down-regulated, and the cellular death or cellular apoptosis occurs. So fundamentally, in the heart and the endothelium, ATP synthesis, mitochondrial density, and electron chain transport expression activities decrease, as well as there is glucotoxicity and lipotoxicity and down regulation of endothelin or nitric oxide. In the muscles, ATP generation, electron transport chain expression activity is down regulated and oxidative stress is increased. In the pancreatic beta cells, the ATP generation is reduced, and in the fat cells, the antioxidant enzymes, mitochondrial numbers, and the electron chain transport components are down regulated. If we don't do good glycemic control, and even if you do aggressive glucose control, the mitochondrial dysfunction doesn't get overregulated. So the ability of the mitochondria to respire and its content is not improved despite of glucose control. And therefore, we need to make a point that we need to have mitochondrial modulators which can make our organ systems efficient and alter modern hemodynamics. So remember, the cellular defect of type 2 diabetes needs correction. And mitochondrial modulation corrects metabolic dysfunction arising out of inappropriate or underutilization of carbohydrate, protein, and lipid substrates. So we need modulators which directly correct this metabolism, which correct the defects of the liver, the pancreas, the skeletal muscle to prevent oxidative stress and insulin resistance. And we have many such drugs. So fundamentally, we are looking at understanding disrupted metabolism. What happens when there is disrupted metabolism, whether it is lipotoxicity, glucotoxicity, genetics and epigenetics, inflammation, you get organ damage, whether it's endothelial damage, type 2 diabetes, insulin resistance, or cardiovascular disease. So fundamentally, when there is disrupted mechanism, where there is disruption of external factors like excess feeding, sleep less, stressful, there is a disruption of vital life-sustaining chemical processes. And when there is a downstream negative effect, every system of the body, there is ensuing of chronic metabolic disease and organ damage. Therefore, we need to understand a lot of landmark studies, including UK PDS told us that beta cells fail over a period of time. And diet, physical activity, BMI management actually can reverse some of these outcomes. And this is an old concept. But in the modern era, things have changed. We have actually inserted a term, new term, which is called remission of type 2 diabetes, which is A1C below 6.5 for more than 3 months without glucose lowering medications. And it's a well-established term. And it was fundamentally discovered by Professor Lloyd Taylor, who said if we eat too much and there is pre-existing insulin resistance, there is fatty liver, which activates the first liver cycle and the beta cell output is modulated. There's a pumping of liver diarrhea of VLDL triglyceride, which makes fatty pancreas, which blunts the insulin response to food. The other biggest dogma we face today in modern medicine is the personal fast threshold. You can see in the MRI picture here and the visual picture that somebody is very obese, may not look healthy but doesn't have diabetes, and somebody looks very healthy and lean and thin but has diabetes. And you can see in these individuals, there is a personalized difference. It is the individual's personalized fat threshold which decides whether diabetes will come or not. It is the fat in the liver and pancreas which will decide whether the beta cells will be susceptible to fat-induced metabolic stress. So in the left-hand MRI slot, liver fat is 36%, there is type 2 diabetes. And if you just lose weight, there is liver fat gone down to 2% and diabetes virtually is non-existent. Also, there is a reversible element when we understand physiology of remission. When we have metabolic cells, the beta cells get exhausted and there is de-differentiation of the alpha and delta cells. When we manage and relieve that metabolic stress, we are able to relieve, and this is a reversible component. This is a functional component on a stunned or exhausted beta cell where de-differentiation and reversibility component is there. However, if there is consistent, persistent metabolic stress, beta cell mass is downregulated, there is apoptosis, there is permanent beta cell failure and death of beta cells and irreversible beta cell damage. So the first half is the functional damage which occurs in the first decade or decade and a half, and this is the element of remission and reversal. Every human being who undergoes type 2 diabetes and is living with type 2 diabetes has a functional damage and a reversible or remissionable component. But they also have an irreversible component when structural damage is already set in. So remember, pancreas is a unique plastic organ which has a unique ability of de-differentiating. And we clearly recognize when there's a loss of beta cell mass, it's mainly the beta cell de-differentiation and not death. Therefore, we can actually restore differentiation of beta cell, and that's having the key insights of unloading and offloading the beta cell metabolic stress. We all live in situations of stress. For example, I very much wanted to be in Bangalore with my good friend Dr. Aravind, but I couldn't be there due to unavoidable reasons. So stress actually triggers biological pathways and effects in type 2 diabetes. So we have a neuroendocrine control, central adiposity, cholesterol, hepatic glucose, beta cell dysfunction, and then we have the sympathetic autonomic discharge causing insulin resistance, hypertension, and central obesity, and we have inflammation which ensues. We are all ingrained in a circadian clock. And in human metabolism, whether it's cardiovascular function, renal function, digestive function, fat accumulation, insulin secretion, insulin sensitivity, we all have a peripheral output. So fundamentally what is happening? Our central clock from the hypothalamus and the peripheral clocks which are there in the liver, pancreas, fat cells, they are all disrupted. Because we are having light at night, sleep during daytime and food intake at night. And that causes circadian misalignment. And these interconnections of circadian system, metabolism, behavior underscore the importance of chronobiology in obesity, dyslipidemia, and therefore we need to recognize that. Unfortunately, in chronic metabolic diseases, there is a catch-22. Evidence of remission in chronic metabolic diseases with eating less, hypocaloric diets is very well known. So is metabolic surgery. But one side doesn't fit all. Some people do beautifully with hypocaloric diets. Some people do very well with bariatric surgery. But most people don't. So we need to have a one-size-fits-all does not work because we have multiple factors. And that is why we need to harness artificial intelligence. Because every human is different. Type 2 diabetes is a very heterogeneous disease. And we need to actually develop, use artificial intelligence, use sensors to harness the metabolic signature of each human being. And it is very important to recognize this fact. So we need to uncover the complex medical conditions to prevent, treat and manage people living with type 2 diabetes, which is very heterogeneous. So the answer is that catch-22 precision therapy. So we need to tailor precision therapy, incorporating all the factors including genomics, psychology, sleep deprivation, physical inactivity, environmental factors including nutrition and hormones. And therefore the emerging approach on the modern approach, the reason we are giving examples of artificial intelligence or twin remission models is, or the whole body digital twin is, that we need to have a precise approach to take into account that individual living with diabetes, the variability in his genomics, in his environment, and his lifestyle for each individual. So good old adage was very easy, just eat less. that was the first dictum in diabetes prevention. And Professor Oris did bariatric surgery and actually caused the first remission data. Professor Taylor then did his elegant direct trial where he is the guru of reversal. And he taught us beautifully that whatever you can do in bariatric surgery, you can actually do the same by just eating less and restore the first phase of insulin secretion and second phase of insulin secretion by just creating a simple caloric deficit in diabetic individuals. And he published this low-calorie meal primary care data in 2 groups. And in 15% of cases, not only it improved and caused weight loss, but also the quality of life. So 50% of the cases, and now there is 4-year data available in this remission, that you can actually cause diabetes remission. They use a very simple approach, meal replacement with low-calorie diet, negative calorie balance is established, depletion of liver and pancreatic fat and remission. And all the gut peptides are administered. Who responded better? People with shorter duration of diabetes and younger individuals responded better. But we need AI. We need to go beyond what surgeons do or what a direct trial can do. And can we develop a whole body digital twin using prediction models of artificial intelligence? Can we believe and do an AI algorithm and create digital twins of the human body? And my friend Jahangir Mohammed, who discovered Internet of Things in Jasper Technology, which is now a part of Cisco, and Dr. Maluk Mohammed, who is a PhD from IIT Madras and runs the incubator hub from IIT Madras Research Park. They discovered the whole body digital twin technology. They created a virtual model of the human body, whether it is a glucose algorithm, the blood pressure algorithm, the weight algorithm, and they were able to predict and do a personalized intervention and develop this whole technology interface with applications so that we can get a patient's digital twin, which is a two-way information exchange, so that we can predict accurately. We can not only just collect and store data and analyze and visualize it, but monitor, respond, and predict very accurately so that we can use it to a meaningful phase. And all such examples are already there, and therefore we are able to now create a diabetes digital twin and get data. But we are living in an era of evidence-based medicine. And therefore, these are data from a randomized control trial. And now it's in its 3rd year, which was presented last year at ADA by Dr. Shamana and myself and the group, where we were able to drop the A1C, the fasting blood sugar, as well as the time in range significantly. Not only that, body weight, waist circumference, BMI, all statistically reduced. And metabolic markers, including blood pressure, improved in a multi-center randomized control trial of twin precision technology or whole body digital twin. Beyond that, lipid profile and visceral adiposity index improved, and various other metabolic markers like fat liver score, atherosclerotic score, as well as inflammatory markers reduced. So eventually, step by step, we can stop medications. Somebody is in stage 6 of diabetes with 3 medications, we can reduce that. We can move them to the stage 5 dual oral therapy. We can use them to metformin monotherapy with the EA1C between 5.7 and 6.4. We can move them to stage 3 of diabetes, no anti-diabetic medications with A1C between 5.7 and 6.4. And we can move them to stage 2 of an A1C of 6.1 without anti-diabetic medication for less than 1 year. And eventually stage 0, where less than 5.7 without anti-diabetic medication for more than 1 year. So it's clearly possible that we can look at a stepwise, stage-wise reduction using precision nutrition and staging, using digital twin technology enabled medicine. So clearly more than 75% of cases can drop their A1C down to a statistically significant level. And really this is the future of glucose management coming in the future. We were able to present this data at the ADA 82nd session last year. And we have more data coming out at the Endocrine Society meeting, which is coming up very much in June, coming up in mid-June at Chicago. We have 4 late breaker abstracts there on the same second year data which is coming up. So artificial intelligence has arrived in diabetes because we know that we are all human beings which are very different. And we are seeing it in everyday's life. Everybody has a smartphone. If you search anything on the smartphone, immediately the AI of the smartphone recognizes that you searched an option of flight or you searched an option of searching a financial query, and immediately will start popping up of things which will be related to that. Similarly, we are using the same technology now for predicting human individual metabolism, getting inputs of genomics, epigenomics, and environmental factors. And then we can use different behavioral and human interventions and environmental interventions for prevention and treatment, also correct the biological clock. For example, sleep more, sleep on time, sleep right. We can use precision medicine to disease treatment like diabetes. And we can take into account every individual's ability and variability, the biovariability of genomics, environment, and lifestyle. We can study external factors like nutrition, sleep, activity, and stress, which disrupt these chronic metabolic damages. And we can create a whole body digital twin with the help of artificial intelligence, Internet of Things, and create a metabolic twin for an individual to assist doctors and get long-term insights and predict and heal metabolism. Eventually, my final take-home point, and again I'm grateful to Dr. Aravinda for giving me an opportunity to speak here, is we are all here with a single goal. We are 8 billion people on planet Earth. We have 500 million people living on planet Earth with diabetes and another 500 million or 500 million living with pre-diabetes. So almost 1/8 of the world, which is 1 billion people of the world, have pre-diabetes or diabetes. And it's very, very imperative that we have a prevention mantra to prevent that diabetes across planet Earth. Therefore, we need to eat slowly, we need to eat on time, we need to eat less, and we need to have a large meal in the morning and try to skip dinner. We need to eat right, we need to do a lot of physical activity and yoga, we need to sleep well for a good 6 to 7 hours, and we need to sleep on time, and of course be smiling. So it's clearly recognizable that artificial intelligence can be harnessed and we can develop a behavioral habit breaker, a circuit breaker in habits. Because type 2 diabetes development is all about wrong habits. And habits die hard, they say. But if we are able to recognize, predict, plot, and make a behavioral change. For example, all of you all, if you all sleep well and sleep on time, we can definitely make a difference on type 2 diabetes management. And the entire team of ADC for this wonderful meeting and for conferring me the Campagoda Operation. I'm grateful to him and I'm really thankful that we are born in best of times but worst of times. And I hope that we can harness artificial intelligence better to ensure that we can clearly make people living with diabetes, their lives better, their lives happier, and they can be disease-free or complication-free. Dr. J. Aravinda, I'm grateful to you and thank you once again for a patient hearing.
So thank you, sir. That was an wonderful deliberation for a very aptly chosen topic for a Campagoda oration. He, like Dr. Shashank, yesterday night also was there. He was discussing about the possibilities, but unfortunately, or fortunately, he is taking as a president of Indian Thyroid Society, so he has to go to the Cochin. That's the reason last moment, midnight, he made this recorded talk and he said, thank you, sir, once again. So we'll move on to the next session.
Moving on to our next session, we now have the chairman, Dr. Kannan Natarajan, diabetologist, Apollo Clinic, Chennai, and the other chairperson, Dr. Prashant Shankar, diabetologist, Dr. Prashant Diabetes Circle from Kerala. We welcome you, sir. Please give them a huge round of applause, everybody. Over to you, sir.
Once again, I thank you, Aravinda, for the great opportunity given to me. Dear friends, now we have an interesting and important topic which is usually facing in our routine clinical practice. We know that this compound, SGLT2 inhibitors, made the whole diabetes care algorithm from the patient-centric approach to the cardiovascular and renal care approach. Even though we have a lot of challenges in this molecule in the human biology, we're producing a lot of GTI and UTI. As a diabetologist, what should know regarding this prevention of UTI and GTI, regarding with SGLT inhibitors? For that, we have the eminent and enlightening speaker and our mentor of CME India. We are learning and excited and Heart Research Center, Dhanbad, and the chairman RSSGI Jharkhand. He's the executive committee member, National RSSGI 2022, ex-chairman of API. He's an admin and founder of our CME India WhatsApp group. We are enjoying this wisdom and knowledge of CME India. Thank you very much. So over to you, sir.
Good afternoon. I'm really delighted. Even after post-lunch session, so many delegates are there. And Dr. Sasan just telling that a smile. So great thanks to Aravinda. He keeps always smiling. Thank you very much. And keep us fresh always. This topic, I have not seen that anywhere in the diabetic conference. As a main topic, it has been discussed, respected chairpersons. So why this topic was chosen, and I'm really to see here, what I am going to tell you or show you, this is all taken from our CME India group great discussion. Once how it happened, I will show you. In the last, today oration is Dr. Avdesh Kumar Singh, AK Singh. He commented, the saddest part of this story is, while the whole world had agreed and keep faith in SGLT2 inhibitors as a first-line drug, here we are trying to know the GTI-UTI issue of SGLT2 after a nearly decade of use. So you will be the great judge whether this topic needs discussion or not. Well, everybody is aware that these days the SGLT2 inhibitors are the star in the treatment of type 2 diabetes, decreasing heart failure, decreasing nephropathy, decreasing CV disease. But just to tell you that these are also associated with a higher rate of GTIs and other than if you compare with the other anti-diabetic drugs. And if you think about the UTIs, definitely that incidence of UTI between SGLT2 inhibitors and other anti-diabetic drugs are inconsistently reported. This you can take as a take-home message. What happens? You're using the SGLT2 inhibitors, urinary glucose excretion reaches up to 90 grams per day. Average daily volume of the urine excreted equates to a urinary glucose concentration of 30 grams per liter. And you know, this is roughly equivalent to that of the agar, that preferred growth medium for optimal yeast culture, including the candida. So it provides a biologically explanation for the observed increased risk of GMI. Other underplayers are also there. So mechanism of increased risk is that it includes increased adherence of candida to the genital tract and reduced host immune response in patients with the type 2 diabetes. And this combined with the further increase in glycosuria in patients on SGLT2 inhibitors therapy and pre-existing anatomical abnormalities of the urogenital tract, this may predispose to complicated UTI. So this is very, very important these days that you should be aware. You can see a number of systemic reviews and meta-analysis to date have shown a 4 to 8 times increased risk of this genitourinary tract or infections in patients taking the SGLT2 inhibitors. So this is not a small data. If you think about the postmenopausal diabetic women on the SGLT2 inhibitors, there is still not clearly established due to a scarcity of evidence. Circumcision in men is associated with maintenance of genital hygiene, which is indirectly related to lower incidence of genital infections. So now the question comes, well, this happens, and this has been well documented. So how much is the threat? It was the FDA issued a warning about this risk of complicated UTI in patients taking SGLT2 inhibitors in 2015. After 9 cases of complicated UTI were reported from March 2013 through October 2014. So this is how the story started. And today we are well aware that the GTI is a common comorbid condition encountered in diabetes itself. And I just told you that the glycosuria caused by this drug predisposed to the development of GTIH, that is balanitis and balanoprostatitis in men and vulvovaginitis in women. These are the main things which is happening, and this GTI occurs more commonly in uncircumscribed men, and Candida albicans was identified as the most common pathogen. So I think the pearl number one, the lesson number one to know about this. I'm not going details of those studies. This post hoc, which if you think about any specific SGLT inhibitors like Cana or DAPA or EMPA, which one is safe, you can see from one Indian study itself that it almost the same, apart from there is also one study which showed that 3 and 6 month incidence of genitourinary infections among type 2 diabetes was higher in DAPA and EMPA. So how it happens, I told about the predisposition factors regarding the adherence of bacteria to the uroepithelium and immune dysfunction, and precise role of glycosuria as a causative factor for this infection is yet to be fully known. So now the question comes, why not all our patients on SGLT2 inhibitors develop GTI or UTI? So what are the predisposing factors? Is it the poor hygiene, or using corticosteroids, or pregnancy, estrogen, oral contraceptives, or warm environment, or tight clothing, or loose clothing, or anything more, some anatomical abnormalities? So there are not established factors, but definitely something is happening which we are not able to understand at present. And from one study, they showed that if the diabetes duration is more than 10 years, overweight, obese, BMI, then factors associated with UTI alone include elevated HbA1c and eGFR of less than 6. So these are also correlated. Now the second point to discuss is, if suppose I want to start SGLT2 inhibitors, should I also add the DP4 inhibitors, gliptins? Again, this is a very debated topic. But I will say that whether using the gliptins with SGLT2 inhibitors modulate the risk reduction, because it has been found in studies that there is slightly lower rates of GTIs reported with the fixed drug combination as compared to SGLT2 monotherapy. And some of the probable reasons for such moderation of GTIs with FDC could be the interaction of DP4 and SGLT2 proteins at the renal tubular cell membrane level. And second, the inhibition of the DP4 enzyme present in certain pathogenic microbes that may render them inactive. But remember, this is still today not an established fact. But this is what we are thinking. And again, a second point which is very important from the studies regarding whether it is better the simultaneous combination of the gliptins and the gliflozin, or whether it is better to give the sequential combination. So what the study says, remember, if you are using it from the very beginning at the same time, this very important paper says that the risk of genital infection has been found increased in sequential combination subgroup, but not in the simultaneous combination subgroup. Could maybe it is GTI or UTI, same thing has been found, you can see here, or you can see here also. So this point is also important, that sometimes it can work, and it works when you combine from the very beginning at the same time. So this is a second point which I wanted to tell you. So overall, the results of analysis of all these things suggested lower risk of GTI and nominal reduction in incidence of UTI when you use at the same time as opposed to sequential combination. So this is the lesson number 3. Now what is happening in the real world? You see here, real world stories. This was October 15 last year. Dr. Meena Chhabra from Delhi presents this case in our CM India group. 50-year-old diabetic male, history of burning maturation. Here it shows two things you remember. The ketone bodies are positive, 3 plus, 150. And you can see here that the glucose is there, okay, and pus cells are 10 to 15. So here again the question comes, this here why urine ketone is there. Should we use SGLT2 inhibitors or not? Again, this is a very, very important question. And she says, does he need antifungal at this moment? Did he have UTI or culture, no bacterial growth? But when the urine culture and this came, the Candida albicans isolated after 48 hours of aerobic incubation. So this is how then this discussion goes on. I think Dr. A.K. Singh is here, and most of the things I am telling you, it is from his wisdom. So now that Dr. Avadhes says here, you remember this important point, that presence of urinary ketone is not a contradiction to use SGLT2 inhibitors. Ketonuria on SGLT2 inhibitors without ketonemia is very common. So this is your words, and so I think this is a great wisdom, great lesson, and my lesson number 4. This is from all our group. Then Vijay Arora from Dr. New Delhi says that the need of a proper gynae checkup is very important. He recently encountered a 78-year elderly diabetic female on SGLT2 inhibitors who was getting treated for repeated urine cultures positive by different colleagues, was found to have pyometra and cervical malignancy. So again, here comes a lesson, and this is quite obvious. Then Dr. A.K. Das from Muzaffarpur asked, don't the SGLT2 inhibitors put the elderly population at risk of UTI and life-threatening urosepsis while preventing heart failure? So what is the answer? Damrish Mittal, I think the giant endocrinologist from this country, he says, if I don't stop SGLT2 inhibitors, the patient does. But it is also true that every day I stop these drugs for 3 to 4% at least because of the side effects. So again, he says that in his practice, the incidence prevalence of GTI was around 25%. But I find in my practice it is something in the tune of 8 to 10%. I asked to many colleagues from the Uttarakhand or different Northeast and other parts of the country, somewhere they say up to 30 to 40%, and somewhere say 3 to 5%, 10%, so it is very, still we are not knowing what is the exact pan-Indian prevalence. So you can see here. So this is how the Ambrish Mittal says, but again, in our group, the final verdict comes from Dr. Avadhes. I am really happy. He says, please note that the highest benefit of heart failure with SGLT inhibitors is in elderly, thus don't deny benefit to them, point number 1. It is a different story that we stop SGLT inhibitors in people with recurrent UTI just for the sake of safety. Similarly, quantum of benefit with SGLT2 inhibitors is more in more frail patients, people who do not wish to prescribe amazing and unbelievable, but fact remains the fact. So there is a dedicated published paper on SGLT2 inhibitors in frail from the delivered trial. So again, this is very, very important lesson from to all of us. But again, Dr. Ambrish Mittal says a patient will not tolerate significant side effects for a perceived long-term benefit. An important aspect of medicine is about keeping the patient free of discomfort also. We should not forget that, and this debate goes on. So, but the point is, your own experience sometimes leads your prescription. You will agree. How you are seeing the things. Then again, in frail patients, there are lots of things are coming, but he say again, this paper says from Dr. A.K. itself that no obviously increase of UTI was observed with SGLT2 inhibitors plus metformin combination. Again, this point is very, very important. So UTI in type 2 diabetic patients receiving SGLT2 inhibitors versus control in randomized controlled trials, what you can find, there is no current RCT evidence showed that SGLT2 inhibitors increase the risk of genital infections. And the effects may differ among SGLT2 inhibitors and trials with different follow-up. So impact of SGLT2 inhibitors on the risk of UTI remains uncertain. The upcoming major trials may prove important insights on this issue. And side effects are always more frequently observed in real-world settings. This is again important to understand. There is no question about that, but my limited point is no data yet hinted the SGLT2 inhibitors has too much increased frequency of UTI. Even in this paper shows that they demonstrated there was no increased side effect with CANAP if you compare with others in the hot climates too. So these are lots of things that are happening. So I will not go in details of all things. Dr. Sasank also commented. But as far as the UTI and the SGLT2 inhibitors are concerned, based on all reports and limited number of cases, a concern for increased risk of urinary tract infection arose, which has become one of the main areas of concern for some of the physicians. But data from large randomized clinical trials and real-world population-based studies have not shown a significantly increased risk of UTI in patients on SGLT2 inhibitors. So this is how the UTI story is there. The pearl is, this concern should not become a barrier in considering the initiation of therapeutic agents. So how much time I have? Over. So 2 minutes, give me 2 minutes. Okay. So restarting, the perennial hygiene is very important. After 3 months of GTI-free status, patients with type 2 diabetes can be prescribed with SGLT2 inhibitors along with the prophylactic antifungal coverage. And this should be avoided in case of a previous history of upper UTIs, complicated GTI, or refractory or resistant GTI. So clinical things you should now, I will not go in detail because my time is over. These are the what is GTIs. You should be aware in these days of when you are using SGLT2 inhibitors about what are the GTI, what is the perennial hygiene, how you are educating your patients, what you are asking for the UTI, what is vulvovaginitis, and what is this one, balanitis, prostatitis. So I'm not going into details of all those, but all points are very important. Just see, and then how you are going to treat it. Like so many topical antifungal agents are there. Again, you should go and read it about the fluconazole. That is a very useful drug for treatment of the candida, and most eliminated unchanged. So I'm not going to detail, but this again, you go and read it. And you know it about the flucytosine, some emerging drugs for antifungal. So again, this prescription or your prescription, the urogenital minorities should be identified and treated. Lastly, then after this, all of the discussion in our group, we have just started Genius study with 42 centers, pan-Indian centers, and we are expected to get more than 15,000 cases. Then we will be able to tell you what is going to happen. I have just started this Genius study. This is just started this month itself. I will not go into detail. So lastly, in 2023, when concept of diabetes treatment has totally changed from glucose-centric to cardio-renal metabolic-centric, and encouraging data for primary prevention with SGLT2 inhibitors is on the door, a judicious use of SGLT2 inhibitors is the need of the hour. And many fears like acute kidney injury, hypovolemia, frailty, these issues are now in backyard. We do not encounter UTI and GTI issue, but again, these can be easily handled. If needed, stopping for a short time and restarting at appropriate juncture with proper hygiene, related information is the answer. And both are generally more common in female than males, mild to moderate in severity, rarely leading to treatment discontinuation, and could be managed using a standard treatment. Thank you very much. So we are doing many, we are also planning a prospective study. Thank you.
Thank you, sir, for that very elaborate discussion on genital tract infections and UTI in patients on SGLT2 inhibitor. As rightly said, it's a topic which is rarely discussed as a single topic. I have a personal question on your personal practice when the patient gets a recurrent genital infection. Do you stop the drug and give the antifungal, or do you continue the drug? Or for what period of time you discontinue the drug?
That recurrent infection should be investigated. I do investigate it, but many times, at least in many cases, I have to, in recurrent cases, to stop the treatment. Because I have experience of at least 5 cases, whenever we started, we got the problem, same problem, vulvovaginitis. So I had to stop it. Sometimes it happens. I think that we should investigate. You can try once, or otherwise it is better to stop in those cases where there is recurrent infections.
Thank you very much for the useful information, sir. I request Dr. Aravind and the chairperson to felicitate the speaker. I also request Dr. Aravind Jagdish to present the mementos to the chairperson. Thank you, sir. Moving forward, we have our next session, and the chairperson is Dr. R. Suman, diabetologist, Madhumeha Diabetes Center, Bengaluru, and the next chairperson is Dr. Sanjay S., diabetologist, Shreya Medical Center, Bengaluru. We welcome you, ma'am. We welcome you, sir. Thank you, sir. Over to you for the further proceedings. Welcome, sir.
Thank you so much. Post-lunch session, actually, quite interesting talks are there, so that we don't really doze off. And we have with us Dr. Tejas Shah, who's a diabetologist and from Mumbai. He's going to talk about non-alcoholic fatty liver disease, an update on diagnosis and treatment. In fact, it's more of a practical aspect what we really deal on this. Generally, what happens is most of the cases when they come to us, they say that, in spite of we not being a drinkers, we still have a fatty liver. What is it? How should we really go about it? To tell us more on that, we have with us Dr. Tejas Shah. Over to you, sir. Kindly just enlighten us in that.
Thank you. Thank you very much, Chairperson, and thank you, dear friend Aravinda, for having me here today afternoon. Good afternoon to all the delegates. So what in the next 15-20 minutes we are going to talk about is something which is a very, very important topic in today's time. We are going to discuss about, I'm going to talk to you about the diagnostic aspect and management aspect of NAFLD. Now, traditionally, it has always been a domain of hepatologists for years, the topic of NAFLD. But gradually, in the last decade or so, what we have been seeing is that this is slowly growing inwards, and it is becoming a amalgamation and bridge to join different specialities, be it a gastroenterologist, diabetologist, endocrinologist, cardiologist, all have been associated with this problem called NAFLD, and that's why it has become such an important aspect of today's times and a part of metabolic syndrome. So NAFLD is one of the most important causes of liver diseases worldwide and will probably emerge as the single leading cause of end-stage liver disease in the next decade or so. What we know is that it passes through various stages over a period of time. Liver is the main area or the main victim which is affected, but there are multiple organs which are affected because of this problem. Be it the heart, be it the lungs, be it the kidneys, the intestines. Every organ overall is slowly and steadily getting affected because of the fat deposition and because of this problem called NAFLD. We traditionally define NAFLD as a liver fat which is more than 5% present in the hepatocytes. There should be presence of insulin resistance and the minimum use of alcohol or no alcohol associated, which is defined as less than 30 grams per day for men and less than 20 grams per day for females, and also exclusion of the other secondary causes of liver diseases. That's how we come to a conclusion that this problem is a NAFLD or non-alcoholic fatty liver disease. It's basically an umbrella term which includes various different conditions included in it. It's basically associated with too much fat deposited in the liver. There are different stages to it. The initial stage, which is only fat or which is only steatosis, is something which we not worry much, or it does not progress much or does not increase the mortality. But when it reaches a stage of more fat deposition with inflammation, that is NASH, it is the more serious form of the disease. It is characterized by liver inflammation and may gradually progress to scarring and irreversible damage, fibrosis, and may ultimately lead to hepatocellular carcinoma, which is the area which we are more worried about. Why does it happen? Well, we do not exactly know the cause why certain people accumulate more fat and certain people do not. You may screen number of people through a sonography, and you may find a fat deposition there like grade 1 and grade 2. A patient may be obese or patient may be lean, you may still find fat deposition there. They are more linked to overweight and obesity, this problem. High blood sugars, hypertriglyceridemia are all the other important causes, more fat deposition, which is more characteristically associated with fatty liver diseases. There are other various markers which have been tried and tested. There is found to be some association with certain genetic polymorphisms also, mainly carriers of PNP, PLA3, and TMF6F5F2 are found to have patients carrying these genetic markers have been associated with more increased chances of developing NASH or developing more of fatty liver diseases. Now, why do we need to worry about this problem? Because it has been associated more with other problems. We know it is a part of the metabolic syndrome. It is more now associated with cardiovascular diseases. It is mandatory for all patients for NAFLD to be screened for type 2 diabetes, to be screened for lipid profiles. But vice versa, it should also be mandatory for all patients with type 2 diabetes to be screened for NAFLD, because what has been seen is that patients with type 2 diabetes progress more severely towards the stage of hepatocellular cirrhosis or carcinoma, and much more faster as compared to patients without diabetes. The prevalence of NAFLD is again around 24 to 25% all over the world. In Asia itself, it is around 27%. And in patients with type 2 diabetes, the incidence increases almost from 40 to 70%. If you look at the figures from India also, the urban areas again have more association of fatty liver disease, almost 16 to 32% as compared to rural areas. But as all other chronic diseases, we are going to slowly see this difference also coming down, and more such diseases are going to come up in the rural areas also. This is an interesting slide because it tells us the entire picture or gamut of how NAFLD progresses over a period of time. Initially, you can have a healthy liver where you will see certain droplets of small droplets of fat can be seen histologically. The hepatocytes are looking normal. The nucleus will be there. As the disease progresses to an initial stage of NAFLD, there could be some changes in the hepatocyte, like the bloated hepatocytes, larger droplets of fats are seen, and displacement of nucleus is seen. Following this, it progresses to a stage of NASH, which is the more severe form of the disease, where you may see more of presence of collagen fibers histologically, and there may be inflamed cells more as well as dying hepatocytes. And then finally you reach a stage of cirrhosis, where you see more of scarring, where you see more of dead cells happening, and remnant of dead cells are seen histologically. So until the stage of NASH, the thing is that these are all reversible stages. If you detect these patients early, with lifestyle modification, with weight loss, or with whatever interventions, maybe you can reverse the stage from NASH to NAFLD, and from NAFLD to a much better healthy liver. But once it reaches the stage of cirrhosis, it becomes a stage of irreversibility, and then you cannot reverse it back to a normal stage. And that's why the importance is to detect these patients much more earlier. Histologically, we see isolated steatosis or minimal inflammation in the early stage of fatty liver, and as the fatty liver progresses to NASH as well as cirrhosis, gradually see more and more of ballooning of hepatocytes, in more inflammation as well as perilobular fibrosis, and eventually cirrhotic changes develop over a period of time. So let us come to why diagnosis, or how important it is to diagnose these patients, and what are the methods that are available to us now to diagnose these patients early. The major challenge is because, again, they do not present to us in a classical way. Presence of hepatic steatosis, more than 5% of hepatocytes determined by histology or by sonography. No significant alcohol consumption enough, or to be, as I told you, defined as recent intake of more than 21 drinks per week or more than 14 drinks per week for females, and no other causes of hepatic steatosis. This is basically the guideline for us to test these patients more. More or less, these patients come to us in an asymptomatic manner. They are usually detected on annual examinations, in routine sonographies, or in routine blood tests, or in routine investigations that do for their medical checkups. 17% of the patients with type 2 diabetes have more significant fibrosis and can be assessed by non-invasive imaging tools. If you look at the guidelines from Association of Liver Diseases, if you look at the EASL, ESD, or ADA, It is mandatory mentioned that in patients with type 2 diabetes and pre-diabetes with elevated liver enzymes, you need to suspect NAFLD and NASH and determine the patient's risk of advanced fibrosis. For screening, basically all patients with obesity or features of diabetes and metabolic syndrome should ideally be screened for this problem. The common methods of screening that we apply or which we are using now is ultrasonography, in blood parameters, the liver enzymes, the FIB-4 index, as well as the fibroscan or the transient elastography. Now, ultrasonography is purely the most simple way to do it, but it has its own drawback because it can only detect a stage of steatosis, but it cannot differentiate steatosis from fibrosis. The other problem with sonography is that it cannot detect enough steatosis also if the number of fat content is less than 30%. So a person has to have more than 30% of fat in the hepatocytes to be actually detected to be in a stage of steatosis also in sonography. When you look at the blood enzymes, the liver enzymes may be normal in 80% of the patients with NAFLD. ALT and AST are not sensitive enough to detect again NAFLD and NASH, and there is a poor correlation that we see between ALT and histology. A patient presenting at NASH stage with histological features may still have an ALT and AST normal or just maybe above normal, but not significant enough, and we may still ignore these reports when we see them. So histologically severity would be similar sometimes in patients with NAFLD as well as in patients who come to us in a normal state. FIB score is a very simple way of calculating or trying to find out the stage of at what stage the fibrosis is progressing. It's a simple blood calculation for which we require an age, the platelet count, the ALT levels and the AST levels. You put these values in this formula where age multiplied by AST divided by platelet count into square root of ALT, and you will get a value of this. So apps are available for this fibrosis score, which you can just enter the data and you can get the score. A level of less than 1.3 is considered to be absence of advanced fibrosis, and more than 2.67 is considered to be presence of advanced fibrosis. And between 1.3 and 2.67 comes into an interdeterminate state where a patient may be at a high risk of developing fibrosis in the future. Those patients who have a FIB score high or who come into that stage should be ideally should undergo a fibroscan or elastography. Elastography or fibroscan again is a test which detects, where it measures the liver stiffness, and it is measured by a mechanically controlled sound wave frequency. It basically measures liver stiffness over a specific area, and again there is a correlation between the liver stiffness as well as the chances of developing fibrosis over a period of time. This has been well validated. It has a 98 to 99% sensitivity and specificity to detect fibrosis or at an advanced stage. It's a simple test, can be done at the bedside. It requires a small machine. The only drawback again with fibroscan is that sometimes it gives false readings in a patient with a very high BMI, about 35. For patients who are morbidly obese, the values of fibroscan sometimes comes wrong, and therefore it is sometimes a drawback with this test again. Fat liver index or FLI is another simple algorithm test. It requires triglycerides, it requires GGT, a waist circumference and a BMI. And again, the fatty liver index it gives a value, and a fatty liver index less than 30 rules out fibrosis, while a fatty liver index more than 60 is supposed to be more predictive of fibrosis. So these are small, simple, non-invasive tests which are being tried nowadays to overcome the problem of liver biopsy. Liver biopsy was always the gold standard and is the gold standard to detect fibrosis, but it's an invasive test. It requires a procedure, and chances of mortality, bleeding, etc. are always higher in that test, and therefore these non-invasive tests are nowadays being tried more. ELF is another test called enhanced liver fibrosis. It is a blood test which is done with 3 serum biomarkers: the hyaluronic acid, the procollagen 3, and the tissue inhibitor of metalloproteinase. And again, there is a specific value window which they have found out that any value between 7.7 to 11 is what they have tried to find out, which is more determinant for fibrosis. Something below 7.6, 7.7 rules out fibrosis, and those above 9 or 9.6 is considered to be more specific for fibrosis. So this is an algorithm which we can try to follow for investigation of patients for NAFLD. For any patient with a higher liver enzyme or patient with obesity or diabetes, you screen them for a sonography. If the sonography detects features of steatosis, you undergo a fibrosis score or an NAFLD score. For a patient with a low risk of less than 1.3, you just repeat the test after 2 to 3 years. For more than 1.3 or at a higher risk, you again subject the patient to FibroScan and to further elastography and to look out for further features for diagnosis. Again, this is a diagnostic flow chart where again patients with liver enzymes and an ultrasound showing steatosis or a liver, or depending on the liver enzymes, if it shows steatosis present or absent. If the patient has normal liver enzymes, you look for serum fibrosis biomarkers, and if again it falls into a low risk category, you just follow up the patient over a period of time. If the patient has a fibrotic biomarkers present or has abnormal liver enzymes, you need to refer it to a specialist further and investigate further for developing advanced stages of fibrosis. Coming to the management aspect of the what we have till now, again, our need to manage our patients with fibrosis is basically to prevent the progression from NASH or NAFLD to hepatocellular carcinoma. 2 minutes? Okay. Weight reduction is the main aspect for treating these patients. What has been seen is 3 to 5% of the patient weight loss is found to have improved steatosis, and 7 to 10% weight loss is found to have improvement in terms of fibrosis. Low-fat diet, Mediterranean diet is found to be useful. Even patients with moderate carbohydrate intake but with a high-protein Mediterranean diet have found to improve in patients with cirrhosis. Bariatric surgery again follows the same principle. Weight loss of more than 10% to 15% is what helps again there to regress the cirrhotic stage or to fibrosis stage. When it comes to drugs, who are the patients whom we should be trying for drugs? Any patient at an early stage of NASH or active NASH with inflammatory activities or patients who are progressing, we know are the patients where drug therapy is what we should be thinking about. Various drugs have been tried, like metformin, vitamin E, PPR GABA agonists, obeticholic acid, but these are all drugs which are still considered to be off-label. Not enough data actually to prove that all these are useful. Saroglitazar is one of the dual PPR agonists which is being tried and which is being recommended by the Indian guidelines. It has its study, it has a phase 2 USA study where it showed an improvement in fibrosis. This is a biopsy-driven study from India from patients with steatohepatitis, again, which showed that patients who were subjected to saroglitazar showed an improvement by almost 52% in terms of worsening of fibrosis. When it comes to vitamin E, the INASL has recommended that it is not to be used in patients with type 2 diabetes. The data does not say that. It is what the PVEN study was done, where it was compared, or where it was done along with pioglitazone, was done only in patients without diabetes, and the mortality risk was found to be higher, in fact, in patients with diabetes. Pioglitazone has still not approved for NASH, but it is recommended. It has shown improvement in terms of fibrosis, and saroglitazar is the other drug which is only approved by the Indian guidelines at this stage. Obeticholic acid is another drug which has been tried, and it has found to be useful. It has shown promising results. There are some small side effects like pruritus and constipation, and it has been tried in a dose of 25 milligrams in patients with end-stage renal diseases. SGLT2 inhibitors, already spoken about here today, but these are the other drugs which have shown improvement. Data is there in the ELIF study with empagliflozin, as well as some positive data coming in with DAPA and CANA. Incretins, liraglutide have shown improvement in decrease of fibrosis, in steatosis, as well as in hepatic enzymes. And we have tirzepatide showing great promising results, which is expected again on liver fat. So to end, to summarize, the drugs which have been shown improvement in steatosis, it is at present pioglitazone, vitamin E only in patients without diabetes. A dosage of pioglitazone is around 45 milligrams in these studies. For drugs which have been shown improvement in lobular inflammation, again, pioglitazone at a dose of 30 and 45, vitamin E and obeticholic acid. And there has been increasing mean reduction in fibrosis has been seen with certain drugs, again, but not proof enough. We may soon find this fourth window in the AD algorithm where we will be choosing a drug depending on the patients whether they have a pre-existing NAFLD or no. The drug of choice again from anti-diabetic basket would be an SGLT2 or a GLP-1 RA or a TZDs to look about. Thank you very much.
Thank you, Dr. Shah, for enlightening us on this topic elaborately. So, see, you have given a lot of information about this topic. So, we'll allow only one question for this session, short of time. So, from the audience, only one question. If there are no questions, we'll conclude the session. Thank you, Dr. Shah.
Thank you.
Thank you for this informative session, sir. I request Dr. Aravind and the chairpersons to felicitate the speaker. I also request Dr. Aravind Jagdish to present the mementos to the chairperson. May we all give him a big round of applause, please. Thank you. Moving on to the next session. Now I welcome our esteemed chairperson, Dr. R. Anil Kumar, diabetologist, Karnataka Institute of Endocrinology and Research, Department of Medical Education, Government of Karnataka, Bengaluru, and Dr. Sudhindra D., diabetologist, Marigold Clinics and Diagnostics, Bengaluru, on stage. Thank you, sir. Over to you, sir.
Well, welcome to the next session. We have RSSDI clinical practice recommendations on the treatment of diabetes. I think this is one of the important topics. The speaker is Dr. Anuj Maheshwari. I think Dr. Anuj Maheshwari is the Governor-elect of American College of Physicians and is the Professor of Medicine in HIMS Lucknow, and he is also, I think, Vice President in RSSDI.
Yes.
So
I
over to
was
Dr.
Vice
Anuj
President
Maheshwari.
completed
I think,
my term.
Yeah, I think we have international guidelines, ADA, ESD, and then ACE guidelines. Definitely, our RSSDA guidelines is different from this because Indian diabetic patient is definitely different from other Caucasians. So I think we will hear from you some important differential points.
Thank you. Thank you, sir, for a nice introduction and context setting. You have really said very rightly that we Indians are different. We are different food habits. We are different way of living. So therefore, our diabetes management may be different than the other countries, and especially for our Caucasian counterparts. Because as if we compare ourselves with the Caucasian counterparts, we are having a racial difference also. So I shall be telling you about RSSDI clinical practice recommendations for management of type 2 diabetes, which have been finally revised in 2022. As we all know that RSSDI is a very active organization in the diabetes care, and at least we are having more than 10,000 members now. And I feel myself lucky that RSSDI has released its first guideline in 2015 at Lucknow, when myself and Dr. Vijmohan, Dr. Narsim Verma was the conference organizer in 2015. So this was the beginning of that time, which we are taking up to the continuously in the consequent years, and now we have reached to the present status. As far as you have very rightly said, Indians are different. Now question arises, what are the difference with which we really are concerned when we talk about the guidelines? Relevant factors to the Indian context are that we are more having the pre-diabetes in our population than diabetes. And many a times this pre-diabetes is not so well recognized. Onset of type 2 diabetes in Indians are also earlier than our Caucasian counterparts and Western population. Apart from that, if we compare with our own onset of the diabetes occurrence in our Indian population 20 years, 30 years back, so we can find that in these 20, 30 years, it has been regressed 10 years earlier further. So earlier when we were doing the MD, it was supposed to be done in the 40 and 50 years of the age to test for the type 2 diabetes. Now we need to do the test for the type 2 diabetes even after the 20 years. We are getting type 2 diabetes patients even less than 20 years also. High prevalence of the diabetes-related micro and macrovascular complications, not a new thing, but more important, our large rural-urban divide. Indians are very much different as far as the cost of therapy and cost of management are concerned. In our country, it is not a state-sponsored health care. We need to care for our own health by ourselves. So again, the cost effectiveness becomes a very important issue. Sedentary lifestyles, physical inactivity, limited resources, psychosocial and cultural factors, adherence and many times poor compliance related to the anti-diabetic therapy. These are the important issues with which we need to frame the guidelines in our different perspective in which Indian population usually survives. So if we talk about the oral anti-diabetic agent, it is always a love for the oral anti-diabetic agent as compared to the insulin and other injectables for management of the diabetes. But decision on the choice of which oral anti-diabetic agent would be working is based on the safety and efficacy. And many a times it is more important to see how many comorbidities are also going on with the diabetes. When we treat a patient of the diabetes, if a person is having the hypertension, if a person is having the dyslipidemia, this will definitely guide us to choose the therapy for diabetes we are going to choose. There are certain newer sulfonylureas which have been recently introduced in last 10 years in the market, like gliclazide, modified release, and glimepiride. They are more effective and less harmful and more safer. I don't want to use the word harmful. More safer as compared to the earlier sulfonylureas which were being used for large time. Thiazolidinedione, a molecule which has been talked a lot once upon a time. It has also been found to be proven worthy on the therapeutic things when it has been given, and it is seen in the same class of the molecule. Rosiglitazone has gone out of the market into 2010 and after that, but this molecule is staying with all its odds as well as its beauties in the treatment of diabetes, especially if the patient is having the dyslipidemia and cardiovascular safety is concerned. Because if we are using this molecule in the later stage when person is already having the heart failure and cardiovascular challenges, then definitely it won't be giving a good outcome. But in early stages, it definitely makes the therapy more better and people remains free of complication for a longer time. DPP-4 inhibitors, multiple DPP-4 inhibitors has been introduced in our country. Many of them are efficient in improving glycemia, both as monotherapy as an add-on to the metformin or any other therapy like sulfonylurea and thiazolidinedione in patient inadequate glycemic control. So once we talk about the injectables, all conventional insulins have similar glycemic lowering efficacy as analog, but with slight increased risk of the hypoglycemia, and lack of flexibility of administration. Insulin supplies should be assured and be of the consistent quality and type, and RSSDI wheel helps practitioner to choose an ideal drug for his patient based on cost, weight, hypoglycemia risk, and other comorbid conditions. So there is a special method of going through with the RSSDI guidelines. RSSDI guidelines has been framed on the basis of the ABCD EFGH approach, and through this approach we encourage the choice of oral anti-diabetic agent to be chosen by the clinician for the patient depending on the needs of the patient in its real perspective. I will be telling you how can we decide those needs at the same time, according to those needs, how can we choose a particular or best possible molecule for any patient. For any type 2 diabetes patient, RSSDI still continues with the idea that for any type 2 diabetes patient, first line of therapy should be the metformin unless it is not tolerated by the patient or contraindicated. So first is age. Age is the consideration through which treatment should be individualized. Like if a person is having a lesser age, we are free to have any molecule, but when the person is increasing with the age and having the comorbidities together, many a times patient ends up in the complication, then some of the molecules gets restricted in older age, like pioglitazone, like sulfonylureas becomes more risky in the higher age group, and obviously insulin is always a need of the hour, so whenever it is required, it is mandatory to be given. But older patient and patient those who are in the geriatric age group, they tolerates not so well the insulin. B is the BMI. The agents which are available, oral anti-diabetic agents which are available with us, if we make them grading in down care of the weight management, then we can see that SGLT2 inhibitor is the highest in the therapeutic line which takes care of the weight management, best followed by the GLP-1 receptor agonist, and then alpha glucosidase inhibitor and DPP-4 inhibitor, which are supposed to be weight neutral, but Indian population have been found to be losing weight with these two molecules also, followed by the sulfonylurea insulin, which are supposed to be having somewhat weight gain. C is the CKD, means if there is CKD, we have to choose the medication as per the status of the CKD in the patient. If the eGFR is between 45 to 59, then we should use the metformin very cautiously. Between 30 to 44, we should use the metformin in the 50% reduced dose, and if it is less than 30, then metformin should not be used. So again, the RSSDI says metformin is not a cup of tea for each and every diabetic. If you are running with CKD, if your patient is having CKD, then you need to look for the eGFR before giving the metformin. Apart from these, some of the molecules which are the short-acting secretagogues, as well as sulfonylurea like glipizide, gliclazide, can be used in the low doses. Alpha glucosidase inhibitors should not be used if the serum creatinine is more than 2, and DPP-4 inhibitors can be used at any level of the eGFR, but certain DPP-4 inhibitors like sitagliptin and vildagliptin should be reduced with rare doses. Duration of diabetes is another parameter which should be considered whenever we are deciding the treatment for the patient. If a patient is having long-standing type 2 diabetes, it becomes a little bit difficult to treat, and we need multiple medications together. But now we are gathering some data in which we can say that even in the early stage of the diabetes, we start with the dual drug therapy. It takes our patient for a longer time without treatment or up titration of the treatment, at least for the 2 times of the years as compared to the when it was started on the monotherapy. So effectivity of the medication increases twice if it is started in the dual therapy in the early stages. But in the duration of diabetes is more, obviously, SGLT2 inhibitor and GLP-1 receptor agonists are the medication. They don't gets affected with the duration of diabetes. Either you are using them in the early part of the disease or you are using in the later part of the disease. Alpha glucosidase inhibitors can also be effective owing to their beta cell independent action in any stage of the disease. But those molecules which are dependent on the beta cells and their activities, they are having their activity little lesser, or they lose their activity with increasing duration of the diabetes. Established CVD is again a very important factor through which we should decide the choice of the molecule. And established CVD, actually CVD is the thing for which we are treating the diabetes. Cardiovascular disease is the biggest threat because of what we think about treating the diabetes. So UKPDS has suggested that intensive glycemic control can reduce the cardiovascular risk and microvascular complications in patients with type 2 diabetes. Later on, some of the studies has come which said that if you are treating aggressively your patient, then there are higher chances of the hypoglycemia, and many a times we could see that accord kind of the studies in which more patient has been died in the aggressively treated arm of the type 2 diabetes. But always it is more important to understand that only those people will not tolerate the aggressive treatment who will not be having good control in their early part of the disease. What exactly happens in our country, this practice is very common. When the patient comes to us, we keep on delaying the therapy for 5 years to 10 years. Many a time patient does it on itself. Many a time patient says that our family member, my family members are not ready. They are saying you are too young to start a medication. Once we will start a medication, it will go on throughout the life. So I want to start medication. I will continue with the lifestyle medication. Doctor, give me one more time. I will come with the good control of the diabetes next time. So all these excuses go on in the air, and because of what its treatment keeps on delaying, and this delay actually loses the metabolic legacy. It loses the metabolic control, which can be continued throughout the years after starting early. So what exactly happens? If we want to avoid the cardiovascular disease in the later life, we need to start the therapy in the early part of the disease. Finances. Everybody knows the finance always remains the biggest issue in India. Most of the Indians are doing the treatment on their own therapy, on their own cost of therapy bearing. They bear all the therapies from their own pocket. So always it remains a consideration for a clinician to decide the therapy which can suit to the pocket of the patient. Worsening glycemic control is another important thing which should be considered while ordering of the glucose lowering agent. Order of the glucose lowering agents in order of their efficacy or HbA1c reduction is starting from the insulin, then followed by the GLP-1 receptor agonist, then SGLT2 inhibitor, pioglitazone, DPP-4 inhibitors, then followed by the modern sulfonylurea and alpha glucosidase inhibitors and glutamate. Hypoglycemia is another biggest concern. Most of the medications now which are in the market, they are not having the threat of the hypoglycemia like SGLT2 inhibitor, GLP-1 receptor agonist, and DPP-4 inhibitor. But once these medications are being used in association of the insulin and in association of the sulfonylurea or other secretagogue, they start, or they many a times increase the effectivity of these molecules, and they cause the hypoglycemia. So I'm coming to the end of my talk. Before giving this RSSDI therapeutic trial, therapeutic wheel is important to show all of you. And I must tell how it is to be used. Many times the patients are keeping this therapeutic wheel, clinicians are keeping this therapeutic wheel on their table, but they are not using it because many a times it is difficult to interpret for them. But actually it is very easy. RSSDI has given the best thing to the members of it and other clinicians of the country. They can very well decide the therapy, the best suited therapy for their patient using this therapeutic wheel. As you can see here, A stands for the age, B stands for the BMI, and I have already told you in my previous slide, A, B, C, D, E, F, G, H, what the mean of this. Now you see and you come over to the wheel. In wheel you can see that lifestyle modification is in the center stage where you can see the black thing is being seen. and it is surrounded by the metformin. Metformin is not seen only in one segment, that is the CKD segment. CKD segment, you don't need to use the metformin, and metformin is not the cup of tea for the people, those who are the CKD. But in rest, all the patient, metformin should be the initial therapy after the lifestyle modification. Once you are going from inside to outside, then you can see in each group there are the medications which are being listed there, and if you go in the clockwise direction, this is the preference of the medication. For example, if in the C group you are going, C stands for the CKD, the SGLT2 inhibitor in the number 1, and then DPP4 inhibitor followed by the insulin, then sulfonylurea, GLP-1 receptor agonist, pioglitazone, and AGI. In the last part, where is the red is the extreme stage of that particular thing for which that is that group belongs. Like CKD, patient is in the end stage of the CKD, that designated with the red, where you can use only the DPP4 inhibitors and insulin. Similarly, in the age, the red part is showing the extreme age, where you can use the medication in order of this, what has been given the clockwise. DPP4 inhibitor is the best one, followed by the alpha glucosidase inhibitors, and then others can be used. So this is the hierarchy of therapy which is depicted in clockwise manner. In this wheel, any of the drugs can be used in the green, and for other zones, drugs must be used in the given order, that is the clockwise. So this is the method through which you can use the RSSDI therapeutic wheel. I have already explained it. Thank you very much for your kind listening.
Thank you, sir. Thank you for that wonderful presentation. I think we as clinicians should know the guidelines. We should update the guidelines also, whether it is ADA, ESD, IDF, or our local RSSDA guidelines. And we should see update also. Periodically we should update. Otherwise we won't know. We'll just be practicing this diabetic drugs. So sir has beautifully shown. And if you see the textbooks, and if you want to go through, it takes so much hours. So in short and sweet, sir has beautifully updated in a short span. So nicely has been, short and sweet he has been explained. So quick one question, I think, because we are lacking of time, one question can we take up? Because it's a very interesting topic. Because without clinical practice and RSDA guidelines, we can't practice diabetes. Whether it is physicians or diabetes or endocrinologists, we can't practice medicines only. So one question, I think all our practitioners may be having a lot of queries regarding this. If there is no, I'll end up the session.
We are seeing more of young type 2 diabetes patients. Do you have any specific recommendations in RSSDI for that?
Pardon, sir, you asked something?
Type 2 diabetes,
yeah.
We are seeing more young patients, as you said, 20 years, 25 years. We are
Yes,
seeing
for
more.
that there is a segment, that is the age segment. If we are starting in the young age for any treatment, first the treatment should be started if the patient has crossed the diabetes diagnosis cutoff for the blood sugar level. Many times it happens people crosses that cutoff, still they delays their therapy. This should not happen, because it will lose the patient's metabolic legacy. So if we don't want to lose the legacy effect, we should start it early as possible. Now your question is very good, which is the best therapy to start in the early age? I believe that again the DPP4 inhibitor is the best therapy to start in the early age, because at that time the patient will not find any difficulty in using that. This is the free from hypoglycemia. Together with metformin, DPP4 inhibitor, metformin can be used together as a combination, like Verify trial. Verify trial has shown that if you are using the metformin and DPP4 inhibitor together, you can continue at least for 6 to 7 years. You won't require any addition of the medication or won't require any increase in the medication. Otherwise, you need to add any medication after that 2.5 years or 3 years. So that is the best combination to start in the youngsters.
Thank you.
Thank you very much, sir. I request Dr. Aravind and Chairperson to felicitate the speaker. I also request Dr. Aravind Jagdish to present the mementos to the Chairperson. Thank you, sir. Moving on to the next session, we now have Dr. Srihari Kulkarni, diabetologist, Manipal Hospital, Kulkarni's Medzone, Bengaluru, and the second chairperson, Dr. N. Prakash, consultant physician and diabetologist, Church of South India Hospital, Bengaluru. Thank you, sir. And we welcome you, sir.
Good afternoon, everyone. Coming to the next topic, we have Professor Jayant Panda from Cuttack. He will be speaking on statins, the numero one therapy for dyslipidemia. Over to you, sir.
Thank you. Thank you, Dr. Aravind. Thank you, chairpersons. Thank you, my many good friends here. It's an opportunity to be nearer to the Raj Bhavan and the Vidhan Shodha on day of swearing in, and lot many shines since morning. And it's possible only because of the academic initiative of my good friend Aravind Jagadish. I mean, even in COVID time, we were missing this, and this fellowship, this shines, these interactions, I am enjoying fullest. Thank you for the hospitality. Thank you for the opportunity. And give a big hand for Aravind. He deserves it. Who has single-handedly brought this Dr. Arvind's Diabetes Update, Diabetes Summit to all of you. I'll be very brief in the interest of time. First, I'd like to know how many of you give statin to your patient who has a normal lipid profile, maybe other metabolic issues like diabetes, like obesity, like hypertension, like family history of different diseases, but the lipid profile is normal. Many times you will face a resistance from your patient. Sure, मेरा तो lipid normal है, आप ये दवा क्यों दे रहे हैं मेरे को? Many times they'll come and ask you. I'll show you in next 10 minutes the evidence. Why should we use statins in the people who have a normal lipid profile, and the CV risk reduction, how is feasible in a patient who is still having a normal lipid profile. So how many of you, I saw 1, 2, 3, oh, few. Okay, that's fine. So I'll show you a very beautiful case report. This is a disclosure. This session is sponsored by AstraZeneca. And this patient, 42-year-old male, corporate worker, both parents diabetic. He's a hypertensive, diabetic, and smoker. And on metformin and dapagliflozin with a blood pressure 150/90 and A1C 7.1. LDL is 139, HDL 42, triglyceride 160, and if you see a lipid profile 6 months before, it was 143, HDL was 41, and TG 172. So not much change in the lipid profile. And he was asked for the lifestyle modification. No medication for dyslipidemia. As usual, we think the LDL is 139 and the triglyceride is normal. Why to give? So does he need any therapy for managing diabetes and the dyslipidemia better? How many of you think that this person with this much of risk requires a lipid in his regimen? Please raise your hand. Good. Let us see facts. Lipid lowering therapy accounts for more than 70% of severe risk reduction in diabetic patients. I taken 3 risk factors. One is a systolic BP, one is A1C, one is the lipid. And this is what is called EUCOPDS risk engine. And this cardiovascular risk in the type 2 diabetes patients are put in Steno 2 study, calculated, and single lipid accounts for 70% of severe risk reduction. So we have to evaluate the patients for dyslipidemia management as a primary prevention. You all know about the Uranus study, where type 2 diabetes with LDL more than 127.6 are taken. And see here the LDL cholesterol, the LDL HDL ratio, and the non-HDL cholesterol, as well as rise in HDL. All four, the rosuvastatin scores over atorvastatin in the Uranus study. We know the history of statin, how Pitava come, how Simba come, how Atorva came, how Rosuva came. Out of all existing statins, the mostly used statins are now rosuvastatin and atorvastatin. And you will see the order of invention and their utilization by the physicians. Still, perhaps atorva is preferred to rosuva. And I'll show you some evidences in favor of rosuva, because latest addition is the rosuvastatin, and the dose is also half that of the atorvastatin. Jupiter, all of you know the justification for the use of statin in primary prevention with more than 17,000 patients. Here, it helped reducing LDL cholesterol levels by 50% in a year. Why reducing by 50%? The change in lipid parameter in the HSCRP was taken, targeting the LDL cholesterol reduction of 50%. So, say it be a rise in HDL, triglyceride, HSCRP reduction, but the LDL reduction 50% was achieved by the rosuva in Jupiter. And not only the LDL, if you see this other combination of risk factors, the macular infarction, the stroke, the CV death, unstable angina and revascularization, the fatal or the non-fatal stroke, all-cause mortality in the CKD, and CV events in CKD, and fatal or non-fatal MI, around 50% reduction in the CV continuum was seen across. So what the European Society of Cardiology and the American Diabetic Association guidelines recommend? I have already told you about targeting 50% reduction in LDL cholesterol. The CV events reduce significantly. So in a high-risk patient, the LDL cholesterol decision making could be based on the net benefit as number needed to treat. And if you will see that, here the score achieved by LDL cholesterol number needed to treat or NTT to prevent the event comes around 50% of the number. This is a very important diagram, and I'll relate it to our Indian Lipid Association of India guideline. This stratification by European Society of Cardiology to very high risk, moderate risk and low risk, where the target of LDL are fixed to less than 55, less than 70, less than 100 and less than 116, the LDL cholesterol, are defined by different events like diabetic with target organ damage, at least 3 major risk factors, early onset of type 1 diabetes with long duration of more than 20 years as very high risk, without target organ damage and duration 10 years, another additional risk factor, high risk, and young patients, diabetic duration less than 10 years with other risk factors, calculated score is more than 1, less than 5% for 10-year risk of fatal CVD is moderate risk, and it's less than 1% calculated score, 10-year risk of fatal CVD is low risk patients. This stratification is followed worldwide, and a high intensity, moderate intensity, low intensity statins are advocated. The Lipid Association of India and the Indian Lipid Guideline has come even up to 30 mg/%. Here in European Society of Cardiology, you see it's ends at 55. the LAI has reached the 30 milligram percent in its latest guideline. And stratifying this, you have to decide the dose of statin. May it be 20 milligram atorvastatin or 10 milligram rosuvastatin, or higher to moderate and the high intensity. The intensification of statin to be considered before the combinations, which many of us don't do. We combine. There are more and more combination drugs. Fenofibrates, azitimib, seroglitazar, many in the pipeline. But how many of us have used 40 milligram rosuvastatin or 80 milligram atorvastatin in the high risk group, which I have already shown you as a very high risk group? Maybe around 70% of your patients will be very high risk as per the stratification. But we get afraid to go to 80 milligram atorvastatin. If you see the criteria, 50% on the baseline. This, we have to remember the LDL cholesterol at the time of risk, whatever is there, to target at the 50% reduction, and the intensification should be considered before the introduction of combination, and if goal is not reached, the recommended molecule is azitimib. Similarly, the ADA guideline, the primary prevention in 3 groups they have done, 40 to 75 years. They are just in moderate intensity statin therapy, 20 to 39 initiating statin, and this group with high risk, multiple atherosclerotic cardiovascular disease, 50 to 70 years, reasonable to use high intensity statin therapy. This is a story which all of you see every day. Diagnosed diabetes, 5 years, 10 years, 15 years, and the complications go on increasing. Smoker, overweight, hypertension, dyslipidemic, heart failure, CKD, atherosclerotic complications, cardiorenal complications, repeated heart failure, and patient goes to face the complications or the mortality in the due course. The 15 years down the line, the problems are increasing and increasing. So in this continuum, all of you come across, the conditions are shown above and the interventions below. The different drugs are listed. The NYHA class 2, the ST elevations. If you ask, does it need any therapy for managing sympathetic overactivity, sudden cardiac death, post-marcal infarctions? Many of us don't realize. The autonomic neuropathy is a big problem. People have sympathetic issues, and many people have a dead-in-bed syndrome or a silent macular infarctions, and we lose them without a proper cardiovascular risk reduction. The strongest contributor to Indian severe risk is dyslipidemia. Please, please, please remember. We know about smoking, weight, diabetes, hypertension, past history of macular infarction, but the strongest risk, strongest contributor is dyslipidemia. You see all these listed factors from the Interheart study. The dyslipidemia appears to be the strongest contributor to the acute macular infarction in Indians. So, does rosuvastatin 5 milligram work? Need for aggressive statin management? If you go through the guideline, you'll realize. And rupture of the vulnerable plaque, the plaque stabilization. Do you consider while treating the patient? What does the European Society of Cardiology recommend? You will see the level of evidence. Very high risk patient, the LDL cholesterol target, they have decreased in 19 from 70 to 55. What I was telling, it has come down to 30 milligram deciliter in Lipid Association of India if you browse today. The patients should start with high dose statin regardless of LDL cholesterol baseline, because they have unstable plaque and they require the plaque stabilization to decrease the morbidity and the mortality, which hardly we practice. And high potency statin at the highest recommended tolerable dose to reach the goals has to be planned. So without misery in deciding the dose, we have to give high risk patients a high intensity statin therapy before we go for addition of azithromycin. Which statin to prefer, that already I discussed. The 20 and 40 milligram rosuvastatin improves the lipid profile compared to 80 milligram of atorvastatin in ACH. We have a inertia of writing atorvastatin. It's a good molecule, there is no issue, but rosuva is efficiency-wise half the dose, and it has been clearly shown that the 20 milligram and 40 milligram both, if you roughly see 80 milligram atorvastatin comes at par with the 20 milligram rosuvastatin, and the LDL reduction always comes better. In the steroid trial, the plaque regression has been proved very effectively, and this is the index, lipid core Borden index in the percentage change post-ACS patients for prevention of the post-ACS complications is very informative about the action of the rosuvastatin in this trial. And the non-culprit lesions, this is a very important fact. I'll take a minute more to tell you that suppose you have dealt with a culprit vessel, the next lesion, next macular infarction, next ACS, it's from Swede Hearts Registry. The real world observation told that the first time MI patients underwent PCI with a vessel which is a non-culprit lesion, and to shape those non-culprit regions, you need statins in the high intensity doses. And then take less than 80% of their statin doses, the 45% relative increase in the total mortality, and you can see all these factors, the adherence to aspirin, statin, beta blockers, CBD, all favors good adherence of these cardioprotective drugs. Safety, it's a hydrophilic drug. The rosuvastatin is a hydrophilic drug. Against atorvastatin is a lipophilic drug. You see, most of them except Prabha, which is hardly used, are lipophilic. Pitava, Lova, Fluva, or lipophilic. And it doesn't target the non-CYP450, hepatic and renal both excretion, making liver not vulnerable, and the T-half is long, giving round-the-clock protection, and effect on the food and bioavailability is almost not there, food not affecting the absorption. These are the dream pharmacokinetics of a drug which we use in a metabolic scenario. And if you see the favorable benefit risk profile across the dosage range, it's the rosuvastatin which has the lowest variation and most dependable pharmacokinetic profile. And when a drug is given to 400 million, that's 40 crore patients, more than 2,482 related literatures published, 739 clinical studies associated, marketed more than 100 countries, and available in populous country like China for more than 10 years, gives its evidence. And if you ask the cost also, now the innovator and non-innovator doesn't have a much cost difference. The last thing I'll tell against generics. Now we have a craze of giving generics after so many projects have come, Janoshadhi and many Niramaya, and many people have started distributing the drugs free. But remember, the methylated impurities affects the HMG-CoA reductase inhibitory effects. That has been proved and published in the phase 4 studies, and it clearly shows the efficacy of drugs, pure and impure, are different. And the Spanish registry clearly shows this. The cumulative probability of all-cause mortality with a pure drug is less, and with an impure drug is high. 62% higher risk in patients with previous cardiovascular effects comparing to the innovator statins. With this, we'll end the discussion. I think I have convinced you that dyslipidemia is the strongest risk contributor to the Indian patients. So please take care of this in your patients, even if you are looking to a normal lipid profile, which is just tip of an iceberg. There are many things hidden below. Use of statins for the primary prevention is beneficial, proved beneficial. Think of primary prevention and convince your patient. Statins reduce the CV mortality in diabetes, goes beyond doubt, and rosuvastatin has an advantage over atorva in the term of efficacy and the safety, and rosuvastatin can be achieved the plaque regression and alter the lipid code Borden index post-acute coronary syndrome, which has a mortality benefit. The branded preparations have an advantage over generic in safety and efficacy study. So, in the metabolic continuum, if we want to give best, which statin, what dose, and which brand, all matter. Thank you again for the opportunity. I'll be happy if questions are there.
Thank you, sir. Thank you for the detailed talk and inspiring Dr. Aravinda. I am sure Dr. Aravinda needs appreciation, because in spite of the roadblocks and 24 ministers swearing in, we have a house full here. All the good work for Dr. Aravinda, and thank you very much, sir, coming all the way from Cuttack. And you have spoken about atorvastatin, rosuvastatin, and more importantly about the branded difference between the generic and branded drugs. Thank you very much. Thank you very much.
Thank you very much, sir. I request Dr. Aravind and the chairperson to felicitate the speaker. I request Dr. Aravind to present the mementos to the chairperson. Please note, coffee and tea will be served near your table. You may also have your coffee and tea in the hall, which is being served there. Please feel comfortable. And also, after the conference today, a gala meal has been arranged for all our delegates and faculty. After the conference today, there's also a gala meal. So please also enjoy that, and then you may leave. Moving on to the next session, we now have our chairperson, Dr. Vishwanath Krishnamurthy, diabetologist, Ramaya Medical College, Bengaluru, and our second chairperson, Dr. Krishna MV, diabetologist, Rajarajeshwari Hospital, Bengaluru. Please give them a huge round of applause, everybody. Over to you, sir.
Good afternoon, all. It's at the outset, we thank Dr. Aravinda for hosting this wonderful conference. It's a packed house, really, as everyone said. Moving on to the next topic, I welcome Dr. Rajiv Kovil from Mumbai, and he is going to speak on diabetes remission, hope or hype. I think we had a lot of discussion on this diabetes remission of late. We have some personalities talking about it, against it. So I think all those myths will be busted with this talk. Thank you, sir.
Thank you so much. Thank you, Aravinda, and the whole team for calling me here. My first disclaimer is that remission or reversal of diabetes is not something I actually practice. These are borrowed slides from friends like Neeta and Tejas, so I'm going to speak on them. So the core goals of remission. So this is the first introduction and also the summary slide. The core goals of remission is weight loss and improved glycemic control, and fundamentally is weight loss which drives the remission. And before we go on to it, we need to know that type 2 diabetes, till now we realize it's a progressive disorder, and UKPD has told us that 50% functioning goes down and 5 to 7% goes down every year. Probably that myth has been busted with these newer data which has come in. So what is the definition of remission? We should not be calling it reversal, that we are clear about, is defined as a return of HbA1c to less than 6.5 that either occurs spontaneously or following an intervention, which persists for at least 3 months without any glucose lowering medication. So that's what the definition of remission is all about. We'll see whether it's really a hope or whether there's a lot of hype around it. What are the evidences we have? Bariatric surgery, low caloric diet, and the low carb diet. So we'll go into all of them. Bariatric surgery has consistently shown that it dramatically improves blood glucose and is able to reverse or put patients into relapse or remission in almost 80%. Importantly, surgery can cause changes in the GI hormones. Today we know that bariatric works through the activation of GLP more. It also changes the gut microbiota, and that's probably one of the pathomechanism how bariatric surgery works. If you look at 5-year studies, and you should look at Stampede, which was a 5-year study which looked at sleeve gastrectomy and the Roux-en-Y gastric bypass. And you can see that statistically there was no difference between both of them in causing a remission. And in terms of medical therapy, the IMT is intensive medical therapy. At the end of 5 years, there was only 5% people who actually could go back based on in a remission in a 3-cohort study. So if you look at this, that bariatric surgery seems to put almost 1/4 of its patient in remission at the end of 5 years. So long-term remission is there in 1/3 of patients. Low caloric diet is what we've been talking about, and the direct study has brought this into focus, and a lot of people and a lot of non-pharma, non-healthcare apps have also developed this around the low caloric diet. Important to understand that micronutrient deficiencies can come with low caloric diet, and supplementation and monitoring should be there, and it's a consideration which we should have when we apply this in practice. Look Ahead was one of the first studies which came up almost 2 decades back, and if you look at the 4-year, if you compare it to Stampede, there was 7% remission with the Look Ahead study. Again, weight was a study which came between 2015 and 2017, just 4.5% remission. Roy Taylor did this counterpoint study, a small study on 8 weeks, showed that there was a 25% early recurrence, then a larger study with 8 weeks of very low caloric diet, and at 6 months, there was a 40% of initial responders still in remission, which took him on to the larger study, which was Direct. So Direct has a very good inclusion criteria. Patients had a BMI more than 27. They were not on insulin. They had a duration of diabetes less than 6 years. We had a good number to follow, almost 306 patients. So they were on a standard care versus a very low caloric diet, which was around 800 to 850 calories for 3 to 5 months. Then stepwise reintroduction, and then a long-term maintenance program. And let's see what the results of it. So again, diabetes remission was A1C less than 6.5 with no medicine for at least 3 months. So what was the remission rate? At 1 year, 46%, and at 2 years, 36%. So almost out of the 306 patients, almost 1/3 of the patient at the end of 2 years were in remission with this. If you look at this, it's a very crowded slide. So if you look at the first co-primary outcome, which was more than 15 kilogram weight loss at 1 year, you had almost 25% of patients who had more than 15 kilo weight loss. If you look at the second part of the slide, if you look at the second co-primary endpoint, which was remission of diabetes, which was HbA1c less than 6.5, you had almost 48%. And if you look at remission of diabetes in relation to weight, as the weight was going down, the remission was going higher. So again, weight seems to be the driver, and diabetes today, we talk about it being a problem related to hyperglycemia. Last week, I spoke on a topic where diabetes could be a symptom of all the metabolic issues that we have. So the ectopic deposition of fat in the liver, fat in the kidney, fat in the pancreas is there not by design, it's by design, is not there just by chance. And that probably leads to type 2 diabetes. So my outlook is that probably diabetes is a symptom of a multi-metabolic morbidity, which we may call as adiposopathy, and diabetes comes in some of the people. If you look at durability of the 2-year results of Direct open label study, the Direct program sustained remission at 24 months for more than 1/3 of the patients. Sustained remission was linked to sustained weight loss. Again, remission is very closely linked to weight loss. 64% of the patients in the direct study who lost more than 10 kilos were in remission at 2 years. So 10 kilos is what we will look at. Secondly, those who were in remission after 1 year and who had stayed in remission after 1 year had lost a greater amount of weight, 15.5 kilos as compared to 12 kilos. So even after 1 year, people who had higher weight loss continued to be in remission as compared to people who had lesser weight loss. Now, with the help of MR spectroscopy and all these, we know that the deposition of fat and probably liver fat, pancreatic fat, seems to be the kingpin in this metabolic blunder which we call as diabetes. And here we saw that there's a loss of ectopic fat with remissions at 24 months when we compare responders versus non-responders. So whether it's liver fat, the pancreatic fat, all goes down with weight loss. Very interesting to see that the UKPDS had told us that diabetes is progressive. One myth that the direct study actually busted, but diabetes is not so progressive. So if you are able to get down 10 to 15% of weight, you are able to change the morphology and also change the beta cell capacity of our pancreas. This is very interesting. So we always thought that once you're a diabetic, you're going to progress. But probably weight loss of 10% to 15% can change the morphology of the pancreas and also the functional capacity of the pancreas. Let's talk about low-carb diet. Low-caloric diet, effective in short term up to 2 years, effectively predominant in diabetes less than 6 years of age. Again, 800 calories, reintroduction, a whole team requires a lot of care and a lot of hand-holding for our patients, difficult with long-term maintenance, concerns about deleterious effects on body composition and physiology of severe caloric restriction. Micronutrient deficiencies would come in, supplementation and monitoring is necessary when we do a low-caloric diet. When we talk about low-carb diet, this is something that we've been always speaking on, and the goal of treatment has always been that we maintain the blood sugar without increasing medicines and again prevent the rise of glucose as such. So multiple studies have found it safe and well tolerated, but long-term data on low-carb diet is still awaited. Study is difficult to interpret due to varying definitions of what is a low-caloric diet. So systematic review of low-carbohydrate diet shows that greatest improvement in glycemic control, greatest medication reduction have been associated with the lowest carbohydrate intake. Now, whatever be it, the weight loss and improved glycemic control comes around as the core goals of reversal. So if you look at this slide, you can see that the HbA1c seems to be much better drop when we have a bypass or when we have a very low carbohydrate diet. Weight seems to be much better with any kind of surgical intervention, whether it's a sleeve or a gastric bypass. This is the retune study. Again, we looked at, in the direct, we looked at patients who had a BMI of more than 27 and a duration of diabetes for less than 6 years. This retune study, again done by the same author, looked at patients whose BMI was less than 27 and duration of diabetes less than 5 years. The whole idea was to test the hypothesis that whether weight loss in people whom we normally considered as not being extremely overweight, can it help in these groups of patients also? So the aim was to test the personal fat threshold, and that is what the twin cycle hypothesis tells us, that each one of us has a personal fat threshold, and beyond that threshold we are not able to store fat in our subcutaneous tissue, and it then goes into ectopic distribution, and that's the problem, and that seems to be the seed of the metabolic issues. Finally we land up with diabetes and all other comorbidities. So again, what we concluded in the retune is that there was remission even in patients whose BMI was less than 27, almost 40%. And the personal threshold, fat threshold concept explains why type 2 diabetes occurs in individuals of very different BMI. So you could have a 23 BMI and still be metabolically obese and have a personal threshold which is low and get into the metabolic issues related with diabetes. These are my views on it. interventions which are aimed at reversal are not first-line standard of care in any guidelines. So whenever we have a newly diagnosed patient, we don't sell the idea of reversal or remission. Standard of care does not lead to reversal. The current standard of care may be suitable for some, but others would surely choose reversal if they understood that there was a choice. But the choice could be offered to them. Those who keep the weight off to manage to keep the diabetes reversed. So those who keep their weight below 10% and 10 to 15 kilos manage to keep the diabetes reversed. 2-year, 3-year, 4-year data is coming up. In Indian scenarios, there are some patients who have gone into sort of a remission with even on their oral medications with weight loss, which we see in practice. That a lot of our patients who may have been on twice-a-day insulin, when they undergo very strict lifestyle changes and lose some weight, they go into a remission where they are using lesser drugs as compared to before. The ones who regularly follow up are the ones who stay reversed. Proper patient education, optimal support is required for a long-term behavioral change. This is a adaptation where it shows that up to 15 kilo intentional weight loss might actually normalize the life expectancy with people with type 2 diabetes. So weight loss, whether it's a hope or a hype, there is some hope in it, but a lot of people who actually are not trained in it are creating the hype, but it's very similar to chemotherapy for cancer. You're not going to remove cancer, but you're going to prolong survival of these patients. So surely there's a ray of hope. Thank you so much for a patient hearing.
Thank you, sir, for highlighting the role of weight loss in the remission of diabetes. Now the session is open for questions.
Yes, Pradeep.
Without drugs. Now, what happens in these individuals beyond 3 months is something which we need to constantly introspect. And when we look into this long-time follow-up of these individuals, most often these people bounce back to their things. So, in all these studies that we're talking about, are they including these percentage who have reversed in 3 months and then they're not taking into consideration the remaining aspect? What kind of contributes
there's this paper by Dr. Mohan which talks about re-reversal of diabetes also. So patients who actually reversed, then they again re-reverse to become a diabetic when their weight gain happened. And if you go through the studies of tirzepatide, especially SURMOUNT, the discussion part, they clearly state that to maintain weight loss in future, pharmacotherapy would be essential. So keeping patients on 800 kilos, 1100 kilos, keeping them motivated for the rest of their life is going to be unimaginable. It's like having euglycemia for all our patients for the rest of the life. So that's a hype. But probably if we are able to give them some years where they go into a remission and probably the deterioration in the organs would be delayed. But that's a hypothesis. We don't have a RCT to prove that as such. Yes, doctor.
Do you want to use the term reversal or remission?
I don't use the word reversal at all. It's a marketing term.
Even international guidelines, consensus, they have said you have to use the word remission rather than
Absolutely.
reversal. Because if you reverse a diabetic patient diabetes, the diabetes should not come back.
Absolutely. So, I completely agree with you. Reversal is a marketing gimmick.
And of course, now we have even non-diabetologists, non-physicians reversing diabetes.
Absolutely. We should take a stand against them.
Thank you.
So last question. Low carbohydrate, high fat diet. Sir, here from the chair.
Yeah.
Low carbohydrate, high fat. That's what often told in videos and all. What do you take on that? So they eat very less, zero rice or something, and high fat.
So again, that comes very close to a keto diet, and a lot of some amount of adverse reactions to hyperuricemia, BUN going up, has been seen with these diets. And again, it's not something that you can continue for a very long period of time. Those are all fat diets.
Thank you, sir.
Thank you so much.
Thank you very much for this informative session, sir. I request Dr. Aravind and the chairperson to felicitate the speaker. May we all give him a big round of applause, please? I request Dr. Aravind Jagdish to present the mementos to the chairperson. Dr. Aravind Jagdish, the chairman and chief diabetologist, Aravind Diabetes Center, Basaveshwar Nagar, Bangalore. For the next session we have, our first chairman is Dr. Ravi Kirti M, diabetologist, V2K Diagnostics and Specialty Clinic, Bengaluru. And our second chairperson is Dr. G.M. Prasad, diabetologist, Pranav Diabetes Center, Bengaluru. We welcome you, sir. Over to you for the further proceedings, sir.
Good evening. Thank you, Dr. Aravind. It is an honor to be here in front of my esteemed teacher, Dr. Baswan Gowda. Good evening, sir. Today's topic is something different than what we have seen earlier or what we have heard earlier. This is an upstream approach to the management of in the field of diabetes. An upstream approach is a method where we try to prevent the onset of disease rather than the onset of, after the onset of disease. So we know that we have been using GLP-1 analogs, both injectables and oral forms for quite some time. But does it have a role in prevention of type 2 diabetes? So our speaker, Dr. Suresh Damodaran, is going to enlighten us about this.
Good afternoon, everyone, and thank you very much for the wonderful opportunity. I think the stage has been set and the discussion happened around weight loss and whether remission and other things. I mean, most of us, few of us in the front desk at least have been working in diabetes for more than 25 years. So the remission word and other things was not used to be, just metformin and a few other drugs just to control. So at least we have good quality of science and also good quality of medication that can support and keep the people in remission, and good that we are talking about it and we are going to move forward with that. So with that start, I think an upstream approach of a oral GLP, this is a sponsored talk, but the important messages is whether we have to be proactive, whether you have to be glucocentric. I'll try to convey the message with the molecules available currently. As I said, it is a sponsored talk, and if you look at the challenge, the thin fat Indian is the huge challenge that we are not dealing with a simple problem, it is a complex issue. So you have to understand the pathophysiology to move in and treat the diabetes along with that obesity, which for an Asian Indian will be a slight this thing in front of a visceral fat which needs to be addressed. And if it is not, and adipocytes will get into insulin resistance, and then the diabetes will be a huge challenge to control. And the sleep disorders and inability to be active and stigma around that will also be a cause for getting into the challenge of uncontrolled diabetes. So weight loss appears to be a real benefit, and if you look at the why weight loss is needed, A1C, lipids and blood pressure all will be controlled. So buy one, get four free sort of thing. So 6 months, 12 months and 24 months without diabetes and with diabetes. So they have a tendency to gain more weight, and that is being a science which is known. But what is the challenge is just to maintain the weight loss, and that is going to be a huge challenge. Rajiv was mentioning the 3 months later what to do. There was a question came in. So how you manage it? It's just purely with lifestyle. So increase in hunger, energy gap will be there, and I'll come to that, how the SGLT2 works and other things. So if you come to the hormones wise, the satiety center, and there's a huge amount of science that is currently come up with PYY, and we were talking about GLP and GIP together, anti-ghrelin, anti-serum, and that the gut hormones are going to be playing a major role in a next decade of diabetes management. So leptin level and the increased energy efficiency, these are all the challenges in maintaining the weight loss what we achieved. So what are the treatment available option? Lifestyle, diet and behavior is the one that we discussed already. And there are a lot of tech companies and other guys who come in with artificial intelligence and this thing in the aspect of lifestyle, and also a lot of areas where people who are not trained coming with lot of wrong messages in the area of lifestyle and dietary support. So this is where the pharma companies who got the obesity portfolio has to play an important role of not providing an environment where these kind of people will flourish. And that is a huge challenge again, because there are a lot of things they have to do for marketing, and if they pick up and do wrong signs, and then we all been very much trouble in terms of managing the obesity. So orlistat, semaglutide, you might have heard orlistat as they come up with some spray or some melts in orlistat. There's few other things happening in that front, and also naltrexone, bupropion, and even zonisamide, and few other drugs have been tried. So weight loss surgery has been there. There is a big surgeon troupe who there is a role for it, but I think there are a lot of challenges along with it. So once you attain the lifestyle, what are the challenges to maintain it? 50% of return of the weight, and again, Rajiv was mentioning about regaining diabetes back. That is the thing. So when you have the lifestyle changes, it has to be maintained. But mentioning about the post-bariatric surgery, the weight regain percentage is with the sleeve, which is the very simplest surgery, and you can go back to one anastomosis gastric bypass surgery, which is a very complex surgery, and it involves quite a lot of surgical intervention. And with that, the weight regain is less, and then the BMI reduction, and also the A1C coming back is less with the one anastomosis gastric bypass, but it's a very complex surgery. So weight regain may be the patient seeking revision bariatric procedure, but if you do gain the weight back and they have to do a revision back, which will be a very, very complex thing. So pharmacotherapy wise, you can maintain and sustain it when it comes to the control. The medication can maintain it for a very long time. So GLP, SGLT2 and pramlintide, which is not available in India, it is a twice daily injection that is been there for a while now, almost a decade, and that drug is not available in India, but there are few molecules like this which is going to be in the pipeline soon. But DPP-4 and glucosidase inhibitors are all weight neutral things, and insulin, sulfonylureas, we know, no brainer, that is all gaining the weight. So appetite regulation is through the satiety center in the brain, and if you look at it, if you want to go into the detail, POMC and CART and neuropeptin Y and AGRP, all the ways that the satiety center is being worked up by GLP, and therefore it produces a result where people eat less. So SGLT2, I was briefly mentioning earlier, so it has to be the calorie loss versus compensatory food intake. So what happens is when you lose calories in the urine, and there will be overall balance-wise, if you look at it, the energy excreted with glycosuria, because it elicits a behavior where the appetite increases. So the weight loss will be around 3 to 4 kilos. You've been using this molecule for almost 5-6 years. You might know from your practice, and that is the maximum weight loss, apart from few other case reports where you have more than 10 kilos or so. So this is the scenario that I put in, a scenario where the obesity is increasing and lifestyle and surgical, what are the challenges with surgical, and we know that pharmacotherapy works, but how to sustain it, and this is what that we are at. So revisiting the management, whether we should be focusing glucocentric and target the obesity alone, or whether we should go for an approach where everything can be addressed. So upstream approach is the where you can prevent the hypertension, coronary artery disease, but the downstream is the when we concentrate mainly in a glucocentric approach, and that is the one that may not yield results. So we talk about reversal and remission and other things. The upstream one is the way forward, so that you get loads and loads of benefit. Obstructive sleep apnea, NASH, osteoarthritis, hyperlipidemia. You might be seeing any obesity drug or a diabetic drug which has got a potential to weight loss. You might be seeing a lot of data coming in, accessory data is coming up with OSA and arthritis and hyperlipidemia beneficial effects. So importance of weight loss, the incident control and remission to lose weight loss in type 2 diabetics. If you look at it, the weight loss and type 2 prevention, DPP, this is a long time, this is almost 30 years ago this study has been done, but if you look at the Lancet data that has been produced in 2019, the risk of type 2 diabetes falls significantly, reduction in body weight. So we also know type 2 diabetics have potential to have a weight gain, and we know that when we tend to lose the body weight, the risk of type 2 falls very, very less. So the weight loss and diabetes control, this is the trial that people mentioned earlier. Look ahead, the Action for Healthy Diabetes study that showed that the modest, even a modest weight loss improves the glycemic parameters, and degree of HbA1c and fasting reduction was proportional to the magnitude of weight loss. Therefore, the contribution towards the glycemic control is in the really good range. So weight loss and weight loss and weight loss will be the key for the diabetes remission. And we discussed about diabetes remission, the direct trial, which has changed the practice of quite a few, again in 2019 Lancet, 46% of patients with intervention group achieved type 2 remission. So greater weight loss then led to a greater proportion of people maintaining the remission. So we can achieve remission purely along with the weight loss only. So we can't do without it. So this is the look ahead 1 year data, weight loss, and what happens is you get buy one, and as I mentioned, a lot of things will be free along with it. So the CVD risk markers with the 1 year data showed the parameters like blood pressure, triglyceride, HDL, all will come down with the weight loss categories. Each, if you go into the maximum of more than 15% with this subcutaneous semaglutide and the new tirzepatide, all will produce more than 15%. And with these group of drugs, then the reduction and the parameters will improve. Therefore, the cardiac benefit is there. In the look ahead is this proved that loss of 5% of body weight will lead to improvement, not only improvement of the risk factors, but 48% of hazard ratio less with CVD at 10 years. So what I've shown is that sustainability and upstream approach is very important so far, along with the risk factors. So if you do have that, and I've showed you a direct trial and look ahead trial to show that is being the trials that has given advantage of proving that along with the weight loss, if you do it, you will reap the benefits even in terms of CVD benefit. Now, I'm just going to touch base very quickly in next 3 minutes or so about the clinical data from Pioneer clinical trial, which is the oral semaglutide. This drug has been tried with EMPA, sitagliptin, liraglutide, and with insulin. So all the molecules have been tried. And what is the bottom line? There is a 1.5% better reduction in A1C in oral semaglutide compared with other molecules across. And these are all the molecules available for us in the market. So if you look at the baseline A1C of 9, that's maybe treatment naive patient or people who's got an A1C of 9, what showed in the Pioneer 1, 2, 3, and so on until 8, and it shows that the post-hoc analysis, the A1C reduction of more than 9, resulting in almost 2.6% when that is the A1C reduction. That is a huge, this thing, you look at the other side, minimum 2% reduction is possible. So again, to show that how that multiple risk factors I mentioned about in the look ahead trial, when you compare it, the weight loss happens with almost 5%, 5 kilograms compared to the other molecules, and that will yield benefit This is like a glycemic control with SGLT of 0.8. Even DPP-4 produces that amount, and the oral semaglutide produces more than 1.4%, and the weight loss is 3.8 kilos compared to 4.7 kilos. But practically it can be more, but the A1C reduction over the years, which is 52 weeks, greater reduction when compared to empagliflozin. So the waist circumference, which is the main thing for an Asian, the waist circumference reduction is better craving control compared to empagliflozin is there. As I mentioned, POMC, neuropeptide Y, and working in the satiety center all has got an impact in producing a better craving control. So these are the things, very minute things are needed compared to SGLT2, which has got a balance of calorie loss, which will produce slight increase in appetite. So 45% reduction in waist circumference with empagliflozin compared to that. So quality of weight loss with semaglutide, the quality of weight loss is very important. The fat over the lean body mass with semaglutide, and threefold loss of body mass. And the glucotoxicity wise, all the guidelines with the ADA guidelines of 2023 that suggest that decision to use GLP-1 proved to be independent of metformin. Just to finish with one case scenario in next 1 minute or so, a patient with metformin and sulfonylurea 46 has got a family history, 8.1 A1C, with diagnosis, metformin and diet and multifactorial treatment, and he has got a lifestyle of 2 to 3 times of walking. He's on, after 3 years later, he had the sulfonylurea dose is increased, and the symptoms of atherosclerosis started. But again, this patient is started on semaglutide, and you can see this is the 46-year-old and 49-year-old. I'll show you the data. This is before and after 3 years, but the patient, Pawan's glycemic control has gone worse, and when the GLP-RA started, you see the A1C reduction is 6.8%, and this is the comparison of this thing. And everybody of us will have their own experience, but I think very, very quickly to show that limited efficacy, development of long-term complications can be prevented. And I show my patient, one of my patients is 146 kilos and gone to 108 kilos. That is almost like 40 kilos of weight loss. That happened with oral Rivals, but it is not for everyone, and it is there with the weight loss you get the good glycemic control. So to summarize, that what I been speaking last 20 minutes or so is a big challenge, and there are drugs to maintain the remission, and the huge challenge is once the weight loss and diabetes is under control, to maintain it, and adopting upstream approach will be the best way forward, and strategies of weight reduction have got multiple challenges, and GLP-1 is proved to be much more beneficial because it works multifactorially, and also it gives a good weight loss along with satiety control. Thank you.
Thank you, Dr. Suresh, for a wonderful presentation. So I just wanted to have this one, like I can, for the sake of delegates, if you can just indicate how to take the precaution before choosing this drug. It is not like we know that like any other drug we can't use this drug.
No, I think what I try to do is just to approach the psychological thing of a patient. One is, of course, the cost counseling should be there, number one. And number two, for the GI side of things, what I will say to them is when you have, it will be there for a week to 10 days. And when you start the drug and when you do have a side effect, that means the drug is working. So that will tackle some sort of psychological thing for the patient. So they will try to overcome that. And also, I will also counsel to the patient saying that the family members are the people who might spoil this thing. So what I will say is, try to make the family to understand that you won't be eating like what 4 dosa or 4 idli, you won't be eating, you will be eating 1 idli, but they shouldn't have sympathy with you. And that is the biggest challenge in India, that when people are not eating, they have to feed you, come forcefully with some juice or something. And that is the second counseling point I do. And then the third thing is to give pan and emised for a week or so, practically. And that tackles many of this thing. These are all some practical tips. Everybody will have their own way to do it. but we have to do something more practically possible.
Do you have any BMI criteria to source for this drug actually?
No, as I said, the Asians have got a different thing compared to BMI. You have to go with the waist circumference, but going with the BMI, probably you won't be achieving much actually, but you might miss out the people who got truncal obesity, which is more dangerous and more toxic.
Dr. Suresh, it was a wonderful presentation.
Thank you.
But in your clinical practice, would you think of starting this GLP-1, at least oral, in an obese patient who is at a risk of diabetes?
Oh, you mean for non-diabetic? No.
Obesity?
No, not yet. Not yet, but I think semaglutide subcutaneous can be, but that takes some time.
No, why not oral when it is so semaglutide subcutaneous?
Well, the data is not there.
Yeah, if there are no questions, we'll close the session.
Thank you, sir.
Thank you for this wonderful session, sir. I request Dr. Aravind and the chairperson to felicitate the speaker. I request Dr. Aravind Jagdish to present the mementos to the chairperson. Moving forward to our next session. We have the Warrior oration right now. For this, we have the chairperson, Professor Dr. Chandaraya, consulting physician at Sagar Hospitals, Bengaluru. And the next chairperson is Dr. Sureka Shetty, diabetologist, Karnataka Institute of Endocrinology and Research, Department of Medical Education, Government of Karnataka, Bengaluru. We welcome you, ma'am. We welcome you, sir.
So good evening all. So now we have got Warrior oration. So this is an important oration named after King of Mysore. We all know how much we love Mysore and our esteemed King Warrior. So we named this oration on behalf of our Mysore King. The king still, their dynasty is still going on. I'm sure all of you would have visited the Mysore palace as well. So Warrior dynasty is a royal dynasty that ruled the kingdom of Mysore, which was a princely state in India. The Warriors were the hereditary rulers of Mysore for over 6 centuries, from the 14th century until the country's independence in 1947. The dynasty is named after its founder, Yeduraya Warrior, who established himself as the ruler of Mysore in the 14th century. Over the years, Warriors played a significant role in the governance and development of Mysore, leaving a lasting impact on the region's culture, architecture and administration. So we have an dynamic, prolific speaker to talk on an important aspect. So when I was discussing Dr. A.K. Singh, he said, which topic boss will choose? He said, you only tell whichever topic you give, I am very comfortable. So, but you know how prolific speaker is he, and how much dedication he does it for the preparation of the slides is tremendous. So he will be talking on an important topic, that is treating type 2 diabetes, hypertension, dyslipidemia in 2023, common mistake that must be avoided. I will now hand over the session to the chairperson, Dr. Sureka Shetty and Professor Chandraya, to introduce the speaker and for further proceeding, please.
Thank you, Dr. Aravind, for giving us the opportunity to chair an important session in this summit, which have hosted a grand meet with lot of experienced speakers all over the country, which brought to the Bangalore. I think the audience are going to get a lot of knowledge from this. Now, coming to the topic, we have treating type 2 diabetes in 2023. Now, what mistakes we should avoid? We use a lot of drugs, insulin, diet, exercise. Now, what should be avoided and what should be used, right combination therapy in these patients? I think Dr. A.K. Singh will enlighten us on this, and over to my co-chairperson to introduce Dr. A.K. Singh.
Thank you, sir. And it's my proud privilege to introduce to all of you Dr. Avdesh Kumar Singh. I think he doesn't need any introduction, but as a role of being a chairperson, he is a senior consultant endocrinologist at GD Hospital and Diabetes Institute, Kolkata. He has more than 138 publications and first author. And during COVID, we have all read his meta-analysis on correlation between diabetes and COVID. Very enlightening, sir. He is also delivering several orations and recipient of several awards. Currently, he is adaptation editor for William Textbook of Endocrinology, Southeast Asian edition. He is the deputy editor for Clinical Diabetology. He is also the associated editor for World Journal of Diabetes and International Journal of Diabetes in Developing Countries. And I think we are all waiting to hear from him what we should not do while we prescribe an anti-diabetic drug. Over to you, sir.
Thank you, chairpersons, for the kind word. Thank you, Aravind. It's always an honor to deliver oration for the king. So I have just come to know, I wasn't aware who is Mr. Wadiyar, so I come to know that he was the king of Mysore. It's my honor to get the oration in the name of that gentleman. So basically it translates into Singh is also king. Jokes apart, difficult job, but then this is necessary. In clinical practice, we often see a lot of scrupulous medications being prescribed by my colleague. That pains me. And when Aravind asked me, what should I talk? I said, the ball is in your court. Tell me what I should. Then he suggested me that why not talk something new, which you have never talked in past, and teach us what mistakes we actually do and which must be avoided. So very difficult. I had to think about how should I go about. Actually, we make a lot of mistakes. But I thought to present you some, I have classified the way of how we make mistake in clinical practice. So you can see I have classified my agenda into two things. First, that we do make mistake and how we should avoid. Second is that we have got a feeling that we are doing a great job, but that is not true. So that's what the two agenda which we need to learn upon. Now, if I take the common mistakes, what is the agenda to discuss this evening is that we do use illegitimate drug combinations, which is not only, favorable in court of law. So if your patient turns out to be complicated because of the drug you prescribed, tomorrow you are behind the bar. Nobody will save you. Because those side effects are life-threatening, and of course, these combinations which is illegitimate must be avoided. The second one is that you might have used the drug which is a legitimate drug combination, but there is a lot of risk when you are using it. So these are the two important bullets to understand why and how we should avoid these things. Now further to classify those illegitimate combinations and legitimate combinations with risk, the biggest thing which I see is, and you might be surprised, if I put that we do often see a patient receiving two different varieties of sulfonylurea. And I'm sorry to make this a statement, this often comes from this part of country. So not Karnataka exactly, from the southern part of the country. I don't want to name the place. By this time, many of you have recognized where I'm trying to indicate that a patient receiving gliclazide in morning and glimepiride in evening is a crime. The second mistake that people often use is to combine a glinides with a sulfonylurea. So we often see a patient receiving one sulfonylurea, great knowledge, but then a bolus dose of glinides, ripaglinide before lunch, and 2 tablets of gliclazide morning and evening. This is a crime. And I will tell you why this is a crime. The third, perhaps this is the most common mistake people do in clinical practice, is to use a premix insulin, and then when the sugar is not controlled, add a longer acting insulin. So for example, you are using human mixtard or hum insulin or lupisulin or whatever insulin premix you are using, conventional premix or premix analog like Novomix or any other premix analog combination. Once the fasting blood sugar is high, you tend to add a injection Lantus or Toujeo or Tresiva. This is wrong. This is not allowed. You cannot use a longer acting basal insulin when the patient already is receiving an intermediate acting, a protaminated soluble insulin. And I will tell you why. The fourth important point, I'm sure that everyone, I thought that is aware that you should not use a AC inhibitor with ARB. It will kill your patient. But yesterday I saw one of my friend who is a doctor, practicing doctor, brought his elder brother to me, and he's prescribed a tablet of capsule of Cardias with a tablet of Telma, and he was on for last 10 years, his potassium was 6.5. I was discussing with Aravind in the morning. So I thought to put it, it's a crime to use a AC inhibitor with ARB, and I will show you all those evidence. Yesterday in some group, somebody asked me, can I use a seroglitazar with fenofibrate? No, sir, not at all. You are not. So these are illegitimate combinations. On your right hand side there are some legitimate combinations that you can use pioglitazone even with insulin. There is no harm if you use insulin in a smaller dose and pioglitazone in a smaller dose. Sometimes your patient is not able to get good control on insulin, and then one tend to add a pioglitazone tablet with a feeling that because this is insulin sensitizing drug, if you add pioglitazone to insulin, the sugar would be better controlled. As I said, this is a legitimate, but be careful that someone is receiving a very high dose of insulin where you tend to add a pioglitazone, because then you think, oh my God, this gentleman is getting 100 units of insulin and still sugar is not controlled. Let's add a pioglitazone. It should make insulin work better. Now in this particular case, when patients are often receiving higher dose of insulin, adding a pioglitazone would lead to exaggerated sodium retention. Ladies and gentlemen, please remember, both pioglitazone and insulin is an insulin retaining drug. So if you use pioglitazone with insulin, it will increase heart failure. So if you have been asked one MCQ question that which drug causes heart failure in terms of tablet, answer comes as a pioglitazone. And the second drug is insulin. So here is the problem with insulin. The high dose of insulin is often associated with increase in heart failure hospitalization. So therefore, if you combine pioglitazone with insulin, be careful. The second common thing is you do prescribe a triple drug combinations containing pioglitazone, and you often use a dihydropyridine CCB like amlodipine. You can use it. This is a legitimate combination. But then be careful again that amlodipine-induced edema and pioglitazone-induced edema will make a haywire to your patient. It can precipitate heart failure. It can precipitate side effects due to pioglitazone like macular edema. So when you use it, if you feel that I need to use it, there must be a pharmacovigilance. Whenever patient comes back to you during follow-up, you must look for whether patient is developing edema. Just looking at the patient, just look at the lower eyelid. If you see that there is some water accumulation, look at the prescription. You must have given these three drugs, pioglitazone, insulin, or DHP-CCB. Try to stop those drugs and replace with the other drug. The second I thought to tell you is legitimate but risky is the pioglitazone with a DPP-4 inhibitor combination. Today, to my knowledge, at least there are 10 pharma company which has come with combinations of pioglitazone with DPP-4 inhibitor. Please remember, the DPP-4 inhibitor has a black box warning across the world, including sitagliptin and linagliptin. Despite there was no heart failure signal in the TECOS trial with sitagliptin and the Carmelina trial with linagliptin, still in United States as well as by European Medical Agency, there is a black box warning for DPP-4 inhibitor in terms of heart failure hospitalization. So therefore, when you are combining pioglitazone with DPP-4 inhibitor, this is a legitimate, you won't go behind the bar, but be careful, this is risky in terms of accentuating heart failure hospitalization. And finally, these are some of the point I'm trying to raise today in this 20 minutes talk. And then important, again, using amlodipine in hypertension. This is left, right, and center. And you are allowed to do it. Using a tablet of amlodipine because it's very cheap in patients with hypertension and diabetes. Have you ever wondered what is the harm you are doing to this patient? Yes, you are doing a wonderful job in controlling blood pressure, but amlodipine has got some issues in patients with diabetes, which I am going to tell you shortly. So I thought to give you the evidence behind the logic which I am trying to put. It's not because I am the boss and I am going to rule, I am going to tell you through the evidence. Now, first of all, let's look into the SU glycinide story, and this is not a rocket science. I don't have the projection to show you, so let me go through laser pointer here to right. Now, just a brief overview how sulfonylurea works. Suffice to suggest, if you look here, that beta cell has got a receptor, which is a sulfonylurea receptor we call SUR1. So sulfonylurea receptor 1 is present in beta cell. Sulfonylurea R2 receptor is present in cardiac myocyte as well as in endothelium. When you use a sulfonylurea, and this is a potassium ATP channel. So potassium ATP channel has got a 2 subunit, as you can see, where from the potassium in a normal resting state, potassium is always extruded from the beta cell. The 1 subunit of this potassium sensitive ATP channel, when you use a sulfonylurea, it binds with one of the subunit of this sensitive potassium ATP channel. And therefore, moment sulfonylurea binds to this subunit of potassium ATP channel, this channel is getting closed. So therefore, potassium doesn't come out. Potassium goes inside the cell. There is a hyperkalemia, cytoplasmic hyperkalemia inside the beta cell, which makes the beta cell depolarize, and then there is a calcium influx inside the beta cell, which is voltage dependent. And because of this increased calcium, it causes exocytosis and insulin is secreted. Now, if you use 2-sulfonylurea, of course, you are bombarding the same SUR receptor. Now, even if you use glycinides, glycinide also goes through the same receptor. So, using 2 different drugs, glycinides are not sulfonylurea, but they work through the same receptor. Therefore, combining these 2 drugs will cause a precipitous hypoglycemia. Abrupt hypoglycemia can kill your patient at a time. And then, if somebody sues in the court of law, you are in the trouble. So you shouldn't use SU with glycinides. Similarly, when you are using 2-sulfonylurea, remember sulfonylurea not only works through the SUR1, which I told you, it also works through EPAC2. The glyclazide is the only sulfonylurea that doesn't bind to EPAC2. And that's why glyclazide has got a least hypoglycemia. Now, if you use glyclazide with other sulfonylurea, naturally you have opened this EPAC2 channel, and then you cause a precipitous hypoglycemia that can kill your patient. So simple reason, don't use 2-sulfonylurea, pretty easy, and never use glycinides with sulfonylurea. Next is insulin. Often seen in clinical practice, you are using twice mixtard, sugar not controlled, add 1 Lantus. This is a crime. This will again make a pharmacological nonsense. How? Let's look at how insulin works. So in a normal physiology, this is an increase in insulin just when you take the meal. there is a constant basal insulin secretion, which is 70% almost. Only 30% is the meal-stimulated insulin release in human body when you take. This is physiological insulin profile. When you use a mixture of rapid-acting insulin with basal insulin, this is how this graph looks like. So this battery is not working. Similarly, if you are using a protaminated insulin, so when you are using, you can see that this is their flatter profile. Now, if you inject a basal insulin, the entire pharmacokinetics of insulin, both the previously used premix analog or conventional premix and the basal insulin which you have now injected, their PK/PD is entirely deranged, and this will land into a hypoglycemia, and again this might make you in a trouble. So this is a pharmacological nonsense to use insulin glargine with any combinations where there is an NPH formulated with. So don't use it. Third point, never use AC with ARB. The story I was telling you, a doctor coming to me to show his elder brother using a mixture of Cardis and telmisartan, that is Remipril with telmisartan. It's not allowed. Look at these two trials. This is a trial, this is an on-target trial published in 2000 where telmisartan alone, Remipril alone, or combination of telmi-Remipril was used. And this trial, the people receiving the combination of drug had much higher side effects like hyperkalemia, kidney failure, etc. So this was the first indication. Now you can see on right hand side is the Van Efron D study, which was done in patients with diabetic kidney disease, where a mixture of losartan and lisinopril was used. So again a ARB. This trial was stopped prematurely because of increase in death in those receiving losartan with lisinopril. So therefore, since this particular trial, in fact in 2008 already FDA gave a warning, don't use it. It also happens with a direct renin inhibitor. Remember, Eliscarine came from Novartis. It undergone a trial called Altitude. In Altitude trial has to stop because Eliscarine caused increase in hyperkalemia, arrhythmia, and cardiovascular side effect. The trial was prematurely stopped because of increase in death. And since then, Eliscarine was banned. Everyone used to use a newer drug, very giving a, little bit of bump that I'm using a direct renin inhibitor, Eliscarine, which costs 65 rupees. You killed the patient. So please look into those data that sometimes doing too much may not be good for your patient. Never use a combination of ACE inhibitor and ARB. Now, the most important point which I'm going to, this evening I'm going to tell you is, which perhaps you have never realized. So every Tom, Dick and Harry use a tablet of amlodipine in patients with diabetes and hypertension. Yes, amlodipine is a very powerful antihypertensive drug, and in fact it is a far superior in terms of lowering blood pressure compared to any RAS blocker. However, there is some problem. Now if you look at the trials, so I'm giving you the little bit of historical perspective where from the story emerges to make you understand why amlodipine alone prescription could be dangerous in patients with type 2 diabetes and hypertension. Never use amlodipine alone. If you wish to use amlodipine, do use it with either a ACE or ARB or with a beta blocker. I will tell you why. So in initial days, it was thought that amlodipine is perhaps a proteinuria reducing antihypertensive drug. But this was done in a non-randomized controlled trial called GISEN study in 1998. Since then, there were several randomized controlled trials that were conducted. And there was a very controversial outcome came with amlodipine. Now, so I'm showing you those trials which shown a bad outcome with dihydropyridine calcium channel blocker. So starting with the ABCD trial to the IDNT to ASK trial, in all these trials, the CCB did badly then compared to a RAS blocker. However, in some of the other trials, like this trial, the all-hat is the trial. From this particular trial, the still amlodipine has been kept in the JNC 8 guideline or all the guidelines in the world. Because in this particular trial, amlodipine didn't do anything bad, but didn't do anything good either in terms of kidney dysfunction. So therefore, people looked into how to take about amlodipine. Is it good in terms of diabetic patient in terms of protecting kidney at the end of the day? Fair enough that it controls blood pressure better than even a ARB, but does it protect kidney at the end of the day? So this is a meta-analysis done by George Bakris and group. This included 28 randomized controlled trial, and we come with a conclusion that if you wish to use amlodipine alone, look at there is an increase in proteinuria. So this one, you can see this is a dihydropyridine calcium agonist, DCA, which is amlodipine, versus non-dihydropyridine. You can see there was a significant reduction in non-dihydropyridine, but there was an increase in proteinuria, which was statistically significant. The blood pressure reduction was similar between two different types of CCB, but the proteinuria reduction was not seen and rather worsened by amlodipine alone. So the authors came to conclusion that when you are using amlodipine, you must use a concomitant RAS blocker or a beta blocker to mitigate the vasodilatory side effect of amlodipine. Now to summarize you, the amlodipine, how it works, let's look at this figure. So if you use amlodipine, it dilates the afferent arteriole. So if you dilate this arteriole, you increases the glomerular pressure, therefore there is increased plasma flow and it causes proteinuria. It exaggerates proteinuria. So you need a drug that constricts the afferent arteriole like a GLT2 inhibitor, or you need a drug that dilates the efferent arteriole like you can see cilnidipine. So you can see you have got a two kind of drug, so just opposite. In one hand, amlodipine increases proteinuria, cilnidipine reduces albuminuria by looking at this particular place. And SGLT2, if you combine, you constrict the afferent arteriole, reduce the glomerular pressure, and reduce the proteinuria. This is how amlodipine works. The moral of the story is that if you wish to use amlodipine, do use with concomitant with a RAS blocker. Now the second half, the common belief that we all feel, that it's wonderful combination, it will do great to you. For example, when you are using a SGLT2 and DPP4 inhibitor, you can see 100 pharma company with all combinations right now, Sita, Depa, Sita, Bilda, Depa, and whatnot, all combinations coming. They always try to make you impressive that look at this, when you use these two drugs, you prevent more heart disease and kidney disease. Yes, these two drugs, if you combine, it lowers HbA1c better than any one drug. But does it translate into any better cardiorenal outcome? This is what I am going to show you. The second one is, people always think that if you combine GLP-1 and SGLT2, because both the drug classes shown a significant benefit in cardiovascular outcome, combining it would do a better cardiorenal outcome. Is it so? Let's look at. And finally, I am going to ask you tonight to give you a thought. When do you prefer an antihypertensive drug in patients with diabetes, nighttime and daytime? So let me take you through first one. Can combining SGLT2 and DPP4 work? So this is a very recent paper we published in the ACE Endocrine Practice. This is the first meta-analysis in the world when we looked at whether combining two drugs, SGLT2 and DPP4, really does anything good to the heart or to the kidney. It works good in terms of glucose control. Of course, combining two drugs would lower HbA1c better than any one drug. But does it translate into giving any extra cardiac or renal benefit? Now look at this evidence. Answer is no. We don't have any evidence that yet suggests that combining two drugs would reduce cardiovascular outcome. I am not going to detail to tell you because of paucity of the time. Simply you can see that we looked at whether using SGLT2 alone, these are all randomized controlled trial. As you can see, more than 32,000 patients use data from the all large double-blind randomized controlled trial using either SGLT2 or combination of SGLT2 DPP4, that is group 1, or SGLT2 alone. If you closely look, if you know how to read the statistics, you can see here the SGLT2 alone is giving a better 3P-MS outcome actually than the combining two drugs. But because it is statistically not significant, so we conclude there is no advantage. But truly, if you are a purist, it looks like that SGLT2 alone is giving a better 3P-MS outcome than the combination. Similarly, if you look at the CB, death or heart failure in the same trial, again you can see here both the drugs is giving you advantage, and you can see again statistical significance is not there, suggesting that benefit which happens with SGLT2 alone remains with SGLT2 with DPP4. It neither potentiate nor diminished it's neutral. So don't expect a great CB benefit. Similarly, if you look at the renal endpoint, look at this renal data. The SGLT2 is giving a much better renal outcome alone than the combination of DPP4 and SGLT2. But if you go to any meeting, everybody will teach you. If you combine a DPP4 to SGLT2, it reduces proteinuria, blah, blah, blah. Sorry, there is no data. Don't get fooled. That was the message. The second one, does combining SGLT2 to GLP-1 gives you benefit? Again, this was the first study we did it to meta-analyze, does it give any advantage? The answer is absolutely no. So let's look at the data. Same, we don't have any evidence that suggests at the moment, if you combine SGLT2 to GLP-1, you expect a better cardiovascular outcome. The only benefit which we received was in the heart failure. So if you see the GLP-1 and SGLT2, combination reduces more heart failure than SGLT2 alone. So that is the only positive outcome so far been seen with combining GLP-1 to SGLT2. And no benefit in the renal endpoint was seen. So finally, to take you through the nighttime versus daytime. So let's vote here. How many of you prefer using an antihypertensive drug giving at night time? Please raise your hand. 30%. So should I assume that? Okay, so let's raise hand. How many of you prefer giving at morning, in the morning time? Okay, so nearly 30%. Now this is a huge controversy, and that's why I thought to tell you. So there was always a controversy whether nighttime or daytime antihypertensive is better. If you ask me, I always use nighttime. Now why I use at nighttime, of course, I don't prefer using beta blocker at nighttime. If there is a diuretics combination in the antihypertensive, tell the patient that for the initial 7 days you might have to go to the washroom, but then after 7 days there is a tachyphylaxis and you don't go for the frequent urination, even if you use a low dose of thiazide diuretics or thiazide-like diuretics. So therefore, if you use even a combination of diuretics with an other antihypertensive drug, it do not causes frequent urination. This concept should be completely wiped out. Now, if you look how to prefer this drug, so this was a trial you can see in 2020 called Hygia chronotherapy trial. What this trial, this has got more than 30,000 patients. In this trial, they gave patient any antihypertensive drug, regardless of the type of antihypertensive drug, either in the daytime or in the night time. And if you look at the result, if you look at the p-value, this study suggested that giving a nighttime antihypertensive drug would lower the whole 24-hour circadian rhythm, night deeper, everything far better than a daytime use of antihypertensive drug. So it's not only the BP control. Look at the right-hand side now. What this trial suggested, and this is huge, that if you use antihypertensive drug in the bedtime, in the nighttime, you reduces death. 45% reduction in all-cause mortality. You can see here 56% reduction in cardiovascular death, ischemic stroke, hemorrhagic stroke, MI, what not, bedtime better. So after the Hygia trial, people really looked at a complete different concept. Oh, is it the difference between giving a nighttime versus bedtime? Are we going to achieve this much benefit? In fact, the journal, you can see European Heart Journal could not believe on this trial. And the editor of this journal actually wrote a statutory warning that we are looking at this particular trial to whether there was some scrupulous data was done. See the interesting finding. And they put the hold this trial, but then this trial came out with a flying colors, and there was no wrong things which was done in particular Hygia chronotherapy trial. Now, since then, people learned that giving bedtime antihypertensive drug is better. But there is a but. But very recently, in this last year, you can see this is a Lancet publication called Time Study. This is a study again looking for nearly 10,000 patients. You can see in one arm and 10,000, 20,000 patients. They give the antihypertensive dose in the morning and evening, and they didn't find any difference. Whether you give in morning or evening, doesn't matter. So the Times trial was just opposite to what we learned in the Hygia trial. So people ask me then, boss, where should we use? That's the biggest question. So few days back, Sripal, Bangalore, this gentleman is actually from Bangalore. Okay, I'm sure you must be aware, Sripal Bangalore is in the United States. He's a known cardiologist in the world. Their team did a meta-analysis. You can see this paper came on 22nd May, so 5 days back. They did a meta-analysis to understand when to use an antihypertensive drug in a patients with hypertension. And they came with this conclusion that if you are using a daytime versus nighttime, there is a one benefit. So you can see this trial consisted of 72 RCT into this meta-analysis. And they came to the conclusion that actually there is no great difference in terms of mortality benefit. But there is a clear benefit that if you use bedtime antihypertensive drug, the blood pressure control 24:7 is far better with nighttime antihypertensive drug. So this is how this study concluded, that the evening dose of antihypertensive drug reduces the ambulatory blood pressure significantly better than daytime. But there wasn't any difference in the mortality outcome. So talk to your patient. Whenever they prefer to use, you can use it. But if you have no choice, if the patient tell you, give it wherever you feel like it is better, I will always prefer to give it at the bedtime. So with this few interesting point, I would like to thank you. And again, thank you very much, Aravinda and everyone, for giving me the opportunity.
Thank you, A.K. Singh, for enlightening us on the various issues when you are using various drugs in diabetes and combination of hypertension and diabetes. What drugs definitely to be not to be used, and what drugs to be used with caution. And really, the audience have benefited with this talk, and a lot of people we see prescribing various combinations in the era of various drugs which are available. You should be very careful. That's what is the message of this whatever oration. Thank you. I think there is no questions in this oration. Over to Dr. Aravind for the felicitation.
Thank you very much for this informative session, sir. I request you all to give him a huge round of applause, please. Thank you, sir. I request Dr. Aravind to present the mementos to the chairperson. Thank you, sir. Thank you, sir. Thank you, ma'am. I also would like to congratulate the main man behind this successful event, Dr. Aravind Jagdish. Let's give him a huge round of applause. Moving on to our next session, we now have the chairperson, Dr. Kiran Nidagundi, Director and Chief Diabetologist, Shubhan Diabetes Center, Bengaluru, and the other chairperson, Dr. Chetan Raikar, Diabetologist and General Physician, Bengaluru. Welcome, ma'am. Welcome, sir.
Good evening, all of you. Thank you, Dr. Aravinda, for having us here. We welcome Dr. Brij Mohan. His topic is weight is a target for type 2 DM. Small introduction to Dr. Brijmohan. Welcome, sir. Dr. Brijmohan is a member of many international associations. He's also associated with many social organizations for diabetes awareness and education, written many chapters as author in Diabetes Updates and co-editor Book of Diabetes. Various presentations involved in phase 3 trials for many anti-diabetic drugs and other molecules. Awarded fellowship for UPDA 2008. He's also received the Lifetime Achievement Award for UP Diabetes Association 2021.
Thank you, hero number one, Aravinda, for giving this opportunity. I always call him hero. Topic for today is weight as a target of type 2 diabetes. We know that there has been a major change over a past decade in the guidelines of management of type 2 diabetes. Inclusion of cardio-renal goals in high-risk population rather than purely glucose-centric goals, which we have been doing for years together. The change occurred because of various clinical trials of glucose-lowering drugs, which showed reduction in the risk of MI, stroke, renal events, and cardiovascular death. Remember, organ protection effect is independent of glucose lowering. So it has nothing to do with lowering of glucose. Yet, we have been focusing on downstream metabolic consequences, which occur probably very late in the course of disease, and that is why UK PDA showed us that type 2 diabetes is a progressive disease. मर्ज बढ़ता गया, जो दवा की वो इसी के लिए कहा था. So there is an opportunity which needs to be tapped in intervening upstream, which is a key pathophysiological driver of type 2 diabetes, that is weight or obesity. Rajiv Govil gave a beautiful talk on weight loss. 15% of weight loss has saluting effect on progression of type 2 diabetes. It causes remission of diabetes, not reversal of diabetes. So that brings us to the concept of weight or obesity as a target of type 2 diabetes. So let us see pros and cons of this. There are many complications of obesity. We know obesity brings with it biomechanical, cardiometabolic, and other complications. And diabetes and cardiovascular disease are very, very important concomitant pathologies associated with obesities. There is an unholy link between obesity and type 2 diabetes. This slide tells you that obesity, which is based on BMI, is actually not the culprit. It is the adiposopathy which is the culprit. The insulin resistance can occur independent of BMI. It can occur in the fat cells, in the liver, in the muscles. And that leads to beta cell dysfunction in the pancreas. The visceral adipocytes are giving rise to adverse cardiometabolic effects. The ectopic fat deposition is responsible for all this. That includes insulin resistance in type 2 diabetes, atherogenic dyslipidemia, hypertension, inflammation, atherosclerosis, and thrombosis, giving rise to various cardio-renal complications. We know that obesity and type 2 diabetes are interconnected, but they are heterogeneous also. Obese persons, all obese persons do not have visceral obesity. If you go by BMI, the visceral obesity, the visceral adiposity may be absent in obese person. Even people with excess adiposity, not all have metabolic complications. So that brings us to the concept of adipose tissue pathology, that is adiposopathy, rather than the quantity, that is BMI, as a prime driver of various complications. This adiposopathy is characterized by adipocyte hypertrophy, the visceral obesity, adiposity, ectopic fat deposition other than viscera, like deposited in the muscles, systemic inflammation, and metabolic dysfunctions. So this abnormality is not proportional to adipose quantity or body mass index. This is functional defect of adipocytes rather than the quantitative defect. Everybody knows that we Indians develop type 2 diabetes at a younger age, at a lower BMI, with a little weight gain, maybe no weight gain, as compared to white population. And this happens because of higher insulin resistance caused by visceral adiposity, poor beta cell response. There is recent shift in definition of obesity. Definition of obesity based on weight has been shifted to one based on comorbidities. WHO recently defined obesity as abnormal or excess fat accumulation that presents risk to health. This is shift from quantitative definition of obesity. ACE 2017 defined obesity, redefined obesity as adiposity-based chronic disease, A, B, C, D. This identifies those people who have complications related to adiposity. The weight loss is a disease-modifying intervention in people with type 2 diabetes. The weight-centric framework proves that weight loss is most common and most effective, probably the most effective means of reversing adipose pathology. But remember that this should not be interpreted as advocating for normal weight. Adiposopathy is more important. The term adipose-centric may resonate better and align with ACE to reflect underlying pathophysiology. So if you look at the roadmap of obesity and type 2 diabetes, this is the road you can see. There is adiposity, adiposopathy or obesity to begin with on the road. It leads to various comorbidities or complications. Then very late in the course of disease comes hyperglycemia, and then macro and microvascular complications. So a glucose-centric approach, which we were doing initially, that is downstream intervention, is not going to halt the progression of disease. We must look for something different, and that is upstream intervention, that is weight-centric approach. There is an opportunity which lies in intervening key pathophysiological driver of type 2 diabetes and obesity, that is adiposopathy. The term upstream approach for early impact on diabetes, what weight loss can do, it disrupts underlying pathophysiology, It reverses or slows down disease progression. There is good glycemic control with the weight loss. It impacts the organ function. The cardiometabolic risk factors are taken care by weight loss, and it prevents micro and macrovascular complications. And there are umpteen number of evidences of trials of weight loss. I'll just focus on 3 of them. Weight loss, reducing risk of diabetes. This is from very famous diabetes prevention program. Every 1 kilogram lost reduces the risk of development of type 2 diabetes by 16% in pre-diabetes. Look ahead, Rajiv told you, better control of glycemia with higher weight loss. This is the data from Look Ahead. Direct study, Rajiv again told you, 86% achieved remission on weight loss of more than 15 kgs. This is the data of direct, and there is very recent 2022 update which says that those who lost most weight, they maintained their remission for a longer period of time. There is 48% lower hazard of CVD at 10 years and reduction of CV risk factors. This is the look ahead 1 year data. There is reduction of blood pressure, triglycerides, HDL goes up and LDL goes down. 5% weight loss does all this. So weight management, what can we do about it? It can be diet, lifestyle, and behavioral therapy. Patient support system is very important. Pharmacotherapy can be used, orlistat, liraglutide, semaglutide. There are combinations of weight loss therapies available, and futuristic are dual agonist like tirzepatide and triple agonist are fast coming up. There can be bariatric or metabolic surgery also, which includes gastric banding, sleeve gastrectomy, and gold standard gastric bypass, Roux and Y bypass. So there can be 3 types of diabetes which we see in our day-to-day practice. 1, adiposity-related diabetes. 2nd, diabetes with cardiovascular disease. And 3rd, isolated hyperglycemia. So what are the primary and secondary treatment goals? In adiposity-related diabetes, insulin resistance is very, very important. Prevalence is around 60 to 70%. Target should be loss of 15% of body weight to begin with, and maintain good glucose, blood pressure, and lipids. Those with cardiovascular disease, 20 to 25% of people are there. Use proven cardioprotective agents, cardiorenal protective agents that includes SGLT2 inhibitor, GLP-1RA. Keep a watch on weight, glucose, blood pressure, lipid, and coagulation. Those with isolated hyperglycemia, there the main defect is beta cell dysfunction, which is around 10 to 20% of people, A1C of less than 7. There are certain cons of this weight loss target also. Targeting hyperglycemia, not weight itself, may be best for patients with severe hyperglycemia, lean diabetics, mild obesity, no adiposopathy. Those at higher risk of hyperglycemia related complications, there are many patients who have microvascular complications at lower threshold, and certain chronic diseases with hyperglycemia like cancer, like CLD, like CKD. These are the patients where we should focus on hyperglycemia management, not on weight management. And that has been included in ADA ESD guideline also 2023. Weight loss is there. This should always be taken care when choosing glucose lowering therapy. ACE also says that this is the principles of ACE, comprehensive type 2 diabetes management algorithm. 10 commandments are there. If you look at it, number 2 and 3 are basically talking about weight. Number 1 indirectly talks about weight. So 3 out of 10 say about weight only. Finally, weight-centric approach should be used irrespective of diabetes duration. This is very, very important. Although the adiposopathy is comparatively more common in new onset diabetes, there is reduction of macro and microvascular complications with weight loss. There is enough evidence as of now. There is secondary analysis of several RCT which have reported improvement in these endpoints. One study, EDIC post-DAM study, observed, 1 minute. Weight loss leads to reduction of microvascular complications in type 2 diabetes that happens irrespective of BMI. Emphasis on weight loss is important, and it is the key driver in changing the course of type 2 diabetes. Anti-obesity agents are going to play important role in management of weight, in management of glycemia. Management of obesity or weight is not a competitor, but an addition to existing treatment goals. Time is right to consider addition of double-digit weight loss, that is around 15%, 10 to 15% of weight loss as principal target for many type 2 diabetes, not all type 2 diabetic patients. And with that, thank you very much. And I invite all of you to KDCon 2023 on 23rd and 24th of December at Kanpur.
Thank you, Dr. Brijmohan sir, for explaining how it is important to maintain or target the weight in management of type 2 diabetes. So any questions from the audience or delegates? There are no questions, we'll end the session. Thank you, sir, once again.
Hiro.
Thank you very much, sir. May we all give him a huge round of applause, please. I request Dr. Aravind sir to present the mementos to the chairperson. Thank you, sir. Moving on to our next session. I welcome our esteemed guests. Our first chairperson is Dr. Balachandra Ji, diabetologist, Shri Dhanavantri Diabetes and Maternity Care, Bengaluru, and our second chairperson, Dr. Vinay N, diabetologist, Savimana Clinic and Diabetes Center, Bengaluru. Over to you, sir.
It would be my pleasure to invite, talking about circadian desynchrony. That is the hidden pathophysiology of diabetes. I welcome you, sir.
Thank you, sir. Thank you. First of all, I would like to thank and to Dr. Aravinda for inviting me. I'm first time in this conference. And what I have seen that a different man Aravinda is. Every time he surprises so many things. And he has given me liberty to choose any topic. And I thought that I should talk something which is not usually talked during conferences. And when we talk about pathophysiology of diabetes, you know, triumvirate to ominous octet to faithful 15 to so many things. In 2023, we know more than 23 pathophysiologies of diabetes. But one basic concept is missing in whole concept of medical practice, and that is the circadian rhythms. They are not being investigated during the history, during the examination, so that this particular pathophysiology is not being addressed. So I thought I should talk about this, and I think all of you will agree that most living organisms have molecular clocks, and almost every tissue which governs rhythmicity in many domains of physiology such as rest, activity, rhythm, feeding. So every tissue, every cell has a clock, and everything in this universe is being governed by clock only. That is the importance of clock. And we have so many biological rhythms. Their rhythms vary in time. They can be even a fraction of second, milliseconds, to hours, and to even days, weeks, months, years. So the rhythms have following the time, and in our biological rhythms, we have examples for all sort of rhythms. But circadian rhythms are those who are 24-hour rhythms, and according to that, we have distribution of various physiological functions that at particular time, particular function is at peak, and another function has another peak time. So every physiological function has got a peak time, and this had to be kept while we are talking to our patient, that what history we should take so that we can find out the missing link. And this is dependent upon so many things, but we know certain things have been studied well. They are the hormonal rhythms. They have been studied well, like we know that cortisol timing releases highest in the morning and drops during the day. And glutamate, melatonin, they are well studied. Melatonin release only at night, and the cortisol and melatonin are opposite to each other. Growth hormone increases during sleep, and we know that growth hormone is secreted by, regulated by 3-4 stimuli. One is the sleep. During sleep time, more growth hormone is secreted. And it is also dependent upon starvation. When the person is starved, more growth hormone is secreted, also by physical activity and also by the darkness. So we know that these hormones have a particular rhythm, and according to that rhythm, particular mechanisms are being regulated. And this is the particular circadian rhythm, and this is just, you see that melatonin and cortisol are opposing each other, and they also regulate so many things, and if we are not following them, then we will miss something in our diagnosis. The circadian rhythm of blood glucose has also been studied. We know that before the meal time there is basal rhythm, and then after meal the glucose increases, and you see that according to that, the hepatic production of glucose do have a circadian rhythm, insulin do have a circadian rhythm, absorption of glucose do have a circadian rhythm. So it is not similar 24 hours. That had to be kept while dealing with diabetes patients. These circadian regulations of central and peripheral clock are well known. We know that there is central clock and peripheral clock at every cell. And the central clock, central pacemaker is regulating the peripheral one. But peripheral do have their own parameters, and according to our rhythm, the peripheral clocks may not obey the central clock. That is disharmony, that is desynchrony. And we, chronobiologists, believe that most of diseases are caused by desynchrony. and they can also be treated by resynchronization. So this desynchronization had to be identified and then try to find out the measures to resynchronize that will help your patients, and you will have to use less drugs if you talk about and you know about this desynchrony and resynchronization. We know that a level of both insulin and counter-regulatory hormones which work against the action of insulin, they are influenced by a circadian rhythm. That is why in diabetic patient, this is important to know this rhythm, and this rhythm will not be same in every patient, because in today's life, everybody has its own rhythm that has been changed, influenced by so many cues, and these cues were not natural. They are artificial light and other cues which are not natural. They have influenced our circadian rhythm. The counter-regulatory hormones, which include glucagon, epinephrine, growth hormone, and cortisol, they raise blood glucose levels when needed. In the middle of the night, there is surge in the amount of growth hormone during night time. It is followed by a surge in cortisol, and which increases blood glucose production by the liver. In people who don't have diabetes, this all process are offset by increased insulin secretion by beta cells. But those who have diabetes, this process cannot be offset, and then we have the raised blood sugar at that particular time. There is a cross-talk between metabolism and biological clock, and these are interviewed at the level of basic property of homeostatic equilibrium in the body. Biological clocks have clinical implications, has long been known, but body work at molecular level is recent information, and this study has been done recently in last 4 or 5 years. We have been able to find out that the clocks are working at that particular level, and functional genetic approaches have also been studied. Now we know that disruption of circadian rhythm and increased oxidative stress lead to reduction of adipokine production in adipose tissue, and that may worsen the metabolic condition, and that can lead to various metabolic diseases. And these diseases, all diseases have this particular mechanism that when the circadian rhythm is disrupted, then the diseases can worsen and their progression can be very, very fast. The dysynchrony, which we level circadian dysynchrony between among the SCN, the central clock, and the various oscillators present in peripheral clock result in circadian associated maladies, and these maladies depend upon dysynchrony and resynchrony. And few examples have been studied well, like travel across multiple time zones, jet lag, we have multiple data on that, and shift workers, we have again robust data in the shift workers. Actually that started the story, and now the most common cause in today's world is our modern lifestyle that is producing dysynchrony, and that is why probably those developing countries are having more diabetes, because the desynchronization is more among them. Evidences are so many, but the recent evidence I'm talking about here, the evidence of internal dysynchrony caused by circadian clock resetting has been studied well, and this circadian dysynchrony occurs when endogenous rhythms become misaligned with the daily profile periodic cycles, and this condition is increased by artificial lightening. So that is one coup which has changed everything, and this artificial lightening has been studied again in terms of dysynchrony. Phase resetting of the various circadian system is the part of this dysynchrony, and we now know that this has been studied at the genetic level, also had been studied at molecular level, and we know it, recognize it. So now we can find out our patient whether he's having healthy clock or a disrupted clock. Both have its own characteristics, and by that we can be able to find out whether we are dealing with this particular person having healthy clock or disrupted clock. This disrupted clock person will definitely have metabolic diseases, whether it is pre-diabetes or diabetes or hypertension or some other disease. This cannot be said that he's a healthy person. Basic metabolic regulators have also been identified, and here the circadian clock components along with the nutrient sensing pathways prevent metabolic disease, and the interaction of 4 types of basic metabolic regulators, they prevent anything to happen, but sometimes they are not able to do that and disease occurs. They are the endocrine hormones, their own rhythm, and the transcriptional regulators which occur after the hormone, or you can say the receptor hormone synthesis, and then cell autonomous signaling modules and enzymes. So these are the 4 methods by which our body tries to control it, and the common behavior by which we can find out whether we are dealing with circadian desynchronization, and that is the increased hunger. That is one symptom. And decreased glucose and lipid metabolism, broad changes in the hormonal signals involved in satiety, and we know that we know the links, and we can find out them easily by doing the hormone analysis. Adverse cardiometabolic endpoints, forced misalignment of behavioral and circadian cycles, and energy homeostasis. So by this, we can find out this. Some other less attended factors regarding desynchrony are more food intake. That is very common in our society. Quantity has increased. Quantity of food has increased, but the quality of food has gone down. Decreased physical activity, again very, very common. Voluntary sleep curtailment. Without any reason, person is not sleeping. Or because of these, all social media, he is not able to sleep. Artificial light, bright red light, or even blue light, that has increased in our life, and night shift working in most of the individuals, and increased stress. That is very, very important, and that reflects, if you go to IDF Atlas, you will find in latest 2020 IDF Atlas that in certain part of the world, the progression of diabetes has slowed down, like Europe and America. And other parts of the world, the diabetes prevalence has increased, and increasing at very fast rate, like Africa and Southeast Asia, especially our neighbor, Pakistan. It is very, very high there. So this one particular factor is very, very common, and that is the stress. Environmental factors are also playing a role, and the most important environmental factor which is being talked and being studied at present is the particular particulate matter. Particulate matter, you can find thousands of research papers on particulate matter, and they have been found responsible for development of cancer, cardiac disease, diabetes, pre-diabetes, and so on. Erratic eating patterns in Indian adults is very, very common, and it has been found in a survey that 40% expansion of India's fast food industry in year by year. Every year, this fast food industry is being increased, and that is again causing the dysynchrony, and this dysynchrony is dependent on certain cues. These cues, most important is the sleep, and then the nutrients, and then the environmental stress. What we have learned from the experimental models. In the experimental models, the studies have been done that how desynchronization can cause disease and how resynchronization can again change everything. The most famous studies were done in the mice. And in mice, 2 groups of mice were chosen. In one group, they were given food at libitum. At any time, they were given extra food. And in another group, they were given only some food at limited time, at only particular time. And it was found that those mice which were given the food at libitum, most of them become diabetic, they become obese, and they develop a lot of diseases, hypertension, and so many diseases, and they died very early. While the other group, where the food was restricted, less food was given, and only at a particular time, they lived long, and they were not having any metabolic disease. So by these all type of studied, it was found that diabetes, inflammation can affect fibrinolysis, fluid balance, vascular reactivity. All these things were found to be associated with circadian deregulation. Those who have the deregulation, they develop all these things. So it can be responsible for causation, aggravation, and flaring up of various common disease and these diseases which we are facing at present. So circadian history taking should be our part of history taking, and that includes the time of sleep, at what time our patient is sleeping, time to meal, what time is taking meal, time to physical activity, whether he's having anything or not, daytime napping, whether it is present or not, nocturia, again very important symptom, time to defecate, time correlation with symptoms and signs, that had to be practiced in our daily practice. So this is one slide which shows that one particular symptom do have a particular rhythm. These symptoms flare up at particular time, and they can give us an idea that we are dealing with this particular disease. If the patients are having these symptoms at this time, then the same symptom at different time can lead us to diagnosis, clinical diagnosis of a particular patient can help that. And later on, by investigation, we can confirm it. Then coming to management again, we know that lifestyle management again needs a lot of resynchronization. By LSM, we can practice resynchronization by changing the time of meal, by changing the time of sleep, by changing the type of sleep. We can have so many resynchronization methods, and that we can apply to our patient. Then our need of drugs will be definitely less. As Dr. Shashank was talking in the morning, by helping that, we can giving our patient less drugs. And the light therapy is the known fact, and we are using this therapy in various psychiatric disorders, also menstruation disorders. Light therapy is working like anything. I'm finishing in 1 minute. The old traditional Indian teaching is very helpful in resynchronization, like having early dinner, chewing the food for more time, giving saliva its work. And the saliva do have so many enzymes and hormones which even go up to the hypothalamus, and early satiety is there. Small frequent meals and not skipping the breakfast, mixing the carbohydrate with protein and fat, good quality sleep and exercise, managing stress. Thank you very much. I know the time was very less, so I was a little fast. Thank you.
Thank you, Nursing Home sir, talking on this. Most important, as you said, it is a hidden pathophysiology of diabetes. It is hidden, yeah, definitely in our households also we can see our kids having the same issues. And of late we are seeing more younger patients, young age patients presenting with diabetes. So this is least touched, but most important, going by the current trends, and definitely it will pick up more. These things will be touched in future also. So thank you, sir. If there are any questions from the audience, we can just 1 or 2 questions.
Audience has developed fatigue syndrome, so they are not asking questions since morning.
Yes, ma'am. Yes.
Sir, very nice take on the circadian rhythm. So what's your advice for our night shift workers? Because we do see many of them. So what are we going to advise? We obviously can't tell them to quit their jobs because...
No.
So what modification can we make?
Yes, a very good question. Night shift working is essential in our social life. What I was talking that those who are not working in night, they are also not sleeping. For night shift workers, there are some methods which can be applied. Even during night shift workers, they should not be allowed to take meal during night time. Their meal time should remain daytime, not night time. Nighttime munching should be avoided. And to compensate that sleep, if possible, the night shift can be keep on shifting. A permanent night shift has more deleterious effect rather than a changing night shift. Because if you keep on changing, then the things become better. So one thing advice we can do about meal, about physical activity, and about sleep. These 3 things can be taken.
But what will be their major meal? Will they have a midnight meal, snacking? So this is what most of the night shift workers in large-scale industries, they do.
We can advise them to have those snacks which are calorie-free during night time, like herbal tea, like these type of things. But the nighttime munching should not be allowed. They are having activity during night time, but meal cannot be taken during night time. Because most of our digestive system, digestive enzymes, liver functions, they are not working at the same level during night time. So if they do that, desynchrony will definitely occur.
But most of them, what they do is, once they finish their night shift, they're going to come back and I think they are going to nap for a longer time during the day. It gets reversed. So
napping will be required. It will be required.
But they sleep, they miss their breakfast, they miss their lunch, so they get up somewhere.
They should not do that. they should take their breakfast, their meal, and then go to sleep. Not just coming after night shift, they go to sleep. No. They should take their meal and then go to sleep. And they should develop a particular sleep hours. Not that just after coming from duty, they go directly to sleep. No. That will definitely help. We cannot avoid night shift.
Okay.
Thank you, sir.
Thank you.
Thank you very much, sir. Thank you.
Thank you, sir. I request Dr. Aravind Jagdish and the chairperson to felicitate the speaker. I request Dr. Aravind Jagdish to present the mementos to the chairperson. Thank you, sir. Moving on to our next session. Our next chairperson is Dr. Shanka S. Sen, diabetologist from Siliguri, and our second chairperson is Dr. Venkataramanappa from Bengaluru. They will be our chairpersons for the next few sessions. We welcome you, sir.
The next talk will be on, the session fully will be on future of diabetes care. So it's something new we'll learn from this session. There will be some small sessions, mostly by 5 speakers, and there is a slight change in itinerary. The first talk will be on once a week therapies in diabetes. The speaker is Dr. Pratap Jethwani from Rajkot. And he is the National Joint Secretary of RSSDI and Chairman of the Gujarat State Chapter. Dr. Pratap Jethwani, the stage is yours.
Thank you, Chairpersons. So let me first thank Talaiwa Dr. Aravinda for making me part of this event, ADC 2023. And today I will be speaking on once a week therapies in diabetes. And this will be the agenda of my today's talk. So first of all, we need to understand why we require once a week therapies in diabetes. We all know that medication adherence is a big issue in chronic care management, and drugs, they don't work in patients who don't take them. And in chronic care, almost 50% of patients, they do not take drugs as per their prescription. And this medication adherence, if it is a poor, then it is linked with inadequate glucose control, increased risk of complications, increased risk of morbidity, mortality, increased risk of hospitalizations, emergency room visits, and ultimately it will end up with increased costs to the society and to the disease management. These are the various factors which contribute to poor medication adherence in type 2 diabetes based on this very good study, the SIMPLE study. In this study, they tried to compare GLP-1 with basal insulin against basal bolus insulin therapy, and one of the criteria of outcome was medication adherence. So they tried to find out which group of patients were more adherent to therapy and what was the effect of medication adherence on the outcomes. And if we see here, then in this group, GLP plus basal insulin, in both the groups, if you see, the people who were more than 80% adherent to the therapy, the outcomes were much better, be it HbA1c, weight, or health-related quality of life or hypoglycemia fear. Everything was much better in people who were adherent to therapy. And if you see the number of adherent patients in both the groups. In GLP-1 plus basal insulin, out of 54, 32 were adherent. And the reverse was there with basal bolus insulin therapy, only 20 out of 56. So the more complex therapy, the less will be the adherence and there will be a poor outcomes. If you give a simple therapy, adherence will improve, that will translate into better outcomes and ultimately good quality of life for your patients with type 2 diabetes. Can we improve adherence by shifting from once daily therapy to once weekly therapy, particularly in case of injectables? And this is a systemic review and meta-analysis of medication adherence. And most of the studies included in this meta-analysis were from osteoporosis, some were from diabetes, and few were from pediatric growth hormone disease. And they concluded that once weekly dosing, the adherence improves, and therefore the outcomes will improve if you follow a once weekly dosing instead of a once daily dosing, and this is particularly true for injectable therapies. The same has been proven in pediatric growth hormone disease. If you use a once weekly therapy, there will be less number of injections, it will be less burdensome, it will positively benefit patients, and it will result in improved adherence, and ultimately this will translate into better clinical outcomes. So definitely we need a once a week therapies in diabetes, particularly when it is an injectable therapy in the form of insulin or GLP-1 analog. So what are the available once a week therapies in diabetes? I think I will first start with the most novel agent, that is icodec, which is a novel basal insulin analog designed in a manner that is half-life is almost 1 week, so it requires once a week administration. It is molecularly engineered in a way that it binds to albumin and it remains in the subcutaneous depot for a longer time. There is reduced enzymatic degradation, and at the same time, the receptor mediated clearance is low, and this will result in the longer half-life of this insulin. And it has got a half-life of 196 hours in humans, and that's why we can use it once a week, and it has been shown beneficial in phase 2 programs in diabetes. So how it works, once we inject this icodec, these are the insulin monomers which are there in the subcutaneous tissue, and they bind to albumin and they remain there. So this is the first day after first injection. This is day 7 after prior to second injection, because it is a once weekly dose. Here still the monomers, they remain in the subcutaneous tissue bound to albumin. Few monomers will enter the circulation. Even 2 days after second injection, still monomers are there in the subcutaneous tissue and few are there in the circulation. And by the end of 30 days, that is 48 hours after fifth injection, most of the monomers now will be in the circulation. So steady state plasma levels will be achieved and maximum glucose lowering will be achieved. So this is the way this insulin works. But this insulin takes 3 to 4 weeks to reach its steady state plasma level concentrations, and therefore glucose lowering will be evident only at the end of 3 to 4 weeks, which is 3 to 4 days for conventional basal insulin analogs like insulin glargine. This is the trial program with insulin icodec, onwards trial program. Almost all trials have been concluded and published. Onwards 1, onwards 2, 3, 5, onwards 4 and 6. Onwards what is the first trial where it was compared with glargine in insulin-naive patients in type 2 diabetes, where HbA1c TIR and HbA1c superiority was compared. Onwards 2 was carried out in patients who are already on basal insulin, and then they were shifted either to degludec or icodec, and their comparison was done as far as HbA1c is concerned. Onwards 3 and 5, they were again carried out in insulin-naive patients, where it was compared with insulin degludec and any of the basal insulin analogs. And onwards 4 and 6, these are the trials which were conducted in patients who are already on basal bolus insulin therapy. Onwards 4 was conducted in type 2 diabetes, and onwards 6 was conducted in type 1 diabetes, where it was in type 2 it was compared with glargine with rapid-acting insulin analog, and in type 1 it was compared with degludec with rapid-acting insulin analog. I will touch upon few of the trials. So this is the first trial where it was compared with insulin glargine. in insulin-naive type 2 diabetic patients who are uncontrolled on oral therapies. And these patients were allowed to continue with metformin with or without a DPP-4 inhibitor. The starting dose of glargine here was 10 units per day. And for icodec, as it is a once-week formulation, it was multiplied by 7, so 70 units once per week. And then, depending on fasting plasma glucose, the dose was adjusted. For glargine, 2 to 4 units daily. And for icodec, it was 14 to 28 units per week. And this is the data. If you see, in icodec, the HbA1c reduced from 8 to 6.69. And in glargine, it was reduced from 8.1 to 6.87, a difference of 0.18%. More number of people were able to reach target HbA1c of less than 7 or 6.5 in icodec group, and the lesser amount of insulin was required with icodec as compared to insulin glargine. If we see hypoglycemia, 0.53 events per patient year in icodec as compared to 0.46 events per year in insulin glargine. So almost comparable, numerically higher, but this was not statistically significant. This is another study which was published recently, multi-center open-label trial which was carried out in type 2 diabetic patients who are already on basal insulin with 1 or 2 OADs, and HbA1c is not at target. And here they have randomized these patients to 3 groups. First group, they have given only insulin glargine. Second group, they have given insulin icodec, that is once weekly feeding dose. So double the dose for first injection, and then subsequently the dose as per the requirement every week. And they have tried to find out their effect on time in range between 15 to 16 weeks, and HbA1c and hypoglycemia was studied. So this is the way they have translated. If patient was on 30 units, icodec non-loading dose 210 units per week, but for loading dose 410 first injection and then 210 units every week. There was a significant improvement in time in range with icodec loading dose as compared to icodec non-loading or insulin glargine. So this suggested that if you load with double the dose, the chances of you reaching in time in target are much better as compared to insulin glargine or if you are not loading. And at the same time, hypoglycemia event rates were similar between the 3 groups. This is another data where it was compared with insulin degludec, and here also it showed that it is superior and the hypoglycemic risk is not more. And same way in basal bolus insulin therapy, it was compared with glargine with aspart as compared to icodec with aspart, again same thing. This is the last slide related to icodec by Dr. A.K. Singh. So in type 2 diabetes, there is a better glycemic control without increase in risk of hypoglycemia, but in type 1 diabetes, when you use it, it is a comparable glycemic control with increase in risk of hypoglycemic events, so you have to keep that in mind. I will just touch upon once weekly DPP-4 inhibitors. These are 2 agents which are available only in Japan. They are not even approved in USA. This is omarigliptin and trelagliptin, and both of them, they are having a good efficacy. This is 52-week data with trelagliptin, 100 milligram once a week dose, and it is having a good efficacy as well as good DPP-4 inhibitor efficacy even over a period of 52 weeks. It is there. Omarigliptin is also having glycemic efficacy, and in Japan they have also done a cardiovascular outcome data with this agent which was used in the dose of 25 milligram every week and compared with standard care of therapy, and it does not show any increase in the risk of MACE or heart failure hospitalization, and generally well tolerated, and it was also having efficacy as far as HbA1c is concerned. We all know that GLP-1 analogs are injectables, and we need to have a once weekly GLP-1 analog. We are already having a few GLP-1 analogs which are being used once a week, that is Biduron, which has got a sustained release delivery system, not available in country. Albuglutide, where it is combined with protein, albumin, which is also not available in country. Only thing available in our country is dulaglutide and semaglutide, but it is also available in an oral form. It is to be given once daily, whereas injectable is once weekly. So if we see the HbA1c and body weight change, if we compare once weekly formulations, then semaglutide has got a better outcome as far as HbA1c and body weight are concerned, particularly when it is used subcutaneously every week as compared to exenatide and dulaglutide. And if we compare it with once daily GLP-1 analogs, then there are conflicting results. And both these therapies, semaglutide and dulaglutide, they have got cardiorenal benefits. This is the data with dulaglutide, excellent HbA1c lowering on top of various therapies, and excellent body weight loss on top of various therapies. There is also data to suggest that we have to use these agents early in the course of the disease. If you see, if your patient is only on one OAD and you add GLP-1, the HbA1c reduction will be much better as compared to when your patient is on 2 or 3 OADs. So we need to use it early in the course of the disease. And they also provide cardiovascular outcomes, positive cardiovascular benefits, as with semaglutide in SUSTAIN 6 and dulaglutide in REWIND, and also the renal outcomes are positive. Tirzepatide I will not touch upon because Dr. Ajay Tiwari is going to speak on tirzepatide. Future perspective, I will say that innovation is the ability to see change as an opportunity and not a threat. We are currently in the era of peptide being given in a pill in the form of oral semaglutide. And this variety of processes are still going on in our world as far as pharmacotherapy is concerned in various fields. And in near future, we are looking forward to this kind of therapies like SOMA, self-orienting millimeter scale applicator, then glucose responsive microneedle, and also this is the particle release micro pellets in which the glucose will be released slowly in response to a glucose. Insulin will be released slowly in response to a glucose hyperglycemia, so that we will be able to maintain glucose in normal range without increasing the risk of hypoglycemia, and that will improve the lives of people living with diabetes, particularly when insulin is must. So with that I end my talk, and I will say that technology is just a tool. Whatever technology you use, particularly it is the person who is using technology that is important. So in terms of getting the kids working together and motivating them, the teacher is the most important, as Bill Gates said. So I think using technology and making you aware of recent advances in diabetes is very much important, because you are the one who are going to use technology safely and judiciously in your type 2 diabetic patients. Thank you very much.
Thank you for that wonderful session, sir. I request Dr. Aravind Jagdish and the chairperson to felicitate the speaker. Let's give them a huge round of applause, please. Thank you, sir. Our chairpersons, Dr. Shankar S. Sen and Venkataramanappa sir, will continue this session.
The present topic is by Dr. Prashad Shankar from Kerala. I request him to kindly speak on artificial pancreas. Prashant, please.
Thank you, Chairpersons, and big thanks to Dr. Aravinda for giving me this opportunity. I have been given a topic which is actually not in my domain, but I'll try to give justice to the topic provided to me by Dr. Aravinda. So, artificial pancreas. No disclosures. So this will be the flow of discussion today. An introduction, early closed-loop systems, current closed-loop systems, DIYs, and finally the future directions. So a biological cure for type 1 diabetes is not realistic in the near future, as we know. But a technical solution for diabetes management, that is the automated insulin delivery device systems, are there. They actually integrate data from a CGM system a control algorithm, and an insulin pump to automate subcutaneous insulin delivery. And many different terms are there for the AID system. All describe the fundamental approach, and artificial pancreas is an overall term which encompasses all these things. So these are the standard terminologies which are there. The first one is a sensor augmented pump, where we have a pump and a sensor which gives the readings, the blood sugar readings, but there is no feedback mechanism to control the insulin secretion. Then we have the LGS, or the low glucose suspend, which actually suspends the insulin release when the glucose actually gets low. Another advancement is the predictive low glucose, or the PLGS, where there is a prediction. The pump automatically suspends before the blood glucose becomes low. And then we have the latest one, the hybrid AID, which is also known as the hybrid closed loop, which is actually an insulin pump system that automatically increases or decreases the basal insulin delivery in response to the sensor glucose values, but still needs the boluses to be provided. An advanced HACL, or the advanced hybrid AID, it also has the capacity to deliver the automatic correction boluses, but still the boluses require manual correction. So this is simple as that. On the right, you have the sensor augmented insulin pump therapy, where there is no connection or there is no feedback control on the insulin. And on the hybrid, you have the feedback control on the insulin release. A full AID is what we are aiming at, which actually adjusts insulin delivery, including the prandial insulin, where the patient has nothing to do. The DIY, or the do-it-yourself AID system, is a commercially available CGM, uses a commercially available CGM and pump, but it is not approved by the regulatory authorities. The artificial pancreas, as I said, is a general term, but again, it's a misnomer because it does not take care of the exocrine functions. And the bihormonal pancreas, or the bionic pancreas actually has insulin and glucagon, and there are some systems which use insulin and pramlintide. So these are the early closed loop system. The first insulin pump, which was developed in 1963, it was like a backpack. It could not be used. It was not used much. And this is probably the first artificial pancreas, which was developed in the 1970s, but it was only again used for research purposes and inpatient use. So this is the classical picture which shows the current artificial closed loop system. There is a computer generated algorithm, and there is a CGM sensor, an insulin infusion pump, and their patient response, and everything is connected to a smartphone. So the JDRF, or the Juvenile Diabetes Research Foundation, in 2005 in 2005 established the artificial pancreas project with the aim of improving the technologies, and it defined 6 categories of artificial pancreas systems. So the first was the very low glucose insulin pump off pump. The second was the hypoglycemia minimizer. The third was the hypoglycemia and the hyperglycemia minimizer. Then came the automated basal hybrid closed loop. Then came the fully automated insulin closed loop, and the fully automated multi-hormone closed loop. So some of these have been developed and are in use. The 5 and 6 are currently not approved for clinical use. So coming to the low glucose suspend systems, these are the simplest form of the closed loop system. They have an ability to automatically suspend the insulin infusion when the level falls below a certain threshold without confirming with the user. And the primary benefit in the studies is reduced nocturnal hypoglycemia without an increase in the HbA1c. And the predictive low glucose system, as we explained, contain algorithms that predict future hypoglycemia and preemptively suspend the insulin delivery before the hypoglycemia. So the Minimed paradigm VO is the one, is the low glucose suspend system. This is the Minimed 640, which is the which has got the predictive low glucose suspend, and this is another model, the T-Slim X2, which is again the predictive low glucose suspend. The hybrid closed loop system, which aim to minimize the hypoglycemia and hyperglycemia. They maintain the glucose levels in the target range through basal corrections. Again, boluses will have to be given. The user still will have to use manual doses with meals, and again, it has shown improvements in the time in range, reduced hypoglycemia in the studies. So the brain of the artificial pancreas is the algorithm. So the algorithm regulates the correct insulin injection rate based on the CGM's glucose level, and the usage of a control algorithm could hinder the event of hypoglycemia and hyperglycemia, and it should have certain properties like this. So there are three main types of algorithms which are used. The commonly used ones are the model predictive control and the proportional integral derivative. Both these are algorithms which are more of the artificial intelligence type. And the fuzzy logic is actually based on the clinician's experience on the response to the blood glucose. And the last one is actually an expansion of the fuzzy logic. Again, these have all been used in various artificial pancreas systems. So these are the artificial pancreas systems which are currently available in the market, right from the Minimed to the Omnipod, the CAM APX, and the Tandem, which are all, some of these are not available in our country. So I'll just go through the Minimed 670G because it is an classical example of the hybrid closed loop. Again, it has got an integrated PID algorithm with Guardian 3 sensor. It has got an auto mode where the automatic suspend works, but it requires minimum 2 finger calibrations per day. And the disadvantages is that the remote data viewing is not available, and the auto mode use declines significantly over time with a high rate of closed loop therapy discontinuation. So it has gone out of interest. This is the latest one which most of us are using, the 780G advanced hybrid closed loop system, which again has an inbuilt PID algorithm. It requires fewer finger prick calibrations, and if you're using the Guardian 4 sensor, it doesn't require any calibration. It administers automatic correction boluses, and glucose targets are customizable, and the remote viewing is always available on your smartphone. And it has got fewer auto mode exits, which means that it can be used. It is more friendly to the patient. This is something which is interesting, which has come up in the past few years. In 2015, there was a movement known as the DIY movement, and it had the hashtag "We are not waiting." But all these type 1 diabetes people with diabetes were frustrated for the lack of proper systems. So these are systems which connect commercially available insulin pumps and CGMs to an open source algorithm. And these work as a hybrid closed loop system or even as a fully closed loop system without any need for the bolus correction. And the algorithms used are Open APS, Android APS, and Loop. These are the commonly used algorithms. And estimates that more than 2,000 people worldwide are using these DIY systems. And the most attractive feature is that it includes low cost and availability and increased customizability. So I would just compare these things to the what we see when we go to buy a PC. You know that there is a branded PC and an assembled PC. The difference is just like that. So there are benefits of the AID, but this has not been evaluated in their RCTs. There are certain gray zones which could create problems to the patients, and again, results of a number of real-world studies show remarkably positive outcomes even during pregnancy, but again, it is not approved in this. So there are some advices which should be given by the practitioner. If somebody asks you about a DIY system, it is not approved. It cannot be prescribed to the patient, but it is patient's responsibility, but the clinician can take care of the patient in some situations, and all these things should be documented. So there is this is the presentation which Dr. Jyotidev gave on the DIY pancreas at the ATTD. You can get it in the YouTube. It's a very useful article. And coming to the future directions, I will just rush through this. The fully closed loop systems are which we are looking at, and these are designed to automate insulin delivery without requiring the input for mealtime boluses. And the main challenge is the postprandial excursion. I will take just one moment. Often the late hypoglycemia is another issue with the fully closed loop systems, and it uses the same hybrid algorithms, and sometimes different algorithms can also be used. The challenge with the fully closed loop system is the glycemic control after exercise and other challenges like the duration, intensity of physical activity. All these cannot be integrated into the current algorithms. And multiple data like heart rate, skin temperature, all these have been tried in the clinical trials. And even the heart rate monitor has been integrated to the closed loop system. And actually, it has shown that the TIR is actually lower compared to the hybrid closed loop studies, even with the ultra rapid insulin analog. So a lot of things need to be done to get a perfectly fully closed loop system. This is the only available closed loop system which is only used in Japan, and it is used only for inpatient purposes, and it is approved only for a 3-day period perioperatively. Again, dual hormone closed loop system, the primary rationale is to prevent hypoglycemia, because we know that glucagon has a very rapid onset of action, and it helps in preventing hypoglycemia or treating hypoglycemia much faster than the stoppage of insulin. And again, the main barriers in the dual hormone system is the lack of stable liquid formulation. The islet is the one which uses insulin and dasiglucagon, which is a extended form of glucagon, which has got more half-life. Insulin has again been tried with pramlintide for better sugars and PPG control. This is another dual hormone approach which is being tried. And again, the practicality is limited by the requirement of 2 separate infusion reservoirs. This is the last area. A multi-center randomized trial on bionic pancreas. This is one of the latest articles which has come, which actually looked at bolus regime. It is something close to the something near to the fully closed loop mechanism. So here, what happened is that there is no typical breakfast, lunch, or dinner bolus which is there. But you have something known as the meal announcements, which consists of qualitative estimate of the carb content, which is like usual for me, more for me, or less for me. And in this, the user is not able to modify the insulin doses. And you can see the results were very impressive. Lower HbA1c, increase in TIR, less time in the hyperglycemic state without increase in the incidence of hypoglycemia. So this is something which could be there in the future. So I will skip the next slides. In pregnancy, the only system which is approved is CAM APS-FX, but off-label use of Minimed 670 is also being done. There are many limitations for the AID systems. We are talking about the advantages. There are quite a number of disadvantages also that has to be taken into account. So these are the considerations for patient selection. Those who are technically capable of use, these are the patients who should be given the AID system. Those who are technically capable of using the insulin pump, those with realistic expectations which may mitigate the feelings of frustration once you start the system. It's not a perfect system. It has got its own limitations. Those who are appropriately trained and supported both financially and medically, especially the insurance coverage comes into play. And those patients who should be mentally and psychologically able to fulfill the requirements. So these are the candidates who should be preferred candidates for starting an automated insulin delivery system. So coming to the concluding slide, the use of AID does not mean diabetes can be cured. AID systems hold promise to relieve some of the daily burdens of diabetes care by adjusting the basal delivery and providing automatic correction doses. The past decade has seen rapid advances in the development of the closed loop system and the hybrid closed loop system, transitioning from research to commercial availability. The ultimate artificial pancreas, a fully closed loop system, has not yet been realized so far in clinical practice, but what the rapidity of research and the success rate of the current trial shows that it is going to come in the near future. And the healthcare system related factors contribute to the closed loop system adoption due to lack of reimbursement. Thank you. Thank you.
Thank you, Dr. Prashant, for the nice presentation. Are there any questions? Thank you, Shankar, for the nice presentation again.
Thank you, sir. I request Dr. Aravind Jagadish and the chairperson to felicitate the speaker. May we all give them a huge round of applause, please. I request Dr. Aravind Jagdish to present the mementos to the chairperson.
So moving on to the third talk on this session, it will be on CGMS and its role in time in range. May I invite on stage the speaker, Dr. Subhash Kumar from Patna, and he will be speaking on CGMS and its role in time in range. He is a PG Deep Diabetes from University of South Wales, UK, MSc Diabetes from Cardiff, UK, and RCGP Royal College, UK. Dr. Kumar, the stage is yours, please.
Good evening, everyone. Thank you, chairpersons. A big congratulations to my perfectionist friend Arvinda and his wife, who I am seeing from the morning that they are keeping the whole thing in a perfect shape. And it is an auspicious day when my Professor Basan Goda and my chairman, immediate past chairman B.K. Singh is there in the hall. So the topic I'm going to talk is on CGM and glycemic variability. Tight glycemic management has become a cornerstone of modern diabetes management. And glycosylated hemoglobin is the only tool which we had until very recently. After the advent of continuous glucose monitoring system, which is a giant leap in the diabetes management, as glycosylated hemoglobin was not able to detect the fluctuations, especially hypoglycemia and hyperglycemia, which were missed, but we used to think that the parameters are within range, as we only looked at the levels which was given by an average of 3 months. But this is a giant leap when we have a matrix where we can have a complete, clear picture of how the blood sugar levels are behaving in a particular person. And if you compare it with the self-monitoring of blood glucose, it is something like SMBG is a still photography and CGM is a complete video where you get a complete picture of what is happening minute to minute in a diabetic person. And the devices which we have in India is from Guardians by Medtronic, 6G by Dexcom, Libre, which has a few models, Libre Pro, and Libre 3 is still not in India, and Eversense by Sensonomics. And out of it, Medtronic and Libre Pro is quite common, and we all have used, and we have seen that they provide wealth of data regarding the glycemic behavior, the dietary pattern, and it helps a lot in terms of adjusting the dose of insulin and other anti-hyperglycemic agents. This is one of the cutest type 1 kid which we have, and there was large glycemic excursion, so we had put, and it also provides us opportunity to make family and the patient understand about the carbohydrate intake ratio, the carb counting, insulin to carb ratio, and other calculations which can be very well or very clearly been measured once we have put this advent. To understand the variability, the excursion, the glycemic variability is defined as fluctuations of blood glucose level over a given interval of time, like within a day or between the day. And it has 2 different metrics, that is the amplitude axis, which measures the which measures as a standard deviation or mean amplitude of glycemic excursions, which has been looked at different newer therapy, and it is considered as one of the goal for the therapy. And time axis again, which is time spent below the target and above the target, that is time in range, which is again a new metrics which we look at when we want to treat a person to prevent the complication in long run. So frequent blood glucose, if at all A1C of the same level, but we can see that a person can have a large excursion of glycemic level, but still HbA1c will not be different. So we had to look at these newer metrics to prevent complications, because earlier when we used to think that even the A1Cs are maintained, but a person is suffering from some other type of complication, either microvascular or macrovascular, and it was the variability which is very important, and it has come in robust data which I will be just showing. So variability also a marker of instability of person's metabolic system, which is expressed as frequent high and low, and it is well established factor to detect hypoglycemia or suspect hypoglycemia when you have large excursion. And the symptoms which we used to miss when patient comes to us with fatigue, confusion, dizziness, mood changes, with good control, we never thought that it is the higher excursion which is causing this. And prolonged frequent glycemic variability can increase the risk of hypoglycemia unawareness, which is always missed many a time in our busy clinic, and other complications which we have understood we have in different studies. So improving time in range becomes an unmet need in the treatment of diabetes, and we have a duration of patient blood glucose within the target of 70 to 180, and also we should have a very fixed interval to have a time below or time above the range, which I will be discussing. This is the level where 70 to 180 milligram is in the target range, that is time in range target, and above target 180 level 1 hyperglycemia, more than 250 level 2 hyperglycemia, and hypo same way 70 and 54 as level 1 and 2 hypoglycemia. So international consensus on time in range has put a clear target, which again depends on type 1 and type 2 diabetes. If an old, frail patient, they may have a little relaxed target. As you can see, the time in range is fixed to the 50%, and they can have a little liberal one. But then it comes when it is pregnancy with type 1 diabetes and GDM and type 2 diabetes with pregnancy, we have different levels. So we have to consider these targets once we treat them. Glycemic variability has been clearly identified as a potential risk for all the complications, and in a meta-analysis of 20 studies of more than 95,000 patients, they have clearly shown a clear link between the complications and higher variability. Same way, the DCC treatment group compare the intensive and conventional arm, where time in range was 52 in intensive and conventional 31%. So higher time in range correlates with less microvascular complications. If you look at the data provided by Beck et al., they clearly showed that if we have a time in range more than 70%, we have lesser risk of retinopathy and microalbuminuria. As the time in range deteriorates, the risk of complications also deteriorates. And there are a number of studies where they have looked at all-cause mortality, coronary syndrome, and other coronary artery spasm, different complications, hypoglycemia, in different studies which has clearly shown that short-term MAGE also has clear link with it. So blood glucose variability leads to rapid progression of coronary artery disease. MAGE early after onset of ACS is a predictor of rapid progression of non-culprit lesions as well. So glycemic variability is clearly linked with inflammation and endothelial dysfunction, which can contribute to the progression of atherosclerosis, and is also indicator for oxidative stress and has a which directs promote the atherosclerosis. If you look at the variability and coronary plaque vulnerability, again this 46 patient data by Gulabra suggested that high MAGE was the only significant determinant of thin cap fibroatheroma independent of coronary risk factor. Homeostasis model assessment of insulin resistance and HbA1c. So GV clearly emerged as a target for reducing the safe blood glucose level and determine the direct effect on vascular complications, and also end-stage renal disease has been clearly linked with the higher variability. So even 10% loss or 10% decrease in time in range will increase 60% risk of retinopathy, 40% microalbuminuria, and 25% neuropathy. How to mitigate that? Low carb diet, meal timing, aerobic exercise, stress also is one of the important factor, and medication and hormonal changes are the one which are non-pharmacological treatment approach for reducing the variability. And we do have drugs which is SGLT2, DPP4, GLP-1 receptor agonist, and we have a combinations of different basal insulin with GLP-1 are the one. Even pioglitazone has shown a reduced variability. So I think we have different drugs and we can choose depending on the requirement of the patient. So I'll stop over here and I thank everyone. I'm happy to take any question if it's there.
Thank you, Doctor, for the nice presentation. Are there any questions? No, thank you.
Thank you for that wonderful presentation, sir. I request Dr. Aravind Jagdish and the chairperson to felicitate the speaker. May we give him a huge round of applause, please? Thank you, sir. Moving on to the next session, it will be continued by our same chairperson, Dr. Shankar S. Sen and Dr. Venkataramanappa.
I now invite Dr. Ajay Tiwari, the diabetologist from Jai Diabetes Care Center, Lucknow, to speak on twin cretins. What to expect?
Good evening, everyone. At the onset, I'd like to thank Dr. Aravind Jagdisha for giving me this opportunity to be part of this scientific feast. And I would be talking about a very interesting new development. And unfortunately, it has not come to India. But this new concept of twin cretins will be the magic pill both for the management of diabetes as well as for the obesity. So these are the famous Petronas towers, and this depicts what I'm going to talk in next 10 to 15 minutes. So we are all aware that despite of the therapies, the current therapies that are available to us, still more than 30% of our patients, they fail to reach their glycemic targets. And despite of having nth number of anti-obesity drugs, the long-term weight loss is still an angina. So we are still not able to achieve, we do not have any drug which definitely causes reduction in the weight on a long-term basis. So we definitely have to have drugs which provide us better HbA1c control and at the same time also address the core defect, that is the obesity. So this is the most important slide, and this shows that what is now coming in the fore, and that is the evolving concept of GIP, that is the glucose-dependent insulinotropic polypeptide, and the GLP-1 partnership in metabolism. And we have already had lot of GLP-1 analogs with us, but once we are adding these GIPs to this partnership, we are adding more to our armamentarium as regards to the control of diabetes as well as obesity. So coming to why this GIP was added, so what is the contribution of various gut-derived factors to postprandial insulin secretion? So if you see, the glucose contributes to 26%, the GLP-1 to 29%, and the GIP adds another 45%. So we are having a very potent combination to address both the HbA1c control as well as the obesity factor. So these are the list of twin creatines which are being studied currently. So we know that tirzepatide is already in the market, and we have other GIP, GLP receptor co-agonists which are being developed, and few of them were discontinued during their development. So coming to tirzepatide, and I think this is a very important drug because it is being touted as a magic pill, and it is being used off-label. And this time when we were in the ACE, they said that this particular drug is being used more for obesity rather than an anti-diabetic drug. And it is short in the market. And Eli Lilly is working on more and more plants to produce more of this drug. So this has got a dual action, that is at the level of GLP-1 as well as for GIP. Once we are using a GIP receptor agonist, we are having improved insulin secretion and the increased adiposity. And when we are combining these two, we have an enhanced hormone activity, increased beta cell mass, improved insulin secretion, and improved glucose homeostasis. So this tirzepatide is a novel dual GIP and GLP receptor agonist. It has got 39 amino acids, and it has got a mean half-life of 5 days, enabling once weekly dosing. And we have got a set of these trials. These are the SURPASS trials, where they have shown their efficacy as regards to the weight reduction as well as for the HbA1c control. So this is the basic mechanism of tirzepatide. So it acts at both the GLP-1 IR and the GIP IR, and it leads to increased production of cyclic AMP, and this cyclic AMP further leads to the protein kinase A production, and this leads to finally the depolarization of the insulin, these globules, and the release of the insulin. So the initial dose is 2.5 milligram once weekly, and it has to be built over every 4 weeks, and the maximum dose that is being touted for as an anti-obesity drug is 15 milligram once weekly. So these are the common side effects. I'm just walking you through the basics so that we have a better impression what we are seeing. So the side effects are dyspepsia, abdominal pain, loss of appetite, nausea, constipation, and rashes. Then hypersensitivity reactions have also been reported, urticaria, eczema, and angioedema. Then there is a increased incidence of thyroid cell carcinoma seen in mouse. So that was also with the GLP-1 analog. So that is one point where we have to think that if there is a history of thyroid cell carcinomas or MEN2A syndrome, then we have to avoid this drug. Then these are the precautions like gastroparesis. This is all with GLP-1 analogs. Cholelithiasis could be there. And diabetic retinopathy, we had an increased incidence of diabetic retinopathy because of the sudden improvement in the glycemic control. Then there could be an increased rate of hypoglycemia when we are using these drugs with insulin or the secretagogues. Then coming to the SURPASS trials, which this was the basic, how this molecule came into the fore, and this is the study design of the SURPASS trial, and we had patients with type 2 diabetes with an A1C between 7 to 9.5 and BMI of more than 23 kilogram per meter square, and they used the different doses of tirzepatide, that is 5 milligram, 10 milligram, 15 milligram, vis-a-vis the comparator. So in the SURPASS 1, they compared with the placebo. SURPASS 2, they compared with the semaglutide. And for SURPASS 3, they compared with, on the background of metformin and SGLT2 inhibitors, they compared with the degludec. And for SURPASS 4, they again had a background therapy of metformin, SGLT2 inhibitors or sulfonylureas, and they compared with the glargine. And for SURPASS 5, they had glargine and metformin, the background therapy, and they compared with the placebo. And this SURPASS CVOT, they are already recruiting. The results are not out as is. So these are the results as regards to the reduction in HbA1c. So if you see all across, the HbA1c reduction is to the tune of around 2.7%. So I think this is very significant. What we have been seeing around 1 to 1.5% HbA1c reduction with the usual therapies that we have, but this drug has a HbA1c reduction to the tune of 2.07% with a dose of 15 milligram. The dark blue bar represents the 15 milligram dose of the tirzepatide. Then as regards to the weight reduction, if you see all across the SURPASS 1 to SURPASS 5 trials, you see there is a reduction to the tune of around 12.5 kg with the 15 milligram dose of the tirzepatide. Then as regards to the safety results, the most common side effect was the nausea, followed by vomiting, diarrhea, abdominal pain, dyspepsia, fatigue, elevation of calcium, calcitonin levels, and the constipation. Then there is no CVOT data available with us, but this particular trial, that is the SURPASS CVOT trial, is already undergoing recruitment. So all across the SURPASS group of trials, we found that there is a substantial reduction in HbA1c to the tune of around 2% and a weight reduction to the tune of 10 to 12 kg. Then they said that yes, we already have some data as regards to the reduction of HbA1c as well as the obesity. So now they wanted to check this drug, whether it has got any benefits or can this particular drug qualify as a proper anti-obesity drug. So they went for another set of studies, that is the SURMOUNT group of trials. So the SURMOUNT 1 had people with obesity or BMI of more than 27 kilogram per meter square and related comorbidities. SURMOUNT 2, people with type 2 diabetes plus BMI of more than 27. SURMOUNT 3, they did not have diabetes. They were only the patients without diabetes but with obesity. And the same holds true for SURMOUNT 4. So we have data with two of the trials, that is the SURMOUNT 1 and SURMOUNT 2. So this is a global clinical development program with more than 5,000 people with obesity or overweight. The SURMOUNT 1 and 2 had people with type 2 diabetes, that I've already told you, and a BMI of more than 27 and comorbidities, and the SURMOUNT 3 and 4 had only patients with obesity without diabetes. So this particular paper was published in NEJM, and this was about the SURMOUNT trial, and what they found that with a dose of 15 milligram of tirzepatide, they had a 20.9 kg reduction in the weight. And that was, I think, what we have seen in the recent times. This was the maximum weight reduction that we have seen with all the three. So I will be comparing the other anti-obesity drugs also. Then very recently the SURMOUNT 2 trial results have already come, and this particular trial will be presented at the ADA 2023. So the Eli Lilly has already come out with the data, and what they have found that the tirzepatide, what they found that average weight reduction with tirzepatide 10 milligram was 12.8%, and with tirzepatide 15 milligram was 14.7%, as compared to 3.2% with placebo. And as regards to people achieving a weight reduction of more than 5%, 79.2% of the patients achieved a weight reduction of more than 5% with tirzepatide 10 milligram and 82.7 with a dose of 15 milligram, as compared to 32.5 with placebo. And the percentage of patients achieving more than 15%, it was 39.7 and 48%. Then this was the actual efficacy estimate, and it was 13.5 kg with a dose of 10 milligram and 15.6 with a dose of 15 milligram. And as regards to the discontinuation due to adverse events, the rate was 3.8% with 10 milligram and 7.4% with a 15 milligram dose. So all the more it was very well accepted, and we had very strong reduction in the weight. So now the Eli Lilly, as a move forward, has already put in a US FDA clearance for accepting this drug as an anti-obesity agent, and by the end of 2023, it is expected that this will be given this thing. So now coming to the most important part, most interesting part, and I'll take another 1 or 2 minutes. This is how it fares vis-a-vis the other anti-obesity drugs that we already have. So the Mounjaro is basically the tirzepatide, and when we compare it with semaglutide, that is the Wegovy, that is the 2.4 milligram dose of semaglutide, we have an average weight loss of 20.9% with tirzepatide as compared to 14.9% with Wegovy. And the dropout rate was similar in both the groups. One was a pure GLP-1 RA agonist at a higher dose, and one was a combination of GLP and GIP. Then coming to what we had previously as anti-obesity drugs. So phentermine, it caused around 5%, phentermine, topiramate, 8 to 10%. When we had a bupropion, naltrexone combination, around 4 to 5%. Liraglutide, Saxenda, which was the first anti-obesity drug to be accepted, it was 8%. Semaglutide, Wegovy, it is 15%. And with tirzepatide, we have 20.9%. And if you see the bariatric surgery data also has 25 to 30%. So now we have an oral drug which could have some effect as regards to an anti-obesity drug, which is not at par but almost equals what we are getting with the surgery. So this has already been accepted as in the algorithm of the glycemic control, which was proposed by the ACE 2023, and they have already said that for overweight and obesity patients, we can have GLP-RA analogs or a combination of GIP and GLP-RA analogs. And for, again, another class, when there is a severe hyperglycemia, again there is an indication for GLP and GIP-RA analogs. So, closing my talk, so I was guessing why this name Mounjaro, where from it came. So this is what I found, that climbing Mount Kilimanjaro is sometimes used as a metaphor for doing something very difficult. For many people, finally getting their weight under control can still seem like climbing Mount Kilimanjaro, achieving a difficult goal. So Mounjaro is a short for Mount Kilimanjaro, which is a metaphor for success. Thank you very much for patient hearing.
Thank you, Dr. Tiwari. Any questions or comments?
Thank you very much, sir. We have a last session now. After this, there's a cocktail party and dinner. So one last informative talk before a good dinner. Please give him a big round of applause, everybody.
The last talk after a long day, but one of the most important ones. The topic is Future of Diabetes Technology. May I invite on stage Dr. Rakesh Parikh from Jaipur. He's a consultant diabetologist from Jaipur. He's a national executive member of RSSDI. And the talk will be on Future of Diabetes Technology.
Thank you, Chairpersons, and thank you, Dr. Aravind, for inviting me for this talk. I'm the last batsman today, and I'm the one who is in between you and the cocktail dinner, so I'll try to rush up. This is a disclaimer. I'm not a professional fortune teller, and I'm not paid for this fortune telling session. Now, future is a subjective term, so the tools which are available in Western world, USA or European countries, since last 5-7 years, they are not yet available in India. So for us, the near future is to have Libre 3 or Dexcom G6, Dexcom G7, or the other insulin pumps which are not available yet in India. That's the future for us. But there are so many other things which are happening in the field of diabetes. I'll just try to touch upon these. Now, the major research which was happening was in the field of glucose monitoring and insulin delivery. Both of these have been covered in the previous talk, so I'll try to skip the slides of these. And then there are a lot of apps and softwares which are available. Again, I'll not cover those because we have a shortage of time. Then there is a new area that is digital therapeutics. I'll just have one slide on that. Then there are certain developments in the field of prevention of complications and treatment of complications of diabetes. I'll have some slides on that. Then newer targets are being identified for treatment of diabetes or even reversal of diabetes or even cure of type 1 diabetes. I'll just touch upon that. Adipose tissue is now identified as a new target. Some drugs are being developed to work in that direction. Then some research is still going on in the field of stem cell therapy and gene therapy. Gene therapy I'll not cover in this session, but gene therapy, there is a technology called CRISPR gene technology in which they have tried to modify the genes or the DNA of adult, and it is in experimental phase as of now, but then that is being looked upon as a future prospect for even cure of type 1 or treatment of type 2 diabetes. And then the last big elephant in the room is artificial intelligence. Again, I'll just have one slide on that. So starting with the monitoring tools, these were covered earlier in the talk, so I'll not go into details, but these are the different CGM devices which are available in the Western world. In our country, we just have Libre Pro and Libre, which has recently been made available. The efforts have been to reduce the MARD. MARD is basically the parameter for variability of the glucose that you estimate from the CGM device. So the efforts are on to reduce the MARD. And these are the latest CGM devices which are available in the Western world, not in India. They have reduced the size of the sensor. So you can see that G7 is the very small sized CGM device. Then Libre 3 is also small. And Eversense is the implantable CGM device which can last for 6 months as of now. So the efforts are in the direction of reducing the MARD, making it, having a longer sensor life from 10-14 days to a few months, and also to reduce the requirement of calibrations which was there with the earlier CGM devices. This is the Eversense device. As of now, it lasts for around 180 days. You just need to put the implant once and it will work for 6 months. Now the efforts are on to make it, the sensor life to be around 1 year or 1.5 years. It's already in the trial phase. I just got a feasibility question from some sponsors, and they are working on the CGM device which can last for 1.5 years. Just you need to implant it once. Now in the insulin pumps, we had so many developments. Again, those were covered earlier, and these are the different devices which are available in the Western world. And again, in the insulin pumps, there are so many things that need to be worked upon. Some of those were covered by Dr. Prashant. The tubing is a problem, so patch pumps are now available. They are not yet in the India. Then the patients still need to adjust the dose of their basal insulin. They need to take the bolus shots. Still there is no closed loop circuit which is available as of now. DIY looping was already covered by Dr. Prashant, so I'll skip it. And this is the Omnipod, which is a pod pump, which is a patch pump, so there is no tubing here. You just need to put it on the abdomen. And then this is the Eco Patch, which is again a patch pump, but smaller in size, and this is disposable. So you need to change the whole pump every week. And this has been bought just yesterday by Medtronic. So Medtronic has overtaken this company, and now Medtronic will be developing it further and bringing it to market. Then dual hormone pumps are the future, not yet available in the market, in which you will have insulin as well as glucagon pump. And in these, the bionic pancreas, Beta Bionic, this is called bionic pancreas. Beta Bionic is a company in which they have developed these dual hormone pumps, and they have done a trial recently in which I think Prashant also referred to that trial. They have shown that the patient doesn't need to do any interference with the pump. The patient just has to put the weight of the patient, and this device will automatically calculate the basal doses. It will also give the bolus shots. The patient just has to announce the meal, that I am taking a meal now, and the pump will automatically adjust the dose of bolus requirement of the patient as well. Now, these are the things which are in the future, but they may not be affordable to our population for a long time. So we have these cheap insulin pump options which are still not in India, available in the Western world, but these can probably be something in between the pump and the routine pens that we use. So these are the connected pens. They work a little bit like a pump. So these pumps are connected, these pens are connected to the smartphones, and they can record the timing of insulin injection, they can record the dose of insulin that is taken, the meal timing can be entered in the software, in the app. They will also tell you about the insulin remaining in the vial and so many things. They can also record the temperature of the insulin. So these are the devices which we might see in near future in our country. And these are the different pens, smart pens, which are available in the Western world, and probably we hope to get them soon in India. And this is a patch pump which is used only for bolus shots. So it's just a patch in which there is a rapid-acting insulin, and every click is for 2 minutes. So it can replace the bolus shots of the patient. So the future is that we are looking for a closed loop artificial pancreas in which there is an insulin pump and there is a glucose monitoring device. Both of them are connected with algorithm. The pump should calculate the doses of insulin automatically. The human interference should be minimum, and all those data can be captured on devices, smartphones, laptops, and can be transmitted to the healthcare provider. So that is the near future. That is the future that we are looking for. Now, this is something interesting. People are working on developing smart insulins. These are glucose-responsive insulins. So these are the insulin molecules which will release insulin only when the glucose levels are high. And you will not require anything additional. Just inject this insulin and it will work only if the sugar levels are high. If the sugar levels are low, it will not work. And the efforts are on in this direction. These are a few of those projects which are working in the field of smart insulin. One of those is the company that is Eli Lilly. Others are the academic universities. And these are the products which are still in the trial phase. Then digital therapeutics is basically a product that delivers evidence-based therapeutic intervention to patients that are driven by high-quality software programs to prevent, manage, or treat a medical disorder or a disease. So these are basically algorithms, and these algorithms are designed that they will provide the interventions or advise the interventions to the patient. Again, in this area, a lot of companies are investing. You can see the names here: Eli Lilly, Novartis, Sanofi. These are all well-known companies, but they are putting a lot of money in this area. AI-enabled fundus cameras, I will not cover. They are trying to make it more and more user-friendly. We just saw this fundus camera in the DTECCON, which was held in Delhi last month. And it is very user-friendly. So you just need to, patient just has to stand there, and with a click, it will capture the fundus the photographs. Then Shockwave is now being tried for treatment of erectile dysfunction. The results are around, excuse me, noise. Shockwave has been tried for treatment of ED, and it is working. Results are not very good. It's a very expensive therapy, and around 50% results are there. So that's the future. Probably we can have that as option for treating ED. Then platelet-derived growth factors are also being tried for treatment of erectile dysfunction. Then for prevention of diabetic foot ulcers, there are custom sensory insoles which have been developed. So these insoles basically monitor the pressure points, the step count, the hours of usage, and temperature of the feet of the patient. They transmit the data to the smartphone, and if required, it can go to the healthcare provider. The healthcare provider can check if the patient is having some pressure points. Then the advice can be given to the patient. And they have even done some studies on this, and they have seen that by using these insoles, the risk of ulcerations can be brought down by 71%, and even more to 86% if the patient is using it for more than 4.5 hours a day. Then there are smart socks also, which are being developed for the usage of diabetic patients. And these socks also monitor the temperature. They also transmit the data to the nurses and the healthcare providers. Then these are the AI-based multispectral wound imaging cameras. The cameras are useful for starting the antibiotic therapy. So you just take the picture of the wound, and the camera will tell the infection whether it's gram-positive or gram-negative. And it's around 95% times it's correct. So you don't need to empirically start a treatment. You can start the treatment by using this camera. Then these are some less invasive CGM devices in which there are micro needles. So it is not a big needle that goes into subcutaneous space. It remains in the dermis, and it can still monitor the blood glucose levels. Then non-invasive glucose monitoring is an area where a lot of efforts are being done. Different technologies are being used. One of them is radio frequency sensing, and they have just published a paper in which they say that this technology is totally non-invasive and is very good compared to the gold standard of blood sugar measurement. Then there are some watches, just 2 minutes more, sir. There are some non-invasive watches. So this is a K-watch. There is a sensor that has to be changed every week, and the watch will record the blood sugar levels of the patient non-invasively in real time. Then there are several other models of non-invasive glucose monitoring. This is a non-invasive continuous glucose monitoring system, which is being developed by SugarBeat. And this is a very interesting device, a POC device, which is connected to the smartphone, and it can measure multiple parameters like HbA1c, lipid profile, hemoglobin, creatinine, and so on. And this has been recently purchased by Siemens Healthcare. So we can probably see some POC devices which are so small and can be used in the labs. This is a skin patch being developed by some students at the University of California, and they claim that this simple patch, which is very small in size, can measure the blood pressure, the blood sugar, and so many different parameters of the patient. Then continuous metabolic monitoring is a new concept now. This is again an implantable device which stays beneath the skin, and it will record multiple parameters in addition to glucose. Then this is a smart artificial pancreas in which this particular part, the blue part, it remains in the peritoneal cavity. The blue part is the glucose sensor, and you can refill the insulin from that part which remains outside the abdomen, and this blue part acts as a sensor. So insulin will be released only when glucose levels are high, otherwise it will not be released. Then this is a bio-artificial pancreas, which is basically a system to prolong the life of islet cells. You will not require a lot of islet cells for transplanting in these patients. Then smart insulin patches are being developed. These are the micro patches, and they remain in the, they are just put on the skin, and again they are sensitive to glucose. Insulin is released only when glucose levels go high. Then 4D bioprinting is tried for diabetic foot ulcers. The patient's own autologous adipose tissue is taken. It is harvested in the petri dish outside. The tissue is regenerated, and the 4D image of the wound is taken, and the tissue is grown so as to fit in the ulcer, and then that is being used now. Then immunotherapy, I'll not go into details because we know that recently teplizumab has been shown and approved to prevent the development of type 1 diabetes. Then there are so many other candidates in the field of immunotherapy in different stages of development. I'll just skip the slides. Then there is one more effort being done for endoscopic glycemic management. So they just do some interventions endoscopically in the duodenal mucosa, submucosa, and they claim to achieve the reversal of diabetes. Then, as I said earlier, adipose tissue is being tried as a target for treatment of metabolic disorders, and they are developing some techniques for inducing browning of adipose tissue. So in the adults, there is a lot of white adipose tissue. Efforts are on to induce browning of that fat tissue so that the metabolic health of the patient can be improved. I'll just skip this. Very interesting. There are non-invasive technologies. By stimulating the brainstem, you can achieve the reversal of some of the metabolic disorders. Stem cell therapy, as I said, there are still trials which are happening, and they are getting some results. And these are different startups or the different companies which are working still in the area of stem cell therapy. These are different candidates and different stages of development. And one company is working on making it a scalable solution to make it more cost effective. So, and at last, artificial intelligence, as of now, I don't know, many of you may not have tried it, but must have heard the name of ChatGPT. My last slide. So the ChatGPT can write a research paper for you. I just gave the demo to Dr. Aravind Gupta. We were traveling together, and I said that आप just topic बताइए, and it will give you a write-up of 1,000 words instantly. It can review. So if you have he just said that, Dr. Rakesh, I have to read an article of 65 pages and review it. So the AI actually, you just upload the article, it will summarize it and give you the summary of that. It can make diagrams for you. It can create images as per your imagination. And it can also work as a chatbot. So it can work as a chatbot for your patients. It will automatically reply to your patients. And there are so many other things which are there in the field of artificial intelligence beyond the coverage of this talk. But when I'm asked to speak about the future of artificial intelligence, I just start thinking whether I should talk on future of artificial intelligence or future of humans. Because our future is at stake once they come into picture. And I think that soon these AIs will probably replace most of the people like us. Before coming to this talk, I just asked a question to the AI. What are the job profiles which will not be affected by AI in future? It gave me 4 or 5 options. Either become an artist, or a teacher, or a nurse, or a truck driver, or a construction worker. So these are the options which we have in the future. Thank you.
Nice talk. Ended that long day with the question of the future on humans. So this was unexpected. So any questions or comments from the audience? Otherwise, we'll be concluding and handing over the mic to Dr. Aravind.
Thank you very much for that informative session, sir. I request Dr. Aravind Jagdish and the chairperson to felicitate the speaker.
Thank you, Dr. Aravind, for having given us the opportunity to be on the stage. Thank you.
I request Dr. Aravind Jagdish to present the mementos to the chairperson. Thank you for your valuable time, sir. Shall we all applaud for him? Thank you, sir. We have now come to the end of our day one program. I personally thank each and every delegate and faculty members of today's session who put in a lot of effort, knowledge, viewpoints, and the elegance in explaining numerous topics to us. To sum it up, it was a beautiful scientific extravaganza. Last but not the least, we have our one-man army, the man behind the success of this summit, Dr. Aravinda Jagadish. Thank you for this wonderful opportunity, sir, and a hearty congratulations to you on this successful event despite the oath-taking ceremony which is happening right next door. Well, there's a wonderful gala dinner arranged for all the delegates and the faculty. Please enjoy the party and dinner. Thank you all. Have a good night. See you all tomorrow. Please come tomorrow without fail. The program starts exactly at 9 a.m. and there are many important topics to be covered. Thank you one and all. Have a good night.